endocrine embryology, thyroid development. Diverticulum arises from floor of primitive pharynx and descends into neck. Right, so that's this thing from here to here. Connected to the tongue by a thyroglossal duct, which normally disappears but may persist as cysts, or the pyramidal lobe of thyroid. Foramen cecum is normal remnant of thyroglossal duct. Okay, so it normally in a person you'll find this foramen cecum, which is a remnant of thyroglossal duct. Okay, this is the thyroglossal duct right here. This little thing, tube. Okay, a most common ectopic thyroid tissue site is the tongue, lingual thyroid. Removal may result in hypothyroidism if it is the only thyroid tissue present. Right, so since this is usually the ectopic site for thyroid over here. If you remove the thyroid and you remove this, or maybe there is no thyroid and it's over here, and you remove the cyst from here, you can suffer from hypothyroidism. Okay, that's the hyoid bone, that's the thyrohyoid membrane. This is thyroglossal duct, thyroid cartilage, thyroid, and trachea. Similarly, you should know this side as well. This is hyoid bone, thyroglossal duct, thyroid, internal and external carotid arteries, superior thyroid artery, inferior thyroid artery, thyroglossal trunk, and left subclavian artery. Okay. So, thyroglossal duct cyst, that's this thing right here, may present as an interior midline neck mass that moves with swallowing or protrusion of the tongue. Okay, versus persistent cervical sinus leading to pharyngeal cleft cyst in the lateral neck. Okay. The most important thing here is that if the cyst is moving while swallowing, it's going to be thyroglossal duct cyst. If it's not moving while swallowing or protrusion of tongue, with protrusion of trunk, it's going to be your persistent cervical sinus. And that's the only way you can differentiate between the two. Thyroid follicle cells derived from endoderm, okay, and parafollicular cells arise from the fourth pharyngeal pouch. Cool. So endocrine, now we're on to anatomy. Pituitary gland, it has two parts. Okay, let me just show you what that looks like. Okay, so this thing right here, so that would be your anterior, and that would be your posterior pituitary. So anterior is known as okay, I did that backward then. This is the neurohypophysis, so that would be the anterior. Why is this backwards? This one's better. We can go to Bing. So that's what it is. As hypothalamus coming, the secretions coming from there and storing over here in the posterior lobe, and this is the anterior lobe, right? Anterior lobe is the side that has optic chiasm. Okay, the stalk, the posterior lobe, and the median eminence. Okay, so anterior pituitary or adenohypophysis, and then you have posterior pituitary, that's called the neurohypophysis. So you can remember that anterior has A, adenohypophysis has A, okay, and the posterior neurohypophysis. Okay. So anterior pituitary, what does it secrete? It secretes almost everything other than oxytocin and ADH. Okay. So it secretes FSH, LH, ACTH, TSH, prolactin, growth hormone, and endorphins. Then it also has melanotropins, which is MSH, secreted from intermediate lobe of the pituitary. It's derived from the oral ectoderm or Rathke's pouch. Okay. Uh, Alpha subunit, hormone subunit, common in TSH, LH, FSH, and human chorionic gonadotropin. Beta subunits are determined hormone specificity. Okay. Okay. So here, propiomelanocorticoid, cordon derivatives. So beta endorphin, ACTH, and MSH. Okay. This is the reason when you have increased amount of this uh, in Cushing's, uh, you also get pigmentation. It's because of the melanotropins also being the same structure or beta subunit as well. Uh, so you'll have endorphins and MSH coming out as well as ACTH because they are all coming from the intermediate lobe. Okay. Uh, then yeah, so it's important to know that this is the reason why you have pigmentation in Cushing's. So go pro with the ban. Then these don't really help. Just know that anything other than this oxytocin and vasopressin are going to be from posterior, and all the other ones are from here. Okay. So FSH, LH, ACTH, TSH, PRL, that's prolactin and growth hormone, and then you have basophils, that's your FSH, LH, ACTH, and TSH, and acidophils are prolactin and growth hormone. Okay. It helps over here as well, so let's do that. To see this while we're doing this. So when you're doing acidophils, that's your prolactin and growth hormone, the ones in pink, and the basophils are these ACTH, LH, FSH, and TSH. Okay. So posterior pituitary, it stores and releases vasopressin. Vasopressin, also called antidiuretic hormone or ADH, and oxytocin, both made in hypothalamus. Okay. So it's actually made up here, up there. That's where the hypothalamus is. This thing right here, and then after it's made from here, it's goes down here through supraoptic and paraventricular nuclei. That's where it's made, and then it's transported through neurophysis. Okay. So in thalamus, it's made in supraoptic and paraventricular nuclei, and then it transported to posterior pituitary via neurohypophysis, via carrier proteins. Okay, it's derived from neuroectoderm. Okay, so it's important to know that it's not made in the pituitary lobe, oxytocin and ADH. It's actually made in hypothalamus. It's only stored here, and then it's released as needed. Yeah, so we'll do this when we get there. And then we have adrenal cortex and medulla. This is GFR. The deeper you go, the sweeter it gets, kind of thing. So adrenal cortex derived from mesoderm, and medulla derived from neurocrest. Okay. Anatomy is adrenal glands. So this is the cortex. Okay. The cortex is this pink stuff right here. So don't confuse that with the medulla. That's the blue one. Because the medulla is where you get epinephrine and norepinephrine made, the catecholamines, and this is where you get the aldosterone and cortisols and the sex hormones from the cortex. Okay, and this is superior surface of the kidney, obviously. So histology. In cortex we have GFR, so we need to know how to differentiate the layers of this. So let's look at that before we move on. So when you see it like this, you need to understand which layers are which. Okay, so this pink one is going to be your R. The middle layer is right here. It's all of this, and this is your upper layer. Okay, and this thing right here is your medulla. Okay, let's see if there's a labeled one. So capsule, cortex, and this is the medulla. Okay, and then you need to know how to differentiate between that as well. So this is the glomerulosa right there. This is the fasciculata, and this is the reticularis, and that's the medulla. Normally, when they give you a photo like this, they would tell you that there's a lesion over here or somewhere, or there's like a cyst or tumor or something like that, and then it's gonna be over here. But then you're gonna be like, okay, that looks like the middle layer. It's the medulla. Then it's not. Medulla starts way down here, and then there's like G is over here. So that's the top layer over there. So from that to that, you can tell the difference between this white area and this little pink area, right? And then over here, it's going this way. Instead of vertical lines, you're seeing the striations either this way or just like little blabs, right? So that's a different layer as well. Let's see if there's a different photo for this. Okay, so you can see the layer that's different over here. This is fasciculata. Okay, that's the middle layer. So G, F, and R is over here, and this is the medulla. Okay. So this is what it's gonna look like. It's gonna be a blue photo. That's the layers. Those are the layers. So this dark blue is the medulla. So between that and the upper, you gotta figure out which one's which. So when you see a lot of white stuff, that's gonna be your fasciculata. That's the middle layer. So anything above the white stuff is your glomerulosa, and then reticularis is under the white stuff, between the white stuff and the dark blue. So they're gonna tell you that, okay, so there's a problem here. So production of which hormone is gonna be affected? Then it's gonna be cortisol, right? Or it could be up here. Then it's gonna be aldosterone, or DHE over here, and then catecholamines down here. Okay. So zona glomerulosa is the top layer. So G, F is for zona fasciculata, that's over here, and R is for reticularis over here, and chromatin cells over here. Okay. So you have regulations by angiotensin. So okay, so GFR, you know this because of glomerulosa filtration rate, right, from the kidneys. It's not the same thing, so don't confuse the two. It's just that it's easier to remember this way. So top one is G, F, and then last inner layer is the R. So glomerulosa is regulated by angiotensin 2, and we'll go over this again down into the chapter. But just overall, angiotensin 2, and it makes mineralocorticoids, okay, and it has aldosterone that is produced. So this is how angiotensin makes aldosterone. Aldosterone does what? It reabsorbs sodium and excretes potassium. Then you have acetylcholine, ACTH, adrenocorticotropin hormone. Right? I don't want to mess that up. I should know this. Yeah, adrenocorticotropic hormone. So, or cortisol, right? So cortisol releasing hormone. That's what's gonna stimulate this part. So if these hormones come over here, what's it gonna make? It's gonna make cortisol, okay? And they're what class of hormones? They're glucocorticoids, or also known as your corticosteroids, okay? Zona reticularis, that's gonna make again, that's gonna be regulated by the same thing, ACTH and CRH, and it's gonna make your sex hormones. So that's dihydro something something something, but we call it DI anyways. So, but we'll look up the full form for that too. Dihydroepiandrosterone. androsterone. Okay. So GFR corresponds with salt, sugar, and sex. Okay. That should be clear now. So this is the salt. This is the sugar, because it's corticosteroid glucocorticoids, and then you have the sex hormones. So sex. Then we have apocrine pancreas cell types. So this is like a little section of the pancreas cell. Like, so what you're gonna see in it is islets of Langerhans are collections of alpha. Okay, alpha is for glucagon, so that's I remember that alpha glucagon, and it's gonna be on the periphery. Okay, like that. And then you have beta. Beta is gonna be your insulin. Okay, so that's your central, and that's over here. That's the majority of the cells right here, right, that you see. And then you have delta, I guess, endocrine cells. Okay, so that's gonna make somatostatin. That's the inhibitor, right? So it's like interspersed wherever it can find place. It's gonna be the one with the least amount of cells in the pancreas. Okay, so somatostatin cells. So islets arise from pancreatic buds. Okay, so alpha is glucagon. Remember that, it's important. And then you have beta for insulin, and then delta for somatostatin. Then you have, now we are on to physiology. Hypothalamic and pituitary hormones. Okay, so vasopressin, also known as antidiuretic hormone or ADH. So ADH hormone function and clinical notes. So function of ADH is it's in the name, right? So diuretic does what? It makes you pee out stuff, right? So anti-diuretic is going to do what? It's going to stop you from releasing all that water. So antidiuretic hormone does what? Increases water permeability of the distal convoluted tubule. So just for that, let's just keep that out over here. Okay. Okay. So distal is right there before it goes into the collecting tubule, and right after the thick ascending tubule, right? So right in this area is where it acts, ADH. Okay, so increases, it actually acts over here too, but it increases water permeability of distal convoluted tubule and collecting ducts. Okay, this is where it acts on principal cells to increase the aquaporins and stuff. It's either a principal or the chief cells, I don't remember. We'll do that in renal. But it increases permeability of distal convoluted tubule and collecting duct cells in kidney to increase water reabsorption. Okay. Clinical notes: stimulus for secretion is increase in plasma osmolality. Okay, so that's an important one. That just means the concentration inside of your body or your plasma. If there's decrease in sodium or increase in sodium, that's what's going to regulate your ADH. Okay, because sodium is what determines the osmolality of your plasma. Except for, we're on the physiology part of your endocrine, so that's 334. Okay. Okay, so stimulus for secretion is increase in plasma osmolality except in syndrome of inappropriate ADH secretion, that is SIAD. Okay, in which ADH is elevated despite decreased plasma osmolality. So SIAD is basically, say you have increase in sodium in your body. So what's going to happen is ADH is not going to be released, right? It's going to be prevented. But then if you have decreased amount of sodium, it's gonna be detected in your renal tubules that there's less amount of sodium coming through. So then ADH kicks in, and then after that, it's gonna reabsorb as much of sodium as it can. Because wherever sodium goes, water follows, and that's like the mantra for your body. Wherever sodium goes, water follows. So if sodium is leaking, then water is gonna leak out. If sodium is uh, yeah, so that's basically it actually. So if you're having like salty food, you're gonna swell up. That's why you swell up, because it's retaining water in those areas. Okay. And what Cialis is, just it doesn't matter what this, if there is a sodium or not. It's just gonna keep reabsorbing sodium, even though you don't need it. And this is usually because of a tumor or trauma or some kind of accident, or in the head. Okay. We'll talk about that too. Okay, so now you know what ADH does. Now we are on cortisol releasing hormone. Okay, so, or corticotropin. Now I'm confused. Hold on. It's corticotropin releasing hormone. Okay. So corticotropin releasing hormone (CRH) is increase in adrenocorticotropin hormone, or ACTH, and then you have melanotropins, so uh, stimulating hormones, so MSH, and then you have beta endorphins. All of these get released when you have CRH coming in to your pituitary, in the anterior pituitary. So decrease in chronic glucocorticoid steroid use. Okay, that's when this increases basically. Wait, no, it's saying when you have exogenous corticosteroids, right, or glucocorticoids, that's when these get decreased. Okay, why? Because now that your body is sensing, because there's a feedback loop, right? So if you have too much of these, this is gonna turn off, right? But now even though it's only chronic glucocorticoid, it's still, all of three of these still get turned off. Okay, it's not just that only this one will. So this is why it's dangerous to just stop steroids abruptly after having a chronic use or long-term use of steroids. Because what happens is the steroid will put an inhibition on CRH. So when you are inhibiting CRH, what happens to ACTH? Decreases. And then if this decreases, then what's going to happen? This thing is going to stop making more cortisol or glucocorticoids, right? So when something stops doing what it's meant to, it's just like a muscle. It's going to atrophy, right? So it's going to shrink. And once it shrinks, it can't function as at optimum level, right? So when you stop using exogenous or taking exogenous steroids, there's going to be a crisis, because then CRH is suddenly going to get increased, and it's going to increase, and the demand keeps increasing, and this is not going to keep up with the demand. So when this doesn't keep up with the demand, again, CRH keeps increasing and increasing. It's going to put more stress on your body because of that, and that's how people go into die basically. Okay, dopamine. So there's decreased prolactin and TSH, thyroid stimulating hormone. Okay, so that's its function. Dopamine inhibits prolactin, and it activates or stimulates thyroid stimulating hormone. That's how dopamine is connected to thyroid. Okay. Then, and also with prolactin. So there is like a question about a tumor in the middle of the place. So So there's a tumor over here, right? And dopamine comes from hypothalamus. Okay, we'll do that in neuro. That will come in neuro. Okay, so dopamine comes in over here, and then it actually goes here. So it goes here into the anterior pituitary, and then inhibits the prolactin, right? But say there's a tumor here, so now the neurophyzins or this whole pathway is going to be disturbed, right? So dopamine is not going to reach here. So what's going to happen? You're probably going to think that's going to be something from posterior pituitary, right? No, it's because of it's also in anterior, because dopamine also comes from hypothalamus. And since it was inhibiting prolactin, now that there is a tumor there, prolactin is not being inhibited, so now it's gonna have increase in prolactin. Okay, it's not gonna have an increase in anything else, but prolactin is the one that gets increased. Everything else get decreased. Okay, so it's also called prolactin inhibiting factor. Dopamine antagonists, for example, antipsychotics, can cause galactorrhea due to hyperprolactinemia, and this is also a reason because for guys to have gynecomastia, because that's what prolactin does in men, and also they might even start leaking milk out because they have oxytocin, they have prolactin, and everything that's needed for it. So it can happen in men too. It happens in women obviously, but also in men it can occur. So if there's a question about a man who's there's a white fluid coming out of the nipple, don't think about like some kind of pus or something, because in pus you will have like fever or neutrophils and all that, but this one's going to be negative for all that. But the discharge is whitish in color. It's going to be milk because that dude has prolactinoma. Okay. GHRH, that's growth hormone releasing hormone, increases growth hormone. Analog for growth hormone is tesamorelin. There's more in it, so gotta be more lin. Okay, used to treat HIV associated lipodystrophy. Then we have GnRH, increase in FSH and LH. This is an important one. We'll do this in repro as well. So it's suppressed by hyperprolactinemia. Actually, let's look at these. So while we're doing this. Okay. So CRH activates ACTH. We did that one. Dopamine inhibits prolactin. Okay, but it also inhibits TSH. Okay, and that's how that is connected to TSH. Okay, then we have GHRH. That's right here. Acidophil. It stimulates growth hormone. Okay. We have GnRH. That's right there. It activates FSH and LH. So suppressed by hyperprolactinemia. Right. So you can see this prolactin inhibiting GnRH over here. Tonic GnRH analog, for example, leuprolide. Okay. So that's the one we give in infertility and to stimulate puberty or something like that. So suppresses hypothalamic pituitary gonadal axis. Pulsatile GnRH leads to puberty and fertility. So when it's in pulsatile, it acts as a stimulator. This one. So you give it in a pump, right? So when it has that kind of effect, it has a beneficial effect for puberty and fertility. But when it's continuously given at the same level and not the pulsatile, it actually inhibits FSH and LH. Okay. We'll talk about that later as well. Then we have MSH, melanogenesis by melanocytes. Okay. It causes hyperpigmentation and Cushing's disease, as MSH and HCTH share the same precursor molecule, which is propionmelanocortin. Okay, so this, and also beta endorphin is also there. Oxytocin, it causes uterine contractions during labor, responsible for milk letdown reflex in response to suckling. It modulates fever, anxiety, social bonding, mood, and depression. We have prolactin, decrease in GnRH, stimulates lactogenesis, pituitary prolactinoma, amenorrhea, osteoporosis. So again, this thing, what it causes, right? So prolactin in men it causes gynecomastia, and female it causes amenorrhea. Okay. Uh, that's the primary thing that they'll give you, like the giveaway right here. That this person of reproductive, this woman of reproductive age, is experiencing amenorrhea, uh, right? And then you're gonna first thing you're gonna think of is prolactinoma. Okay. Osteoporosis, hypogonadism, and galactorrhea. Okay. Then you have breast feeding increases, which increases prolactin and decreases in GnRH. So then you get delayed postpartum ovulation, natural contraception. That's why you can not get pregnant within 6 months of delivery. Somatostatin, that's the inhibitor one. It inhibits everything. Okay, so it decreases growth hormone. It decreases TSH. Okay, so growth hormone is getting inhibited by somatostatin, TSH, and other stuff too in GIT. But we'll read that in GIT. So also called growth hormone inhibiting hormone, or GHIH, analog used to treat acromegaly. Okay, we should know what the analog is. It's octreotide. Let me just confirm that. So octreotide is a potent synthetic somatostatin. Okay, so you need to know octreotide for that. You need to know leuprolide for GnRH. Okay, and these are the important ones. All the other ones are there. You should know it, but you should definitely know these two. TRH, that's TSH, increase in TSH and prolactin. Increase in TRH, right? So thyroid releasing hormone. This comes from hypothalamus. So remember that. Don't confuse which one's coming from which. TRH comes from hypothalamus, goes to the thyroid, and that's where you goes to the anterior pituitary, the TSH, and then TSH goes to the thyroid and releases T3 and T4 from there. Sometimes when you have Graves, it gets released by itself, so then you won't have TRH releasing, but you still have a high number of T4 and T3. That's how you differentiate between the tumor of, or Graves, or a tumor of hypothalamus. So basically, if you have a, just a quick one, right? So if you have a tumor in hypothalamus, you will have increased amount of TRH, right? So then you'll have increased amount of TSH and increased amount of T3 and T4. Normally there's a feedback loop. So if you're seeing that there's a high levels of T3 and T4, that means the feedback loop is not working, or there's a tumor in TRH releasing this without the feedback, right? Then say what happens if you have a tumor in anterior pituitary, right? You're gonna have low TRH level, but then high TSH. That's why you have high levels of T3 and T4. So that's how you know that the tumor is in anterior pituitary. And then you have low levels of TRH and TSH, but high levels of T3 and T4. That means the antibodies against the against the thyroid follicles are causing the stimulation of T3 and T4, and that's what Graves' disease is. Okay, this is the one. Graves was the one where the follicles are stimulated instead of being inhibited by the antibodies or in immunity. We'll read about that as well. Okay, so TSH and TRH increases in TSH and prolactin. Increase in TRH, for example, in primary and secondary hypothyroidism, may increase prolactin secretion, and which causes galactorrhea. So that's how that's connected to that. So we'll read about all of these in detail now. Okay, starting with growth hormone. This is growth hormone releasing hormone coming from hypothalamus into the anterior pituitary, and then anterior pituitary secretes growth hormone, and then growth hormones goes and does its effect on the bone, livers, muscles, and fat tissues or adipose tissue. Or yeah. Okay. So what regulates GHRH? That's when you sleep, hypoglycemia, stress, puberty, and exercise, right? So all of these things are gonna cause release of this. So this is how you become, taller, I guess, because that's what increases the bone growth. But then if you also have aging or obesity or hyperglycemia, it's gonna inhibit this. Okay, so that's how you don't have these things, basically. So of course we know that somatostatin also inhibits everything. So growth hormone inhibits growth hormone. Right? Then we have anterior pituitary coming in with growth hormone. If you have a high level of growth hormone, it will send a negative feedback loop and inhibit the anterior pituitary as well as the GHRH as well. Okay. And then we have growth hormone going into the liver. The liver then releases IGF, and IGF is somatosmedin C. Okay. So also no, I think it's also called insulin-like growth factor. That's its name. Let's just check in case they give you a full form of this. Yeah, so insulin-like growth factor 1. That's what it's called. Okay. So insulin-like growth factor, and then what that does is it activates the amino acid uptake in the bones, protein synthesis, DNA and RNA synthesis, chondroitin, sulfate, collagen, and increase in cell size and number. It also activates the amino acid uptake in the muscles and increase in protein synthesis here as well. And it also goes over into the anterior pituitary to inhibit if there's increased levels of IGF or insulin-like growth factor, right? And IGF also inhibits the GHRH. So whatever is inhibiting this is going to inhibit both of these things. Besides somatostatin. Somatostatin only inhibits the anterior pituitary. And obviously those two. Okay. So basically it's just these two things. The growth hormone and the insulin-like growth factor. And growth hormone directly activates the glucose uptake and decrease in glucose uptake and increase in lipolysis for the adipose tissues. Okay. So this way you reduce fat, and this way your muscles don't use glucose for energy. Instead it uses fat for energy, so that's why there's increase in lipolysis. So let's read about that. Also called somatotropin, not to be confused with somatostatin. That's the opposite of this. Okay, so also called somatotropin. So statin is like stasis, right? So that's like stop, if you get confused between the two. So somatotropin, secreted by anterior pituitary, stimulates linear growth and muscle mass through IGF-1 or somatomedin C secretion by liver. Increase insulin resistance. So this is why it's called insulin-like growth factor, because it increases insulin resistance. How? Because in the body, when you have insulin-like peptide, your body is going to think that you have too much of insulin, so it's going to get sensitized to insulin, and that's how you get the insulin resistance. Diabetogenic, release in pulses in response to growth hormone releasing hormone. Secretion increased during sleep. hypoglycemia, stress, and puberty and exercise. Right there. That's why you have a linear growth or like growth spurt during puberty. Secretion decreases with aging, obesity, and hyperglycemia. Somatostatin and somatomedin, which is insulin growth factor. Uh, Regulatory molecules secreted by liver in response to growth hormone acting on the target tissues. This thing right here. Okay. Excess secretion of growth hormone, for example, pituitary adenoma, may cause acromegaly. Okay. This is the pathogenesis of acromegaly in adults or gigantism in children. Right. Pathogenesis for that. Pituitary adenoma. Okay. Then you had, so the treatment for that would be somatostatin analogs like octreotide, or surgery. Okay. Antidiuretic hormone, also called vasopressin, source is synthesized in hypothalamus. Okay, where supraoptic and paraventricular nuclei. Right, we already looked at that part. Let me just open that up again. Okay, we'll just go with this one. Okay, so hypothalamus, so neurosecretory cells producing, releasing, and okay, okay. So I was just trying to figure out which one's which, but out of them, supraoptic is the one on the top. I think that's how it is. And then paraventricular nuclei is the one at the bottom. So if you have a picture trying to figure out which one's which, the top one is going to be the supraoptic, and the bottom one is going to be the paraventricular nuclei. It's stored and secreted by posterior pituitary, right? We already talked about that. So that's optic chiasm. So that's the anterior pituitary, and then you have posterior over here. So here it only stores and secretes. It does not produce it. That's important differentiation you should know. That's the distinction that they're going to test you on. Function regulates blood pressure, right? So V1 in the vessels, and then you have V2 in the kidneys. So it regulates blood pressure via V1 receptor and serum osmolality via V2 receptors. Primary function is in serum osmolality regulation. So ADH decreases serum osmolality, right? If that doesn't make sense, just imagine you have a glass full of salt, right? So actually, let's make that this. So it's full of salt, okay? Shouldn't have picked blue. That looks like water. But it's full of salt, okay? And it doesn't have water. Right? So what does this mean in terms of, like, say if it's in plasma, you have a lot of salt. That's called increase in osmolality, right? So there is an increase in osmolality because this is the level of water and there's too much salt, okay? So how do you decrease the osmolality? You increase the water level, right? So when you have this much water, this gets diluted, right? And now you don't have that much concentrated sodium. So that is decrease in serum osmolality, okay? And that's how ADH works. It increases water and, decreases osmolality. So the function is serum osmolality. Regulation is regulation. So ADH decreases serum osmolality, increase in urine osmolality. Okay, what does that mean? So since it's a closed system, if you have body plasma and then whatever you pee out. Okay, so say you were before you're peeing out this much water, right? And that's why your water level was this low. But now that this is rising, that means you're gonna pee out less water, right? So you're gonna pee out this much water, but then in other, like the other place, you had more salt here, concentrated, but now you have more concentrated salt here, right? So that's why there's an increase in osmolality in the urine, but decrease in osmolality in the plasma. Okay, so that's what that means. ADH decrease in serum osmolality and increase in urine osmolality via regulation of aquaporin channel insertion in principal cells of renal collecting tubule. So remember the loop of Henle, right? It was like, so yeah, glomerulus over here, proximal tubule, descending, ascending, and then distal convoluted, and then you have collecting tubules here, right? Uh, Also, what you don't see is like the paraventricular stuff over here, right? The paraventricular capillary network or reticular network around here. Okay, that's the one that makes your EPO actually. So we'll talk about that in renal. But anyways, so this is the area of collecting tubule that has three types of cell. One is principal cell, one is chief, and then the other one is like just normal one, I guess. Uh, and I think one of the principal or the chief, it's probably the principal cell that has aquaporins. So aquaporin is pretty cool because it's the only place where the whole concept or the mantra that we follow, where sodium goes, water goes, right? That's the only place where it doesn't apply because aquaporins don't require sodium to pull in blood, pull in water. Okay, so it will pull in water without the use of sodium, and that's why aquaporin is cool. And aquaporin gets regulated by ADH. That's the cool thing about it. That's why it's important to have ADH and functioning aquaporins, because there are diseases where aquaporins, are, what do you say, they don't get regulated by ADH. They don't listen to it. Okay, but again, we'll talk about that later. But just understand the concept why ADH decreases serum osmolality, increases osmolality in urine. While regulation of aquaporin channels inserted in, oh, there you go, there it is. So principal cells of renal collecting duct. It's important to know that it's principal cells. It will come up. Okay, so ADH level is decrease in central diabetes insipidus. Okay. Normal or increase in nephrogenic diabetes insipidus. So what is diabetes insipidus? That's what I was just talking about. Okay, so over here, and I'll draw like a hypothalamus over here as well. That's hypothalamus, that's pituitary, and this is your renals. Okay, and let's pick a different color. I don't know why yellow, you can't see that. This color. So the diuretic hormone, it comes in right from the posterior pituitary, and then it acts on the cells over here in the principal cells, right? But say there's a problem anywhere here. So if antidiuretic hormone doesn't basically get released at all, what's gonna happen? There's no retaining of the water, right? So water keeps flowing through, and that's what diabetic insipidus is, right? Just increased amount of water leaking. Okay, now say, how do we check if it's this or not? We give desmopressin. Desmopressin is a analog for that, right? It only works if it's central DI. Okay, central DI is central because it's coming from the brain. So if ADH is not coming and acting over here, that's called central DI. So we give desmopressin, that's ADH analog. So desmopressin is going to come and act over here on the principal cell, and then it's going to start retaining water, and the osmolality decreases in the plasma now because of this, and increases in the urine. That's what we check for actually, not the plasma, but we check the urine osmolality. So if there's decrease in urine osmolarity, that's how we know that it's central DI. But now say that doesn't happen even when you give it, right? When you give desmopressin, but the osmolarity of the urine does not change. What does that mean? That means that central is working good. It is releasing ADH, but what's happening is that this one is not listening to it. How do we know? Because we gave desmopressin and we followed it for like 4 to 6 hours, and the urine osmolarity didn't change. So then we know that it's nephrogenic DI and not the central DI. Okay, that's just a quick little thing. We'll talk about it more. ADH level is decreased in central diabetes insipidus, normal or hold on. Okay. So ADH level is decreased in diabetes insipidus, normal or increase in nephrogenic DI. Nephrogenic DI can be caused by mutation in V2 receptors. Okay, so that's what we talked about, the V2 receptor in the renals. It doesn't listen to ADH. So nephrogenic DI can be caused by mutations in V2 receptor. Desmopressin, ADH analog, is a treatment for central DI, because again, it's because this one is not releasing ADH. And so when we give desmopressin, V2 receptors listen to desmopressin, and that's how we know that it's central diabetes insipidus and not nephrogenic. Okay, so desmopressin ADH analog is a treatment for central DI and nocturnal enuresis. Vasopressin is also a potent vasopressor that can be used to increase organ perfusion and septic shock. Okay, vasopressin is a potent vasopressor, right? So that's vasoconstrictor. Okay, that's what it means, and it acts through V1 receptors. Okay, so is also a potent vasopressor that can be used to increase organ perfusion in septic shock. Okay, so how do you remember that? That vasopressin is a vasoconstrictor. It presses the vessels together, right? So it's in the name. Vasopressin is it presses the vessels together, so it causes vasoconstriction like that. Cool. Let's finish this one. Prolactin, source secreted mainly by anterior pituitary, stimulates milk production in breasts, inhibits ovulation in females and spermatogenesis in males by inhibiting GnRH synthesis. Okay, so we have over here. Let's see if this is what they're talking about, or let's read through it and then I'll just go over the notes. So stimulates milk production in breast, inhibits ovulation in females and spermatogenesis in males by inhibiting GnRH synthesis and release. Okay. Excessive amount of prolactin associated with decrease in libido, the source, and structurally homologous to growth hormone. Not important, but this is excessive amount of prolactin associated with decrease in libido, because they'll tell you this can come in question stem, this can come in as question stem, or even this as well, right? So inhibition of ovulation or spermatogenesis. So regulation, prolactin secretion from anterior pituitary is tonically inhibited by dopamine from tuberoinfundibular pathway of the hypothalamus. This is the neurohypophysin pathway as well, tuberoinfundibular pathway. This pathway is what supraoptic and paraventricular uses as well. Is the same one. So prolactin is prolactin in turn inhibits its own secretion by increasing dopamine synthesis and secretion from hypothalamus. TRH increases prolactin secretion, for example, in primary or secondary hypothyroidism. Okay, we already looked at that. How thyroid is connected to this. We'll talk about that. Dopamine has stronger effect on prolactin regulation than TRH does. Okay, is there a photo for that? They used to have a good photo for this in the old book. We'll look into that on that. So dopamine has stronger effect on prolactin regulation than TRH does. Dopamine agonists, for example, bromocriptine and carbocholine, inhibit prolactin secretion and can be used in treatment of prolactinoma. dopamine antagonists, for example, most antipsychotics and metoclopramide. This is what we use to treat antipsychotics, right? We give dopamine antagonists, and I mean psychotics, sorry, not antipsychotics. And estrogen, for example, OCPs, pregnancy, stimulates prolactin secretion. Okay, let me see if there's a thing for that. Okay, no. So let's look at this thing. Stimuli, hypothalamus, anterior pituitary, and peripheral action. So here you have medications, chest wall injury via auto ENS, nipple stimulation, or slide cry of the baby. All of these things will inhibit dopamine, okay? Because you can, if there's a crying of baby, your mother's not going to be happy, so it suppresses dopamine, right? Nipple stimulation also suppresses that. Chest wall injury, again, you're not happy about that, so dopamine suppressed. And medication, you're not happy about that, suppresses dopamine. Then if dopamine is inhibited, then dopamine also, you know, inhibits. It normally inhibits prolactin, right? So it's not going to be inhibited anymore. Okay, so if dopamine is not going to be inhibited anymore, you don't, if you're going to look at this, you can't look at this. That's why it's saying that normal function of dopamine is to inhibit prolactin. But now if this thing is inhibiting dopamine, then it disinhibits dopamine, right? So now the prolactin is going to be activated. So normally what prolactin does is it inhibits GnRH, and what GnRH normally does is it inhibits ovulation and spermatogenesis, right? So in primary hypothyroidism, what's going to happen is it's going to activate TRH, right? That's the tumor of hypothalamus kind of thing, right? So not the tumor, sorry. It's just the feedback loop that there is not enough T3 or T4, so that's why it's gonna, come back and like make more. So TRH gets stimulated. TRH will increase, and then that's gonna stimulate prolactin. Prolactin stimulates milk production, okay, as well. So in hypothyroidism, you can see increased amount of breast milk, I guess, but I don't think they test you on that. And then in pregnancy, estrogen also activates prolactin as well. Okay, it's important to this concept right here. Dopamine inhibits prolactin, so if dopamine is inhibited, prolactin then goes on and stimulates. In males it will make gynecomastia, in females it can inhibit ovulation, and males spermatogenesis inhibited. Okay, that's the only important thing out of all this. Just understand that concept. Thyroid, we have four. We went through that. We went through this. We are on thyroid, right? Before we move on, I have a few notes. So let's, for the growth hormone is pulsatile, right? So this is how it goes up and down, up and down, up and down, up and down, right? So when you're looking for pathology like some kind of tumor or something, for growth hormone, it has a up and down phase to it. So while it's on the peak, you can detect it, right? Because there are going to be high levels. But when it's down, you can't really detect growth hormone during that time, right? So when it's down, you can't detect it, but you can detect it while it's peaking. Not down, but when it's peaking, right? So growth hormone is pulsatile. So to diagnose pathology of growth hormone and not miss the growth hormone detection during downward peak, we check for IGF-1, which is insulin-like growth factor, right? released from the liver right there, right? So that's the one we check for pathology of growth hormone. We do not check growth hormone. Okay, that's important to know. There's a question about that. This is the diagram I was talking about from the previous FA. So we have slight cry of the baby or whatever. It's gonna stimulate the higher cortical centers, which inhibit dopamine, but it actually has a positive effect on the TRH, right? So not that it has a positive effect on it, it's just that TRH comes from here, hypothalamus, and dopamine comes from hypothalamus as well, okay, which is in pink. Dopamine inhibits anterior pituitary prolactin release, whereas TRH stimulates the release of prolactin, right, in the anterior pituitary. The TRH is act or stimulated in primary and secondary hypothyroidism, because hypothyroidism is lower levels of T3 and T4, so the body's like, yo, we need more, so send more help. So then this is the first signal for that, right? In dopamine, it inhibits this. It goes through the tuberoinfundibular pathway, right? Medication, chest wall injury, nipple stimulation, all of these will, make you sad. So it's going to inhibit dopamine. So when dopamine is inhibited, prolactin is uh, disinhibited, right? So what does prolactin do? It, milk production. Um, Also, reduction in prolactin elimination will cause, like for example, renal failure will cause increase in prolactin as well, right? So that will cause, prolactin stimulates, uh, basically it inhibits itself. So how does it do that? By stimulating secretion of dopamine, because dopamine is the inhibitor for prolactin, right? So that way. Prolactin also inhibits GnRH, which is known to stimulate FSH and LH. Both of these are required for ovulation and spermatogenesis. So this is why you have in prolactinoma, where there's increased amount of prolactin causing amenorrhea. Okay. Also, it's known to cause gynecomastia in men. During pregnancy, estrogen causes increased amount of prolactin as well. Okay, done with that. Okay, this is for thyroid. We need to do thyroid for that. This is insulin. Okay, that's it for now. So thyroid hormones. Let's look at this. Before we read about it, let's look at the diagram. So you have hypothalamus, right? Hypothalamus releases TRH, and that's thyroid releasing hormone. This goes to anterior pituitary, causing stimulation and release of TSH, production and release of TSH from anterior pituitary. Then TSH goes to the thyroid, and that's where thyroid follicle cells are, stimulated to produce and release T3 and T4. So T3 and T4 then goes to the effector organs. T3 and T4 negatively inhibits its own production. So if there's enough levels, it's going to tell the brain, yo, we good, right? So then it's going to inhibit the hypothalamus. It also inhibits anterior pituitary, tells the president and the vice president, yo, we good, right? So then it'll inhibit the release of TSH as well. Now, notice how there's TSI here, okay? That's thyroid stimulating immunoglobulin. That's what I was talking about when I was talking about the antibodies. This is going to be in Graves' disease. We'll talk about it there. But what's going to happen is T3 and T4 gets released, and there are high levels of these, right? So it's going to inhibit TRH and TSH, right? But there's still increased amount of T3 and T4. That's how we know, because of this whole diagram, that thyroid stimulating immunoglobulins are activating thyroid follicle cells, and that's why we are having high levels of T3, T4, causing hyperthyroidism. Okay, so how is T3 and T4 made? It's actually made by thyroglobulin. Okay, in the follicular cells, thyroglobulin then comes and attaches to iodine 2 via oxidation and then organification, and this then causes mono and di IT. So that's this thing right here, diiodotyrosine and monoiodotyrosine. Okay, when you have that, for oxidation and organification, you need thyroid peroxidase. Okay, that's important, and then you also need it for coupling reaction. So all three of these things, oxidation, organification, and coupling reaction, you need thyroid peroxidase, and this is important, right? So most of the drugs that we use for thyroid, uh, this is where they interact with. They interact with thyroid peroxidase. Okay, so then with coupling reaction, you get MIT, DT, or T3, T4. Then you get, endocytosis into the thyroid follicular epithelial cells from the follicle itself. Then in there, you have protease. So what does protease do? It cleaves, right? So it's gonna cleave it, and then it's gonna make it go out here, and also recycle a little bit. So MIT and DIT are gonna get recycled, while T3 and T4 get released into the blood. Okay, so when it's recycled, you need deiodinase. So again, A's, so that's gonna cleave it. So it cleaves it into either thyroglobulin, right? So there's TG, right? Because T3, T4 are detached and then they go outside. What's still attached? TG, thyroglobulin, and MIT and DIT. So you need the cleavage of those two. So deiodinase is the one that cleaves the two. So then thyroglobulin goes here, and then you have, MIT and DIT, via they also get split up into individual iodines, and then they go here to become oxidized into I2, and then combine with TG as well. Okay, that's the whole thing. For this, and here after it's in the blood, T3 and T4. T4 is in more amounts and higher levels than T3. Okay, and go in circulation, and then in the peripheral tissue, when it's taken up, T3 or T4. For T4 to become T3, it needs 5-deiodinase, and then, or just T3 by itself, downstream thyroid function. Okay, so now that's done, let's take this photo. I'll read about it. Okay, thyroid hormones. Thyroid produces triiodothyronine and thyroxine, iodine-containing hormones that control the body's metabolic rate. Hold on, just looking at things. Give me a sec. Okay, cool. So, thing about tyrosine, you need to know, it crosses placenta and congenital hypothyroidism. Okay, that's the only major thing you need to know until now. Source. So follicles of thyroid. 5-deiodinase converts T4. That's this part right here. T4, the major thyroid product, to T3 in peripheral tissue. Important. It's only in peripheral tissue, right? So 5, 4, and 3. So 5 converts 4 into 3. Peripheral conversion is inhibited by glucocorticoids. This thing right here. So peripheral conversion from T4 to T3. It's inhibited by glucocorticoids, beta blockers, and propyltyrosine. thiouracil or PTU. Okay, so they only wrote PTU here, but it's going to be PTU, beta blockers, and glucocorticoids. This is important because in some cases you'll have high level of T4 and low level of T3 in a question stem, and you have to figure out that this person is like suffering from a heart disease, some kind of cardiomyopathy, and they require beta blockers. And beta blocker does what? It inhibits 5-deiodinase. Okay, or even like if they have like steroids, they're long-term steroid users or something. So you need to know that these things inhibit conversions of T4 to T3. You also have reverse T3 or RT3, which is metabolically inactive, so it's useless. Okay, byproduct of the peripheral conversion of T4, and its production is increased by growth hormone and glucocorticoids. Okay, so they don't have reverse T3 here, so what we can do is like just draw one right there. Let's make it gray. So over here to here, it produces RT3. Okay, so while it's making T3, it can also make this, and that's what that is. Okay, so reverse T3 is a metabolically inactive product of peripheral conversion of T4, and its production is increased by growth hormone, so you can have like a plus sign there, and glucocorticoids. While it's inhibiting making of active T3, glucocorticoids is increasing the amount of reverse T3. Right. Function of thyroid peroxidase include oxidation, organification, and organification of iodine, so that's I2. So oxidation and organification of iodine into this thyroglobulin. Okay, so include oxidation, organification of iodine, and coupling of monoiodotyrosine, MIT, or diiodotyrosine, DIT. So you can just think of it like DIT makes T4, or because it's 2 and 2 makes 4, or 1 MIT and 1 DIT is going to make 3, right? Because 1 plus 2 is 3. So it's inhibited by PTU and methimazole. Okay, it's right there. PTU and methimazole is going to inhibit thyroid peroxidase. And DIT plus DIT is equal to T4. DIT plus MIT equals T3. And then there's also something called the Wolff-Chaikoff effect. This is an important effect. We actually use this effect to our benefit. How? It's protective autoregulation. Okay, sudden exposure to excess iodine temporarily turns off thyroid peroxidase. Okay, decrease in T3 and T4 production. So when you have too much iodine in your body, what happens is this effect takes place, which is temporarily turning off the thyroid peroxidases. It inactivates it or inhibits it, right? So you have PTU, methimazole, and also the Wolff-Chaikoff effect, both inhibiting this. Why? It's protection, because the more iodine have, the more T3, T4 you would have, and then you would go into hyperthyroid crisis, right? Or thyroid storm or something. But to prevent that, we have this effect. So when there's too much iodine, these two things get inhibited, so it protects your body from thyroid storm. Function: only free hormone is active. Okay, T3 binds a nuclear receptor with greater affinity than T4. So T3 is the one that actually does the thing, and not T4, which is why we give the inactivated form, or the less active form, levothyroxine, as a treatment for hypothyroidism, right? Because then T4 gets converted perfectly if needed, and when needed, and where needed. We don't usually give T3 right away. So T3 functions in 7Bs, and these are important to know. What does thyroid do basically? So thyroid is needed for brain maturation. Uh, you need it for bone growth, so synergism with growth hormone. You need it for beta adrenergic effects, increase in B1 receptors in heart, so increase in, again, we know what B1 does, right? It increases heart rate, contractility, and renin, and all that stuff. So you need thyroid for increase in cardiac output, heart rate, stroke volume, and contractility. Beta blockers alleviate adrenergic symptoms in thyrotoxicosis. So if you have thyrotoxicosis, that's just increased levels of thyroid hormones, T3 and T4. If you give beta blockers, it's gonna, alleviate it or mask it. Basal metabolic rate increases via increase in sodium potassium pump, ATP is pump, increase in oxygen consumption, respiratory rate, and body temperature. You need it for blood sugar because it increases glycogenolysis, so that's breakdown of glycogen, and you need it and via gluconeogenesis, that's making more glucose. Breakdown in lipids, okay, increase in lipolysis as well, and that's why most of the people with hyperthyroidism, they have lower body weight, right? Stimulates surfactant synthesis in babies. That's important too. So you need to know all of these, or at least if you think about thyroid, it's going to be about BMI and brain maturation, growth, lipid breakdown, blood sugar increase, and all that stuff. Okay. Then you have regulation. So how is it regulated? So thyroid releasing hormone gets stimulated, right? So positive TSH release, so it stimulates TSH from pituitary gland. Then that will go to the thyroid follicles and stimulate the follicular cells. Thyroid stimulating immunoglobulin, TSI, may stimulate follicular cells in Graves' disease. Okay. Negative feedback primarily by free T3 and T4. Anterior pituitary. So negative feedback from T3, T4 in the anterior pituitary will decrease the sensitivity to TRH, and in hypothalamus it will decrease the TRH secretion. Okay, it doesn't affect the secretion or anything, it affects the sensitivity to TRH. Okay, in anterior pituitary, but in hypothalamus it decreases the TRH secretion. Thyroxine binding globulin, TBG, binds most T3, T4 in blood. Bound T3, T4 equals inactive. So again, active ones are the ones that are free, right? It was somewhere here. Only free hormone is active. So while it's bound to, some kind of protein or globulin or something. So thyroxine binding globulin, that's TBG, it binds most of T3 and T4. That's not going to be active then. So bound T3, T4 is inactive. Increase in thyroid binding globulin in pregnancy. So this is also the reason you would have postpartum thyroidism of some kind. It could be hyper or hypo. So that's how pregnancy affects thyroid. OCP use, estrogen, increases in thyroxine binding globulin. It also increases total T3 and T4 as well. Decrease in thyroid binding globulin in steroid use, or also nephrotic syndrome. That's increase in albuminuria as well, right? So you pee out the proteins. T3, T4 are the only lipophilic hormones with charged amino acids and require specific transporters to diffuse into cell, facilitate diffusion. Okay, they are lipophilic hormones, and this is important reason. I already went over the thing in biochem, but why is this important that it's lipophilic? That means it can go through the cell membrane and it can go through nuclear membrane and attach directly onto the DNA to affect the transcription process. Okay, there are not that many things that can do that. It was thyroid. It was what was the other stuff? Steroids, thyroid, fat soluble vitamins, aldosterone, progesterone, and there was one more, estrogen, I think. So all of these things can go and attach directly on the zinc fingers and DNA. Okay. Okay. That about covers it. TPO is thyroglobulin iodinization. You need to know that. Iodotyrosin coupling. So TPO is iodotyrosin coupling. So T3 and T4, T3, T4 are lipophilic. Thyroxine crosses placenta in congenital hypothyroidism. You have increase in reverse T3 because of growth hormone or glucocorticoids, and you need to know that PTU, glucocorticoids, and beta blockers inhibit 5-deiodinase, PTU, and methimazole, and the Wolff-Chakoff effect due to excess iodine effects here. When you have radioactive iodine, what do? We actually affect this pump right here. Okay, the symporter. That's the one we try to inhibit, because that's where radioactive iodine comes in from. This symporter. It's important because both of those things are going in together. Because normally one thing goes in, the other one goes out. So when that doesn't happen, when both things go in, it's called a symport. And this is where radioactive iodine attaches. So this is where we, the drugs to prevent radioactive iodine damage are gonna be here. Okay, next, parathyroid hormone. Parathyroid hormone sources are chief cells of parathyroid. Okay, parathyroid is pretty important. So I'll just give you an overall of the thing that it does. What it does is it decreases the ionized calcium, increases phosphate, or it decreases. Sorry, no. That's not what PTH does. This is what regulates PTH. So if there is decrease in calcium, increase in phosphate, or decrease in vitamin D, active form, or calcitriol, all of these three things is going to activate PTH. So actual function of PTH is to increase calcium, decrease phosphate, and increase vitamin D active form. Okay. So when PTH is stimulated, it goes and attaches to the parafollicular cells. So parathyroid glands, the 4, and then PTH released into circulation. Then it goes into the renal tubules to make increase 125. That's the active form of vitamin D synthesis. What does vitamin D do? It causes reabsorption of calcium from the intestine. It actually also causes increased reabsorption of phosphate as well. Okay, from the intestine. However, from the renals, it increases only the calcium reabsorption, not the phosphate. It doesn't have phosphate action on the renals. So that's why in urine, when you check the urine that's pissed out, You won't notice any calcium there, but you'll notice the phosphates there. Okay, so this causes increase in serum calcium and decrease in serum phosphate, and this will then go ahead and inhibit the release of PTH then, because we have enough calcium now. Okay, and even in the renal tubules, the increase in vitamin D also inhibits PTH. Okay, so increase in vitamin D or calcium will inhibit PTH. Another thing it does is PTH released into circulation will go into the bone or the intestine, right? So that's where it is. So we have inactive form of vitamin D. Okay, so PTH causes stimulation of 1-alpha hydroxylase. This is the one that converts inactive vitamin D to active vitamin D, or calcidiol into calcitriol. Okay. Also, decrease in phosphate is going to cause vitamin D release as well, right? Or activation of vitamin D, because what does vitamin D do? It increases absorption of calcium and phosphate in the intestine, right? In the bone as well. It causes demineralization or reabsorption of the bone. These are the terminologies they use. Increase in calcium and increase in phosphate released from bone. So you have increased amount of calcium and phosphate at the end of that. Okay, that's the vitamin D activity as well. So you have to remember, vitamin D causes increase in reabsorption of calcium and phosphate from intestine and the bone. Okay, is the reason we have increased amount of calcium and decreased amount of phosphate in the serum is because of its action on the renals. It only reabsorbs calcium, but not the phosphate. Okay, so now let's read this. Parathyroid source. Chief cells of parathyroid increase in free calcium in the blood. That's the primary function of it. Okay. You have increased calcium and phosphate absorption in GI system from the intestine. Increase in calcium and phosphate from the bone, resorption. Okay. You have increase in calcium reabsorption from the distal convoluted tubule. You need to know that this happens in DCT, distal convoluted tubule. Remember, I drew the thing, the glomerulus, and then you have proximal, descending, ascending, and then it was the distal convoluted tubule, and then you had the collecting duct. So it's this area right here. Okay. Thiazides and all that stuff affect this area, the drugs for diuretics. Okay. Decrease in phosphate reabsorption, the proximal tubule, convoluted tubule. So that's this area right here in the loop of Henle. Then you have increase in active form of calcitriol. This also happens here. So active form of or calcitriol production by activating 1-alpha hydroxylase in proximal convoluted tubule. Try to make D3 in PCT. Okay. Now parathyroid hormone increases serum calcium, decrease in serum phosphate, increase in urine phosphate, and increase in urine CAMP. That's a new one that I didn't talk about. So it also increases urine CAMP. Okay. There's increase in rank L. That's a ligand, right? I'll talk about that more in detail during the musculo chapter. But normally you have this cell right here. It's called the osteoblast, and then you have another cell, osteoclast. So osteoclast is the one with the ligand. Okay, like that, and then that ligand attaches to this thing right here. Okay, and normally this thing has an osteoprotocrine, right, OPG, and then when this attaches to this, or not OPG that, but OPG is over here, I guess, or something. It's something like that. So when this attaches to this, this thing travels from here to this into the osteoclast, and then osteoclast activity increases. But to prevent this from happening, there is also another decoy for this. It's called osteoprotocrines. That thing attaches to this, So while this is attached to this receptor, this thing cannot end up over here, right? So then you have osteoblastic activity. Okay, so increase in rank L receptors, so increase in this, right? You have more of these, and say you have one of this, then this is going to competitively inhibit this, and there are chances that this will be attached to this, then this, right? So you have one of this over there. Okay, so increase in rank L, so receptor activator of NF-kB ligand secreted by osteoblast, this thing, and osteocytes bind rank receptors on osteoclast. I think I did backwards then. Maybe rank-L was on this and the receptors on this, and the rank-L is the one that causes release of this into this. It's one or the other. We'll figure it out in musculo, but this is overall the theory of that. So secreted by osteoblasts and osteoclast sites. Sorry. So osteoblast has B. So osteoblast does building activity. So it's known for, you know, mineralizing the bone or building the bone. Okay. Osteocytes are known for osteoclastic activity. C for clast or crushing the bone. So or demineralization of the bone or reabsorption of the bone. Okay. It makes the bone weaker. That's why C is for crush. Osteoclast or osteocytes. So it binds rank receptors on osteoclasts and their precursors to stimulate osteoclasts and increase calcium, because that's when you have osteoclastic activity, you release calcium and phosphate, right? So that's called bone resorption. Intermittent PTH release and also stimulate bone formation. Let me just confirm this so we don't mess it up. There are too many terms I don't want to bother with. So osteoblasts. Okay. So rank-L is on the osteoblasts and T cells. Okay. So I did the opposite. So this would be here, and instead of this, let me just bother for completeness sake. Like that. So this is going to come in and attach to this, and that's how this signal goes from here to here to increase osteoclastic activity. Okay. PTH is phosphate thrashing hormone, because it decreases phosphate, serum phosphate, right? PTH related peptide or PTHRP. This is an important peptide because it's the one that we detect for renal cell carcinoma and some other carcinomas. So PTH related peptide, PTHRP, functions like PTH and is commonly increased in malignancies, for example, squamous cell carcinoma of the lung, okay, and more commonly renal cell carcinoma. Regulation is decrease in serum calcium, which increases PTH secretion, increase in serum phosphate, which increases PTH secretion. Okay, decrease in magnesium also causes increase in PTH secretion. This is the one we don't normally talk about, but you should know that it's not just calcium and phosphate that affects it. It's also the magnesium, and magnesium is also in this area. So calcium and magnesium, I think, are the ones that transport freely because of the polarity of the osmosis of the water or whatever. Not osmosis, but like the gradient, basically. So what I mean by that is normally it's the sodium and potassium and all that are actively getting reabsorbed, right? So there's like a receptor here or a ATP pump there, ATP pump here. You'll have sodium going in or calcium going in or something like that, right? Like that going in. But for magnesium, it doesn't have a receptor or a channel. So magnesium actually goes through the little gaps right here. It doesn't go through, it goes through the gap because of the gradient that this creates. Okay, that's how those travel. It's magnesium. There's another one as well. I don't remember that. We'll do that in renal. But yeah, decrease in serum magnesium increases PTH secretion as well, and decrease in serum magnesium also causes decrease in PTH secretion. So how does that affect this magnesium? It's this formula right here. So when there's increased amount of calcium getting reabsorbed, it causes a positive gradient, so that makes magnesium come in as well. Like that. Okay. Common causes of decrease in magnesium include diarrhea, aminoglycosides, diuretics, alcohol use disorder. Okay. There was a note on this. Let's see what this is. Right, so if there's a parathyroid excision, causes hypocalcemia, which leads to circumoral numbness and finger numbness, right? Oh yeah, that's the buzzword for hypocalcemia. Okay, circumoral numbness and finger numbness. They usually just give you this, and from this you should know that there is decreased amount of calcium in the serum, because that's the only thing that's going to cause the circumoral numbness. Okay, thyroid cancer. Okay, so this is an important concept too. So thyroid cancer can lead to some same parathyroid. To say okay. So when you have thyroid cancer, what do? You cut out the thyroid, right? But these parathyroid glands are attached to it. So if you take away thyroid, you're also going to take away the parathyroid. So to avoid that, what they do is they save parathyroid by mincing it, and mincing it. That means cutting it, dissection like that. They cut it, and then they take that and attach it somewhere else on the body. Why somewhere else on the body? We'll talk about that. But so far, mince and deposit anywhere, usually deltoids, except for the neck. Okay, that's important. In case of return of the cancer, thyroid attached to the parathyroid, right? So easier to work on it if in the arm, than on the neck, right? Or on the area that's already operated on, like neck, which is healing and fibrosed. Okay, that's why. So since we minced this area and then attach it to the deltoid, there are chances that there were some thyroid cells, and those thyroid cells could have chances of having thyroid cancer cells, right? So in case you start getting increased amount of thyroid again, then it's easier to operate on your deltoid than the area that's already operated on, like the neck, right? Because it's already trying to heal, and then if you do more damage to it or open it up and stuff, you don't want that. That's too messy. So it's easier to work at deltoid, so that's why you put the minced, chopped up parathyroids over there, and that's the theory of that. Okay. We have calcium homeostasis. Okay, so just again, osteoblasts have ligands. So osteoblast is the one with the L in it, in the blast, and ligand is L as well. So that's how you can remember osteoblast and ligand. I guess I'll try that now and let you know if it works. Okay, calcium homeostasis. Plasma calcium exists in three forms. Iodized or free form. This is 45% of the time. It's the active form. If it's bound to albumin, it's going to be inactive, right? And this is 40% of the time. And they're also bound to anions, approximately 15% of the time. Ionized free calcium is primary regulator of PTH, Changes in pH alter PTH secretion, whereas changes in albumin concentration do not. Okay. Okay. Even if you have more albumin, that doesn't mean you'll have more calcium or something. However, if you have more PTH, you will have more calcium, right? But PTH is altered by pH as well. So metabolic acidosis or alkalosis. Okay. Calcium competes with hydrogen to bind to albumin. Okay. That's why in acidosis you have increased amount of hydrogen, right? Hydrogen ions. So they will bind to albumin more. So you have more free calcium in that case. But if you have increased amount of pH or decreased amount of H or increased amount of bicarbonate, H will bind less to albumin. Sorry, lost my train of thought. H will bind less. Okay, it's right here. So H will bind less to albumin. So albumin then binds more calcium. So you have decreased amount of ionized calcium roaming around, and this is why you would get cramps, pain, paresthesia, or carpal pedal spasm, or circumoral. Where was it? Oh, it was in my notes. So a circumoral numbness. Increase in PTH causes decrease in pH, more H. Albumin binds less to calcium, so you have increased amount of ionized calcium and decreased amount of PTH. Done with that. Now you need to know about calcium. It's the opposite of PTH. Okay, so sources again: parafollicular cells, C cells of thyroid. We need to know where that is. I think I'm not sure. We'll look that up. These are the follicular cells, these are the colloids, and these are the parafollicular cells. Okay. So parafollicular cells or C cells of thyroid. The function is decrease in bone resorption. Okay. That means less bone is being ripped apart. And then you have the regulation is increase in serum calcium, and which causes increase in calcitonin secretion. So it's just like a feedback loop for PTH, basically. So calcitonin opposes actions of PTH, not important in normal calcium homeostasis. Calcitonin tones down serum calcium levels and keeps it in the bones. So while PTH increases serum calcium, calcitonin decreases serum calcium. That's the easiest way to remember that. So keeps the calcium in the bones. Okay. Glucagon. This is made by the alpha cells of pancreas. Function is to promote glycogenolysis, gluconeogenesis, lipolysis, ketogenesis. Alleviates blood sugar levels to maintain homeostasis when bloodstream glucose levels fall too low. For example, fasting state. We already talked about this in biochem. While insulin tries to remove glucose from the blood, glucagon tries to bring glucose into the blood, right? So it's going to do everything that it can to do that. Breakdown of glycogen, making of new glucose, breakdown of lipolysis, right? Why this? Because your body uses glucose for energy, but it's trying to keep glucose in the bloodstream, so it's gonna try to have free fatty acids come in, so that body would use free fatty acid to get its energy from. That's why it breaks down lipids, and then ketogenesis as well, because of the breakdown of the free fatty acids that causes ketones. Regulation secreted in response to hypoglycemia. Okay. When you have hypoglycemia, you need glucose in the blood. Who better than glucagon to do that? It's inhibited by insulin, amylin, somatostatin. Somatostatin again, statin stops stasis. It stops everything. So, And amylin is found in the saliva and the pancreas, both places. So when you're trying to do pancreas function tests, we don't look for amylin, we actually look for lipase. Okay. Insulin, you already know about that. The beta cells. And hyperglycemia, all regulate glucagon. When you have hyperglycemia, this gets inhibited and insulin gets activated. Right? So insulin, this is the C peptide, right? And then you have this little two bond. We'll talk about all of this. So this whole thing is called prosinsulin. So before this is made, you have pre-prosinsulin. Okay, pre-prosinsulin is synthesized in rough endoplasmic reticulum of pancreatic beta cells. Okay, beta cells are the ones that make insulin, right? Cleavage of pre-signal, pro-insulin stored in secretory granules. Cleavage of pro-insulin leads to exocytosis of insulin and C peptide. So this yellow thing is insulin, right? And the red thing is C peptide because it looks like C. So exocytosis of both of them equally. This is important to know that first you have cleavage of pre-insulin. Do they have it here? No, they don't have it here. Okay, so let me see if we can find that diagram for this. Okay, I guess this is just as good as any other. Okay, so we have N-terminal signal peptide, B chain, C peptide, and then A chain. Okay, so this is called pre-proinsulin. Okay, pre-proinsulin synthesized in rough endoplasmic reticulum of beta cells. Then there's cleavage of pre-insulin. So from this we have disulfide bonds. Both of these are attached, and this is the cleavage right here. So proinsulin. So cleavage of pre-insulin makes proinsulin. So this is proinsulin now. Stored in secretory granules. So there are secretory granules in the cell. That's where they're stored. You have, actually there's also one from UWorld, I think. No. Okay, let's finish insulin in 10 minutes. How are we going to do it? We gotta leave. Okay, cleavage of proinsulin, exocytosis of insulin and C peptide equally. Both insulin and C peptides are increased in endogenous insulin secretion. For example, type 2 diabetes mellitus, insulin secretagogues, and insulinoma. Okay, all of these things will increase insulin but remember, type 2 diabetes mellitus is insulin resistant diabetes, right? And then insulin secretagogues will also cause some kind of that, and then if you have a tumor of that beta cells, you have increased amount of insulin. Whereas exogenous insulin lacks C peptide, and that's how we decide if the insulin is externally administered or it's coming from inside, because C peptide only exists from inside when it's made via biosynthesis, but if it's synthetic, then it won't have C peptide. That's how you know the thing from the other. Important to know C peptide. Function is pretty easy to figure out. So before I get rid of this, proinsulin, Golgi apparatus, that's the distribution center of beta cells. Then they send it to vessels, right? Secretory granules. That's where it is. So C peptide half-life is more than insulin. Marker of insulin biosynthesis or insulin synthesis and secretion. This is insulin half-life is around 6 minutes. Okay. Function: binds insulin receptors, so tyrosine kinase. Uh, let's see if I can do this. Okay, let's get done with at least the function of it, and then we'll do the regulation. Binds insulin receptor tyrosine kinase activity, right there, right? Tyrosine phosphorylation. Inducing glucose uptake, carrier mediated transport into insulin dependent tissue. Okay, insulin dependent tissue is right here. And then gene transcription. Anabolic effect of insulin is that it increases glucose transport into the again, remember, basic thing is it gets rid of glucose from the bloodstream, right, or the plasma. So increase in glucose transport into the skeletal muscle and adipose tissue, increase in glycogen synthesis and storage, increase in triglyceride synthesis, increase in sodium retention in kidneys, increase in protein synthesis in muscles, increase in cellular uptake of potassium and amino acids, decrease in glucagon release, and decrease in lipolysis in adipose tissue. Okay. Unlike glucose, insulin does not cross placenta. And this is important. Unlike glucose, insulin does not cross placenta. So this is how you end up with a baby having hyperplasia in the pancreas. Hyperplasia of the pancreas is because glucose is in the baby, but there's no insulin. So baby has to make its own insulin, and that's why when they're born they have high amounts of insulin, and chances are they'll go into hypoglycemia when they're born. Okay. These are the transporters that they're for glucose, and it's on most of the cells in the body. So primarily, GLUT4 are found in adipose tissue, striated muscles. Exercise can also increase GLUT4. That's why in diabetics we tell them to exercise a lot, especially the ones that put stress on the striated muscles, because that will develop more GLUT4, and that will take out the blood glucose from the bloodstream when insulin comes in. Because how much time do I have? Okay, I think I can do this. So remember, this is like the transporter, and this is the cell, right? And this is the blood, right here. That too. Okay, so you have glucose here, right? You have glucose here in the bloodstream. So to go into this, it needs to go through this door right here. And to go through this door, you need a key. And this is the key, the insulin, right? That's how the theory is. You need insulin to open the door for glucose to go in, okay? So you over here in adipose tissue and striated muscles, you have GLUT4, okay? And these are insulin dependent glucose transporter. Okay, now insulin independent transporters, the ones that you don't need key for, and you can go, just from here to here, are from GLUT1, GLUT2, 3, and 5. GLUT1, that's RBCs, brain, cornea, placenta. Okay. You have one type of RBC, one brain. You have two corneas and one placenta. So at least you can remember RBC, brain, placenta, and for cornea, you see one thing with two eyes. I don't know. Just remember, you don't confuse these with others, because this also happens to be GLUT3, where you have brain and placenta only. Okay. Your one brain works as three, or you can have three children and one placenta. GLUT2, this is an easier one to remember, and this is usually the one they test you on. It's this and this, okay, and also this one they test you on. So GLUT2, bidirectional, beta islet cells, liver, kidney, GI tract. Think two-way street. So two-way street for GI tract, urogenital tract, and liver has portal and normal venous circulation, and then you have beta islet cells that use GLUT2 Okay, this is the important one. Beta islet cell uses GLUT2. GLUT3, brain and placenta. GLUT5, F for fructose. Spermatogenesis. So fructose uses GLUT5. Spermatogenesis, GI tract. And then you have in the kidneys SGLT1 and SGLT2. We'll learn about this in renal. That's where the flozins are. Flozins use this. Sodium glucose co-transporter, kidney and small intestine. Okay. It's important to remember small intestine and kidney use these, and don't pick GLUT2 for that. Even though it says GI tract, for small intestine, pick this as the answer. Brain prefers glucose but may use ketone bodies during starvation. RBCs utilize only glucose. This is important. Only glucose, as they lack mitochondria or aerobic metabolism. Okay, 3 minutes. I don't want to rush through this, so we'll come back and brick lips. Sorry. Insulin independent, glucose uptake, brain, RBCs, intestine, cornea, kidneys, liver, islet cells, beta cells, placenta, and spermatocytes. Right. If you don't want to remember all that, you can just remember that GLUT4 is the insulin dependent one. Right. That's the one where you require the key to go in, and this is your adipose tissue, striated muscles. That's it, and that's why you tell them to work out, so you can develop more GLUT4 channels where insulin can attach to, and then it can make less serum glucose. Right. Okay. On to regulation. Regulation glucose is the major regulator of insulin release. Insulin response with oral versus IV glucose due to incretins. For example, glucagon-like peptide or GLP-1, glucose-dependent insulinotropic polypeptide, GAP, which are released after meals and increase in beta cell sensitivity to glucose. Already know all this. When you eat food, insulin is released, right? How is it released? It's glucose, attaches to the receptor there, which are sensitive to glucose on pancreas, on the beta cells. So release decreased by alpha 2, and it's increased by beta 2 stimulation. Right? 2 regulates insulin. Okay. So beta 2, alpha 2. Okay. Glucose enters beta cells. So over here we have GLUT3. So before that, let's talk about this right here. So glucose comes in, you have tyrosine phosphorylation, and from here it either goes to phosphoinositide 3 kinase pathway, or it goes through RAS-MAP kinase pathway, right? This is IP3, and this is the RAS, right? So here you have this is the RAS-MAP kinase pathway. So how it works is you have dimerization, phosphorylation happens, and cross phosphorylates. That just means that there's a cross between them, and then SOS or GRB2 attaches to it. Then RAS makes a complex where GTP is GDP attaches and gets converted to RAS GTP, and then you have RAF, MEC, and ERK, right? Here we have glucagon, which stimulates protein kinase A. Glucagon does what? It makes it breaks down glucose, so we have more glucose in the blood, right? So protein kinase A activated, it decreases glycogen synthase, and it activates glycogen phosphorylase. So when you have glycogen phosphorylase, glycogen converts to glucose. Okay. Here, glycogen synthase is inhibited by glycogen kinase A, but it's activated by insulin and tyrosine kinase. How? It activates protein phosphatase, and that also activates glycogen synthase. We have insulin receptors. They also get phosphorylated, right? So that's this thing right here that we talked about, and this goes to tyrosine phosphorylation of insulin receptors, and they go into IP3 and RAS. right? IP3 is the one with phospholipase C uh, comes in and converts the, what was it? Uh, it helps convert the thing from that to IP3 plus DAG, right? That was in, I think we still have it in downloads. Yeah, this thing right here. So PAP, that's what it was. Okay. So this is how that one works, right? So it comes in alpha GQ and phospholipase C, PAP 2 gets converted to IP3 under the influence of phospholipase C. So IP3 and DAG, and then IP3 is the one where, you know, calcium from it, sarcoplasmic reticulum, and then it activates PKC. DAG also activates PKC. That's protein kinase C. Okay. So you have tyrosine phosphorylation coming in, phosphoinositide 3 kinase pathway, or the RAS-MAP kinase pathway. So RAS-MAP kinase pathway is this. You have RAS GTP, and then it makes RAF, which is MAP kinase kinase kinase, then becomes MAP kinase kinase, then you get MAP kinase or ERK. Right? That's how you get there. RAS binds to SH2 domain and becomes activated. These things use this pathway, insulin, insulin like growth factor 1 from growth hormone, right? Or somatomedin C, also called. Then you have fibroblast growth factor, platelet derived growth factor, and endothelium growth factor. Regulation, okay. So yeah, so it comes in RAS kinase, then it causes cell growth, DNA synthesis. Or over here, glycogen lipid protein synthesis, right? Insulin causes what? Reduction of glucose from the bloodstream, so in the form of glucose, lipids, and proteins. Okay. This IP3 will go into vesicle containing GLUT4, right? That will attach over here and cause increase intracellular uptake of glucose. That's it. This is your insulin dependent uptake. So you need to know about this pathway, RAS-MAP pathway or PAP, okay. Or IP3. Yeah. Okay. Then you need to know about this one. So here, glucose enters beta cell from here, GLUT2. Okay. Then you have increase in ATP generated from glucose metabolism. Okay. Then you have okay, sorry. So when you have increase in ATP generated from glucose metabolism, this ATP then goes and binds to the potassium channel. Okay, so ATP generated from glucose metabolism closes when it binds to the potassium channel. It closes the potassium channel. This is the target for sulfonylurease. Okay, we'll talk about that. It's the drug, diabetic drug. Okay, and then what happens when potassium is closed? It depolarizes beta cell membrane. Okay, so when you close potassium channel, it is ATP sensitive, right? So that will cause depolarization. What happens when you have depolarization? Calcium comes in. Okay, so depolarizes beta cells, then voltage gated calcium channels open, and there is a calcium influx. Okay, so again, glucose, you have glycolysis. You remember glycolysis, the pathway we did in biochem, right? This thing right here, and you have ATP over there, ATP over here, and ATP is used up over here and here, right? And it's also used up here. So you make 2 ATPs over here, basically. So that's glycolysis, because right there, glycolysis, breakdown of glucose. So via glucose breakdown, it makes ATP. The 2 ATPs are then used up, come in here and attach to potassium. Potassium closes the channels. That causes depolarization, because now you have enough buildup of potassium ions or positive ions, right? Because that's how depolarization occurs when the positive ions gather. It's usually with sodium because sodium is also in positive. So when potassium goes out, two sodiums come in and that causes depolarization. But when you close this, there's buildup of potassium. It's enough to cause depolarization and bring the threshold for positive polarity above the threshold, causing depolarization and action potential or whatever. So when that happens, you have voltage gated calcium channels open up. When that happens, there's influx of calcium, then you have intracellular calcium, and then in the vesicles, uh, the ones that contain insulin granules, remember we talked about that in the secretory granules. There, the calcium causes exocytosis of insulin granules, and they go out and then they secrete the insulin into the blood vessels. Okay, so again, voltage-gated calcium channels open up, calcium influx, and stimulation of insulin exocytosis. Okay, and that's how it goes out. So if you just understand it this way, it's pretty easy to answer questions about these. They'll ask what happens once glucose comes in. What's the first thing that happens? Well, ATP is made from glycolysis. And then they say, okay, there was ATP found in the cell. What's the first thing that happens after that? Then it closing of potassium channel that causes depolarization. It's the closing of potassium and not the influx of sodium. Okay, that's important. There's no sodium involved anywhere here. Okay, at least not in this. Only place where it would be involved is in kidney and small intestine through sodium glucose channel, right? So there's no sodium channel or sodium involved anywhere here. So depolarization, influx of calcium causes secretogranules to go out and then secrete insulin. Cool. Next, adrenal steroids and congenital adrenal hyperplasias. This is a very easy concept as long as you remember which one is where. Okay. So just remember it like there are 3 lines here. Okay. There are 2 things you need to know that happens here and 2 things you need to know that happens here. Okay, that's all, and nothing else you need to bother with. But to make it easier, if you understand all of this, it's quite easy to comprehend it, right? So you have cholesterol converting to pregnenolone, to progesterone, to 11-hydroxycortisone, and corticosterone and aldosterone. Okay, and aldosterone is what's made in zona glomerulosa, right? That's the thing we were talking about up there in the right here, anatomy. We need to know what they look like, correct? So, okay. Alright, so that's how aldosterone is made. Okay. What are the things you need? You need 21 hydroxylation, okay, to go from progesterone to 11-deoxycorticosterone. The thing you need to know about deoxycorticosterone is that it's a weak mineralocorticoid, and that's an important factor. So, weak mineralocorticoid. Don't laugh at my spellings. Not fair. I'm working without spell check. Okay, so that one is 11-deoxycorticosterone. And then to make corticosterone, you have 11-beta hydroxylation. Okay, and that's an important one too. And then you get corticosterone. From corticosterone with aldosterone synthase, you make aldosterone. Okay, this one is stimulated by angiotensin 2, which is stimulated by renin. Right, that's the whole ROS system. Important thing to know about aldosterone is that it reabsorbs sodium, but also absorbs hydrogen in exchange for potassium. So it excretes potassium. And reabsorbs hydrogen or sodium, either way. This is a weak mineralocorticoid. It will come in handy if you remember that. Okay. So 21 hydroxylation and 11 beta hydroxylation. Another thing you need to know about is these two things, right? So up to here. So here we talked about 21 hydroxylation on top, uh, right? And here you were talking about 11. So it's going from 2 to 1, okay? 2 to 1. And over here we have 17 and 17, so we don't even have to worry about that one over here. So what does 17 alpha hydroxylase do? It actually makes cortisol. It helps make cortisol. So you need this to convert pregnenolone or progesterone to 17 hydroxyprogesterone, 17 hydroxy pregnenolone. Okay, they both get converted to 11 deoxycortisol from the same enzyme, 21 hydroxylation. Okay, and with same enzyme 11 beta hydroxylation, you make cortisol. Okay, so these two things again, 21 first, then 11 beta, and beta is less or second, so you can remember that way too. Alpha is always the first, so alpha goes up here, so that's 17 alpha hydroxylase up here, but they won't give you alpha, so you have to remember that it's 17 hydroxylase as well. You gotta remember it that way too. Okay, so 17 up here, then you have 21, and then you have 11. As long as you remember this position, it's gonna be easy to do this. So then you have 11 deoxycortisol making cortisol, and then again cortisone. These are glucocorticoids made in zona fasciculata. That's the one with the white space, right? Then you have these getting converted with the 1720 lase to. We don't need to worry about these. The only thing we have to worry about is this, and this. These three things. That's it. And its position. We have DIA, dehydroepidosterone, or DIA. DIA goes into converting into androstenedione, which gets converted to testosterone. With 5-alpha reductase, it makes DHT, right? Necessary for development of external genitalia for men, as well as this again, it's a sex hormone, right? So it can make testosterone, or it can make estrone, which converts into estradiol, and then estradiol can convert into estrogen. And yeah, so estrogen and DHT is what gets made with androstenedione. Okay, in the peripheral. Okay, now before we move on, just so we talk about it, 5-alpha reductase is inhibited by finasteride. Okay, finasteride is used in treatment in baldness, because this is what causes male pattern baldness. So when this is inhibited by finasteride, it could help with that. Anastrozole, letrozole, and exemestane, they inhibit the aromatase. Aromatase are found in where? Fatty tissues, adipose tissues. So that's why in guys with who are obese, you see gynecomastia, because they have aromatase, which converts testosterone into estrogen. Normally it's balanced out equally, so you don't have to worry about it. But when you're fatter, you have a higher force of estrogen compared to testosterone. That's why you end up with gynecomastia. So these two can get inhibited by anastrozole, letrozole, and exemestane. You don't need to remember the name, as long as you know that when you look at these inhibit aromatase. Okay, so these are aromatase inhibitor. We do them in repro as well. Over here we have glycuronic acid that inhibits conversion of cortisol to cortisone, and here we have ketoconazole. Again, we give ketoconazole for fungal or dandruff, like ketoconazole shampoo, not oral, but like just topical. So it inhibits cholesterol dismutase, right? And that also that if it's taken you know, if it's taken orally, then it can cause gynecomastia in males as well. Okay, so now that we're done with this, just a little logic. That's all we have to apply to it. So say if I inhibit 21 hydroxylase, okay, what's gonna happen? This is not gonna get converted to this, so this whole process is not gonna happen. It gets stuck here, right? So you have more of these products, so they will get shifted into this, right? So you have more cortisol being made compared to this before it was making, right? And you'll have more sex hormones getting made, okay? So that's how this works. So say this is functioning okay, but you have deficiency of 11b hydroxylation. What's gonna happen? You make a lot of 11 deoxycorticosterone, okay? But you gotta remember, it's a weak mineralocorticoid. What does that do? It has a similar action to aldosterone, which is reabsorption of water, increasing blood volume, increasing your BP, right? So even though you're not making aldosterone, you can still get increase in BP with 11 beta hydroxylation, okay? And then it won't go from there over here. So that's why it's important to remember this is a weak mineralocorticoid. Okay, it still has. It's not going to be as powerful as aldosterone, but it still has similar action to it. And for steps, you can just think of it like aldosterone with 11 beta hydroxylation. Okay, so between 21 and 11, you get weak mineralocorticoid made. So if there's deficiency of this, you have this. And remember, this thing doesn't do a feedback loop like aldosterone does. Okay. Okay, so now say you have both of these functionings, 21 hydroxylation and 11 beta hydroxylation, but you had deficiency of 17 alpha hydroxylase. Again, sorry, I forgot to go over this. So 11 beta hydroxylation, you have this buildup and you have this and this buildup as well. So they both get converted to, again, cortisol and sex hormones or androstenedione. Okay. Now you have deficiency of 17 alpha hydroxylase, then you don't get cortisol or you don't get this either, the testosterone or estrogen being made. Then you're just gonna have zona glomerulosa. Okay. Now say you have deficiency of 21, or usually this is the one they talk about for this, but it also happens because of this. Okay, so any number that has 1 at the end of it, right? 1 at the end of it is going to cause virilization. So what is virilization? First we'll look at what Google says virilization is. Alright, that's the development of male physical characteristics such as muscle bulk, body hair, or deep voice in female or pre-pubescent boy, typically as a result of excess androgen production. Okay, now that's clear. We can talk about this. So virilization happens with anyone that has deficiency of a number that ends with 1. Okay. So what does that mean? So when you have this deficient, you have more of these products, and these get converted to cortisol. Sorry, not cortisol. Sorry, that doesn't happen because you need this for that as well, right? So then it just gets converted to sex hormones, right? So androgens, and then androgens make more testosterone, as you can see. This is the primary place where it happens in the adrenal medulla. It can go on and with aromatase and make more of this. However, you will have a lot more of testosterone than you will getting converted from aromatase. Because remember, aromatase is in what? It's adipose tissue. Now, in young females, you won't find that much adipose tissue where aromatase is available. So again, that's also the reason why testosterone has a higher balance than estrogen and that. So if it's a male and you have high testosterone, that's okay. It just means they're gonna develop faster than they would have. But in females, it's gonna cause virilization, right? They'll may have physical male characteristics, and that could be anywhere from like body hair to like enlarged clitoris that looks like penis in them. So that's how they confuse. That's how like a child might grow up as a boy and learn that she was a girl all along. This happens in, I think there was like a House MD episode on that as well, where no, that was opposite. It was a guy who lived like a girl until puberty, and then they realized that this person has both the ovaries and testes. So then in that episode, they had him or her decide if he wants to be her or she wants to be him or something like that. Anyways, so now let's put that to the test, right? Uh, let's cover this up and see if we can figure it out, right? Okay, so we'll look at it here and then figure it out with this, okay? So 17 alpha hydroxylase, what's going to happen for mineralocorticoids? So 17 alpha hydroxylase, you won't have these. Oh yeah, another thing. So anything that starts with 1, you're going to get increase in mineralocorticoids, and mineralocorticoids increases what? BP, right? So that means this starts with 1. So deficiency of this will cause increase in this as well, right? So weak mineralocorticoids you're going to get, and you'll get this, but you won't get cortisol, okay? So this, and also if you have 17 alpha hydroxylase, you'll have more aldosterone causing increase in BP as well. Okay, now let's try this. So 17 alpha hydroxylase, what's going to happen to mineralocorticoids? That will increase, right? Then what happens to potassium? What does aldosterone do? I told you already, it excretes it, so that's going to be decreased, right? What's going to happen with BP? Mineralocorticoids increase, so BP will be increased. You have cortisol. What's going to happen in cortisol? You don't have cortisol being made, right? Because there's a deficiency right there. Then you have sex hormone. Sex hormone, there's going to be a decrease in that as well, right? What will the lab say? We'll read about that. And presentation. If it's a girl, it's okay because she's not getting this, and she'll get estrogen from this somewhere, or one way or the other. But if it's a guy, he will have female characteristics, I'm guessing. So let's see. So what did we say about this? Okay, so mineralocorticoid, we said it goes up. Aldosterone secretes potassium, so that's going to decrease. BP, mineralocorticoids go up, so BP goes up. Cortisol, it's not going to be made because it's not going through, right? And then you have sex hormone, again, it's not going through, so it's not going to make sex hormones. Labs, you'll see decrease in androstenedione. Okay, that's just that right there, the sex hormone one. Presentation for male, they're going to have atypical genitalia, right? Because you need DHT for external genitalia development in males. We'll read about that in repro. Okay, so that kind of looks like females because the external genitalia is not developed, so it just looks like a clitoris kind of thing. And they won't have testes descending. So they have to get rid of the testes within like I think it was like 2 months before it turns, malignant or something, because it has a higher risk of malignancy, the undescended. So it's called orchidism or something like that. XX. So in females, they lack secondary sexual development. That's what they lack. Okay. So it affects female, but not to the as far as it does affect the males in this one, right? So 17 alpha hydroxylase, you got that one. Now mineralocorticoids. and 21 hydroxylase deficiency, what's going to happen to mineralocorticoids? It's going to be decreased, right? Because you have deficiency of the green thing right here. So it's not going to make weak mineralocorticoid or aldosterone or cortisol or 11-deoxycortisol. But what's it going to make? A lot of sex hormones, right? So mineralocorticoid decreased. So what's going to happen to potassium? Nothing, right? It's not going to have any effect on that. BP, nothing, or it could be increased. I don't know. We'll see about that one. BP, since mineralocorticoid is down, BP is going to be down as well. Or, yeah. Then you have cortisol. Cortisol is going to be decreased, right? Similarly as this one, because that's not going to be made. Sex hormone, we know that one's going to be increased because of this, right? For labs, we'll read about it in presentation. Since now there's going to be more testosterone, for males it's going to be okay, but for females they're going to have virilization, right? So let's see. Mineralocorticoid is decreased. For potassium it's increased. Okay, I said no change or increase, right? So increase. Mineralocorticoid is down, so BP is down. Cortisol, it's not going to be made. And then sex hormone, again, it's increased, right? So the labs will show that there's increase in renin activity, and then you have increase in 17-hydroxyprogesterone. Okay, so 17-hydroxyprogesterone, that thing right there, and increase in renin activity. Why? Because remember, you have lower BP, so what's that going to activate? It's going to activate ROS. So ROS is going to activate, and then you have renin making angiotensin, and then angiotensin is looking for a place to convert to activate aldosterone synthase, but aldosterone synthase is there. However, they don't have the precursor corticosterone or 11-deoxyhydrocorticosterone, right? So it's not making aldosterone. If it's not making this, renin is going to think that angiotensin 2 is not enough, so it's going to keep making more angiotensin 2, and then it's going to make more of this, and then this, right? Also, you have to remember, even though it doesn't apply here, angiotensin 2 is a vasoconstrictor, okay? That's an important thing to remember that. However, don't think of that when you think of this diagram, okay? Because you don't have the blood volume, so even if you increase the vasoconstriction, it's not going to affect the BP. So increased renin activity because of that. What happens to the thing? Most common, this is the most common one, presents in infancy. This is called the salt wasting, because remember, this was the salt. Mineralocorticoid is the salt, right? So salt wasting or childhood, precocious puberty. Okay, presents in infancy or childhood. Okay, and for female, it's going to cause virilization because they have a lot of testosterone now. Okay, because of this deficiency. Now, 11-beta hydroxylase mineralocorticoid. Although it's not making aldosterone, it is making 11-deoxycorticosterone, right? And that's a weak mineralocorticoid. So mineralocorticoid, I think it's gonna be increased, but we'll see about that. Potassium, aldosterone has a effect on that, but not this thing. So I'm guessing that'll be increased. BP, it is a weak mineralocorticoid, so that will be increased. And then cortisol, it's not going to be made, right? Because that's different. You need that to make cortisol. Oh yeah, we forgot about this one. So miridapone, this is where it can inhibits that. Okay, then sex hormone, that's going to be increased, right? So because you will have more product buildup of this, so then that will make that, because it's not making cortisol either. So that level, read about presentation. Again, you'll have virilization in female. If it's a male, it's okay. Okay, let's see. So decrease in aldosterone, but increase in 11-deoxycorticosterone. So it results in increase in BP. Yeah, we talked about that. So it does have effect on potassium. Okay, so it decreases potassium as well. So it acts just like aldosterone. Nothing different than aldosterone. increases BP. Cortisol is decreased. Okay. Increase in sex hormone. We already know about that. So you have decrease in renin activity because since obviously you have increase in BP, so RAS is not going to be activated, and you have salt, so it's not going to be detected in the renal tubules either. Okay, so presentation, it presents in infancy or childhood, and XX, so virilization. Okay, and let's read this. All congenital adrenal enzyme deficiencies are autosomal recessive disorders, and most are characterized by skin hyperpigmentation. This is due to, again, we already talked about this, right? So if you don't have this, this is going to increase, right? And if this increases, so does MSH, right? So again, all congenital adrenal enzyme deficiencies, all of these three are autosomal recessive disorders, and most are characterized by skin pigmentation due to increase in MSH production, which is co-produced and secreted with ACTH, and bilateral adrenal gland enlargement due to increasing ACTH stimulation. So yeah, that is what it says. If deficient enzyme starts with 1, it causes hypertension. Okay, so that just means this one starts with 1 and this one starts with 1, right? So this one, deficiency of this is going to make weak mineralocorticoid, and deficiency of this is going to make aldosterone a lot more. Okay, so that will cause increase in BP. If deficient enzyme ends with 1, it causes virilization in females. Already talked about that. So if it ends with 1, that's this and this, right? It's going to make more of this product, which gets converted to this androstenedione and testosterone. Cool. Next. Cortisol, adrenal zona fasciculata, that's where it's made. GFR, the middle one. It's bound to corticosteroid binding globulin. Function is increase in appetite, increase in blood pressure, upregulates alpha 1 receptor on arterioles, increase in sensitivity to norepinephrine and epinephrine. This is permissive action. Okay. Okay, so before we do that, let's do this thing. Okay, so if you have any kind of stress, or there's a difference in circadian rhythm, that will activate hypothalamus to release corticotropin releasing hormone, which will release will stimulate the anterior pituitary to release or cleave or convert propiomelanocorticoin into endorphins, MSH, and ACTH, and then the ACTH goes on and makes more cortisol. The cortisol inhibits hypothalamus and anterior pituitary and downstream cortisol function. So what are the downstream cortisol function? It increases appetite. This is also known as stress eating. Increase in BP. This is why even if they don't have a problem with hypertension, people will have BP of like 160 when they're in a doctor's office. That's called the white coat syndrome. Upregulates alpha 1 receptor on arterioles, right? Alpha 1 are the vasoconstrictors. Increase in sensitivity to norepinephrine and epinephrine. This is a permissive action. At high concentration can bind to mineralocorticoid. That's or aldosterone receptors. So cortisol is also a weak mineralocorticoid. Okay, and that shouldn't be hard to grasp because it's in the name, right? Corticosteroid. So cortisol is also weak mineralocorticoid. Okay. So at higher concentration, it can bind to mineralocorticoids or aldosterone receptors. It increases insulin resistance. This is diabetogenic. It increases gluconeogenesis, lipolysis, and proteolysis. Decreases glucose utilization. Okay. Insulin resistance. So increases gluconeogenesis and lipolysis and proteolysis. So this causes decrease in glucose utilization, decrease in fibroblast activity, poor wound healing, decrease in collagen synthesis. There is an important concept about this as well. I've written that cortisol increases neutrophils but does not allow it to go to the site of inflammation. So cortisol sequesters all other WBCs in bone marrow. Okay, so you gotta remember that there will be increasing neutrophils as well. And it's not just cortisol, even with corticosteroid, it has a similar effect, right? That's why long-term corticosteroid or steroid use causes infection chances of all that, and you have like vasculitis from staph and all that stuff. So also you need to know that cortisol increases glucose. That's how you remember that. This whole gluconeogenesis and lipolysis and all that stuff. Okay. So, okay, and oh yeah, right. Let me just check one more thing. Yeah, okay. This is what I was doing. So cortisol increases hormone-sensitive lipase, to convert TGO into glycerol and fatty acid. Why is this important? Because cortisol is the reason you survive stress. Stress like surgery, infections, exams, trauma, right? All this stuff. There's a question about this woman who was stripped, who was hungry for a long time, but then when they checked the blood glucose, it was normal. Which one was the factor that helped it maintain the blood level, right? It's cortisol. Cortisol is the one that does that. It helps you survive all of these things, okay? And how does it do that? The increase in cortisol causes stimulation of hormone-sensitive lipase, which converts triglyceride into glycerol and fatty acid. And the glycerol is the thing that goes on into the liver and converts to glucose via gluconeogenesis. Okay. So cortisol again here, it increases gluconeogenesis. Okay, and the other side is fatty acid gets converted to acetylcoenzyme A via beta oxidation or breakdown of fatty acid, and because of that you'll also get ketone bodies, right? And ATP. So the ketone bodies is the reason you get muscle pain. Okay, that's all for that. So increase in gluconeogenesis and lipolysis, we just saw that, right? And proteolysis. Fibroblast activity, poor wound healing. Again, it causes neutrophilia, but it still increases infection because it doesn't, allow neutrophil to go to the site of inflammation, and also sequesters other WBC. So it decreases inflammatory and immune response. So it inhibits production of leukotrienes and prostaglandins, inhibits WBC adhesion, so neutrophilia, blocks histamine release from mast cells. It causes all the other WBC to sequester, so you'll get eosinopenia and lymphopenia. It blocks interleukin 2 production, right? Interleukin 2 production is for T cell, right? Remember, hot T-bone steak. So hot was fever, IL-1, 2 was T, 3 was bone marrow, and then you had 4 for IgE, then IgA, and then 6th was acute phase reactant. Okay, decrease in bone formation, decrease in osteoblast activity. That's the building one, right? So building one, so it doesn't mineralize the bone or build the bone, so there's decreased formation of that. This is different from increase in bone osteoclastic activity. It's not the same thing. Osteoclast is still doing what it was doing. There's no increase or decrease in it, but there is decrease in osteoblastic activity. It's independent of each other. Okay. Cortisol is a big fig. That's how I remember these, but I think you don't need that anymore. You just know what cortisol does. Exogenous glucocorticoids can cause reactivation of tuberculosis, right? Because it sequesters, macrophages as well, and it can cause reactivation of TB and candidiasis because it blocks interleukin-2 production. There you go. That's why. Okay. Regulation is by corticotropin releasing hormone or CRH from hypothalamus, stimulates ACTH release from pituitary. Once it's the pituitary, it causes cortisol production in adrenal zona fasciculata. That's the white area. Right. Okay, white area. So then excess cortisol decreases CRH. There is a feedback loop, right? Excess cortisol feedbacks that. ACTH and cortisol secretion, all of it gets inhibited. Chronic stress induced prolonged cortisol secretion, so cortisol resistance, impaired immunocompetency, and dysregulation of hypothalamus pituitary adrenal axis. Okay. Another one is HPG, that's hypothalamus pituitary and gonadal axis, but that's for repro, so this one is for this. And yeah, so chronic stress may induce prolonged cortisol secretion. So cortisol resistance will happen, and then you have impaired immunocompetency and dysregulation of the axis. Done with that. Now appetite regulation. So for ghrelin, I think of that one as actually I'm gonna butcher the spelling for that, so there's no H, okay. So gremlin. You know gremlin? They eat a lot, right? I'm just trying to there's a gift for that. Put this image in your head, right? So they eat a lot. So this is what I think of when I think of ghrelin. Okay. And I think that's majority of you guys as well. So gremlin. It stimulates hunger, so orexigenic effect. You gotta know this word. Why you gotta know this word? This word's not gonna show up, but what will show up is where it is. So orexigenic and anorexigenic peptide signals the gastrointestinal. Nope. They don't have that word here. So just remember this, orexy, okay? So anything after that, they're talking about this, okay? Stimulates hunger, orexigenic effect, and growth hormone release via growth hormone secretagogue receptor, produced by stomach, obviously. This one's produced by adipose tissue, okay? Sleep deprivation, fasting, and Prader-Willi syndrome increases ghrelin production. Okay, this is the one where the kid is obese, right, and he eats a lot. So ghrelin makes you grow hungry. Okay, so it's the one that makes you eat. So it stimulates hunger and growth hormone release as well, and produced by the stomach. Okay, and you'll see it in increased amount in this. And that axon. Okay, 10 minutes. Let's finish this page. Appetite. It acts on, you need to know this, it acts on lateral area of hypothalamus, okay, which is the hunger center, to increase appetite. We'll know about this in detail in neuro, but remember, gremlin eats, it makes you eat. Leptin makes you lean, okay. Leptin, like the leptin tea, and people drink tea to stay lean, right? This is the satiety hormone. This is the one where you're like, okay, I'm done eating now. I have enough. I'm satisfied. That it's produced by adipose tissue. Okay, so that, and this is the reason why if a person is obese, you would think that, if a person is obese, you would think that the cell is going to make more leptin, more adipose tissue than more leptin, right? Which is true. Leptin does get produced a lot, but what happens is the area in hypothalamus that it acts on, or here, ventromedial area of hypothalamus, the satiety center, it starts getting desensitized to this. Okay, so no matter how much leptin you produce, eventually what's going to happen is it's not going to respond to it, and that's why leptin insensitivity occurs in obese people. So satiety hormone produced by adipose tissue, mutation of leptin gene, mutation of this will cause severe obesity. Okay, because now you don't have anything that's telling you to stop eating. Obese people have increased leptin due to increase in adipose tissue, but are tolerant and resistant to leptin's anorexigenic effect. Okay, I just explained that. Sleep deprivation or starvation will cause decrease in leptin production. Again, that could be your stress eating as well, right? When you're deprived of sleep at night, when you're studying for your exams, you feel hungry, you're always munching on something, and that's why you get fat or pick up weight within like a month or two, because you're just sitting around and reading all night. Leptin keeps you thin, acts on ventromedial area of hypothalamus, satiety center, and it decreases appetite. Then you have endocannabinoids, cannabinoids, right? So that's your marijuana or CBD and all that stuff, giving you munchies. Act on cannabinoid receptors in hypothalamus and nucleus accumbens. Okay, nucleus accumbens is the cucumber one. I forgot that. There's a nice mnemonic for this. We'll do it in neuro. Grab a new right, GABA. That's the one. Grab a cucumber. That's how I remember that. Accumbens is the one that makes GABA. Two key brain areas for the homeostatic and hedonic control of food intake. Okay, so it increases appetite. So two key brain areas for homeostatic and hedonic control. Which ones? Nucleus accumbens and hypothalamus. The receptors. So exogenous cannabinoid causes the munchies. Okay, good enough. This is the signal pathway. I actually went over it a couple of times, so I should be able to get through it in 7 minutes. So this is the pathway for insulin and stuff, and then we have the pathway in downloads. This one. So let's get rid of this one. Okay, so CAMP, right? CAMP is CMP right here. It's made from either GS or GI. Not GI, sorry. It's excited with or stimulated by GS and inhibited by GI. Yeah, and CGMP is used by this. That's for your BNP, ANP, and EDRF. The CMP ones are all of these: FSH, LH, ACTH, TSH, CRH, ACG, ADH. That's the V2 receptor, the renal one. MSH, PTH, calcitonin, the opposite of PTH. GHRH, glucagon, histamine. Okay, so CAMP: FSH, LH, ACTH, TSH, CRH, ACG, and ADH, the renal one. MSH, PTH, calcitonin, histamine, that's H2 receptor, glucagon, and GHRH. Okay. For CGMP, it's only three things. That's the one with guanylate cyclase, right? So when NO comes in and attaches to guanylate cyclase, it converts GTP to cGMP. It could be NO, or it could be some other stuff, but usually this is the one they talk about. Converts GTP to cGMP, and that activates the protein kinase G molecule, right? So you have BNP and ANP and EDRF, endothelial derived growth factor. That's NO, nitric oxide, right? So BNP again, that's brain nucleic peptide or atrial peptide. This is the one from atrium. This is the one from ventricles, and this is on the in the vessels itself, in the endothelial lining of the vessels, and that's where the NO comes from. And they work via cGMP or guanylate cyclase. Then we have IP3, right? That's this thing right here, IP3. So you have GQ coming in, the second messenger phospholipase. With the help of that, PAP converts into IP3 and DAG, and they both activate protein kinase C, right? Via calcium from sarcoplasmic reticulum. So IP3, GnRH, oxytocin, ADH. This is V1 receptor. This is the one in the vessels. Because it causes what? It's a vasopressin, right? So it presses the vessels inwards. The way I showed you that was this. It's a vessel, and then when vasopressin attaches to receptor, it causes vasopressing into each other. TRH, histamine, H1 receptor, angiotensin 2, and gastrin. These don't work for me, so that's why I'm not going over that. You can do that though when you wanna. I just remember it the way, this way, because I went over it a couple of times. Okay, so again, gastrin, IP3. And it's also not really tested on that much. What will be tested on is for like FSH. No, they don't test for that. They'll test for these, NO. So you need to know about this one. The IP3, you just need to know the mechanism, because they'll test you on like this whole mechanism right here, right? There was a question about this, but I talked about it in biochem, so I won't go over it again this time. Intracellular receptor, how much time do I have? 2 minutes. Hurry up. Intracellular receptor, we have progesterone, estrogen, testosterone, cholesterol, aldosterone, T3, T4, vitamin D. You have receptor tyrosine kinase, that's this thing right here. It's insulin, IGF-1, FGF, PDGF, and EGF. And then you have non-tyrosine kinase, that's this little paragraph I wrote. Downstream signal phosphorylase relation, tyrosine kinase that is bound to intracellular JAK-STAT, activates JAK-STAT pathway and activation of transcription factors. You have growth hormone, prolactin, and EPO for that. Okay, so G, colony stimulating factor, erythropoietin, thrombopoietin, prolactin, immunomodulator, for example, cytokine, interleukin 2, interleukin 6, interferon, and growth hormone. JAK-STAT pathway, think acidophil and cytokines. And we're done. Break. We were talking about this one, non-receptor tyrosine kinase, right? So we need to know what that is. We know what receptor tyrosine kinase is, hopefully now, right? But what is this? So this was receptor tyrosine kinase. That's how this one works, and this is a photo to help us understand that better. So you have phosphorylation on the thing, and then it cross-phosphorylases, right? That doesn't happen in JAK-STAT, okay? So then you have GERB2 right there, GERB2 and SOS. They make a complex with the RAS, and then the RAS converts GDP to GTP, and that's what causes the MAP kinase signal pathway. So first you have RAF, which is MAP kinase. Right? Then you have MEK, or MAP kinase, or MAP KK, and then you have ERK, or MAP kinase, or MAP K, right? That's the MAP kinase thing, and then it goes in and then does the transcription factor, attaches to the transcription factor, right? Here on the JAK-STAT pathway, you don't need any of these complexes. You just need JAK getting phosphorylated, which attaches the STAT to each side, and then the STAT with the phosphorylation becomes JAK-STAT activate gets activated, and that activation is called JAK-STAT signal pathway. They directly go inside and do the transcription. So that's what was here. Downstream signal, phosphorylation, tyrosine kinase that is bound to intracellular JAK, right? Intracellular JAK right there. So then it activates the JAK-STAT pathway and activation of transcription factor from there on. Okay, here I've written growth hormone, prolactin, and erythropoietin, and then there are two more that you need to know, which are growth hormone stimulating factor and thrombopoietin. Oh, one more here, immunomodulators. These are your cytokines, interleukin 2 and interleukin 6 and interferon, right? So you need to know this and you need to know about this. The other ones are, they could be asked or not, but majority of the time when they're asking about these, they're questioning about the pathway itself, and it should be clear now how that works. Okay, intracellular receptors. For these, we're going to talk about that over here. Okay, so signal pathway of steroid hormones. So what happens is binding to a receptor located in the nucleus or in cytoplasm. So hormone comes in, it goes in to the receptor. Receptor then transformation of the receptor to expose DNA binding protein. It goes in, attaches to the DNA straight away. So binding to enhancer like elements in DNA. Right. Then you have intron, exon, and then you have mRNA. mRNA is the one that goes outside of the nucleus into the ribosome to get translated into proteins, right? And this is the one where I was talking about the zinc fingers. So the place where it attaches to is called the zinc finger domain, and the domains are where, and there are only a couple of things that attaches straight to it, right? So that one, I said like progesterone, estrogen, steroid, thyroid hormone, fat soluble vitamins, and aldosterone, right? And that's what you have here, right? So progesterone, estrogen, testosterone, cortisol or corticosteroids, right? Or steroids, aldosterone, thyroid, and fat soluble vitamins, vitamin D. Okay. Mostly that's the one that we talk about because that one has a more effect on the DNA than any other ones. That's all. So steroid hormones are lipophilic and therefore must circulate bound to specific binding globulins which increase their solubility. In males, increase in sex hormone binding globulins, sex hormone binding globulins lowers free testosterone. Okay, so basically just like any other thing, if you have a free molecule, it's considered active. If it's bound to albumin or any other protein, right? If this is bound to like that or this, it's considered inactive, right? So to be active, it gotta be free. So see, this was your sex hormone binding globulin, right? So that and this. Okay, so this one, it lowers the free testosterone, right? Because then it binds it, so you don't have any more of these. So that's what's it. So when you don't have free testosterone, what happens? There's an imbalance between testosterone and estrogen now, right? So there's more estrogen now. Estrogen. Right? So in males, estrogen can cause gynecomastia. Okay? That's why. Via aromatization and all that stuff as well. In females, what happens is, again, same thing. Increase of this will, attach that to it. So it won't make much of a difference for a female. But if you have less of these, now it's the opposite, right? Now you have more free testosterone. So again, you're going to get virilization, which is, facial hair. So hirsutism or hirsutism. I call it hirsutism. Okay. So increase in estrogen occurs in OCPs and pregnancies, right? So increase in estrogen causes increase in sex hormone binding globulins. But definitely remember this thing right here. Okay. So increase in free testosterone for males, it's okay, but if you have decreased binding it to this, causes gynecomastia. In females, opposite. We don't mind it if it's bound to it, but if it's free, then it's going to cause hirsutism. Okay. Increase in estrogen is proportional to the amount increase in sex hormone binding globulin. Cool. Done with that. Now we're on to pathology. Serum. This is CF. So serum of inappropriate. Okay. Syndrome of inappropriate antidiuretic hormone secretion. We already went over this. Hypothalamus. That's where ADH is made. Then it goes and gets stored in the pituitary, and then it gets regulated and released as needed, right? ADH, and then it goes into the medullary collecting tubule, right? Proximal and collecting, or sorry, yeah, I think we're about that there. It increases urine osmolality, so increases the concentration of sodium in the urine, right? And decreases the urine volume because the water is getting reabsorbed. So then it will decrease serum osmolality because now the concentration of sodium is decreased compared to the amount of water, right? And then you have increase in serum volume because of equipoise. Both of these will then inhibit the hypothalamus from secreting ADH, right? Also, if you have increase in serum osmolality, that means increase in sodium concentration, you will have ADH released, okay? And then PTH, the storage, if you have enough of, central DI inhibits hypothalamus, so it prevents ADH. I think it's just trying to make sense of it. I'm not sure if that's how it works, or I'm reading this wrong. Okay, if you have SIA, then obviously it's going to activate more ADH and stimulate more ADH release. ADH antagonists, lithium, and nephrogenic DI, right? All of these mean that ADH is not working. It inhibits ADH. However, in nephrogenic DI, that's not what it is, right? It's that even though ADH is being released, it's not being attached to the receptors in your collecting tubules, and thus you have nephrogenic DI. Okay, so let's read about that. So it's characterized by excessive free water retention, euvolemic hyponatremia. That means the volume of sodium stays the same, but since the volume is increasing of the water, it's causing natremia, like a hyponatremia compared to the water. Okay, that's important to know. It's not that the levels or concentration of sodium is increasing or decreasing. It's not the concentration, the level of sodium in the serum is increasing or decreasing. It's just that the water is increasing, making it seem like compared or relative to what the level was before. It's euvolemic now, hyponatremia. Okay, with continued urinary sodium excretion. Okay, urine osmolality is more than serum osmolality. So it's still getting secreted just the same amount as it was before. Body responds to water retention with decrease in aldosterone, okay, and increase in ANP and BNP. Remember, ANP and BNP from CVS, where high blood volume through the heart will cause release of ANP, BNP because their action or function was to decrease blood volume, right? Or BP. And aldosterone's thing is all about reabsorbing sodium to get water in, right? So all of this will increase urinary sodium secretion, Normalization of the extracellular fluid volume. That's how it gets normalized. Uh, and how you get euvolemic hyponatremia. Let me just make sure I'm not confusing you guys. So implies normal sodium stores, right? Normal levels, and a total body excess of free water. Okay, that's what that is. It happens in this as well. Polydipsia, that's when the person drinks a lot of water throughout the day. Uh, you don't have polydipsia, don't worry. You could, I guess, I don't know. But, because I normally go through like 3 liters of water a day, that could be considered polydipsia as well. Okay, euvolemic hyponatremia. Treatment is fluid restriction, the first line treatment. Salt tablets, we give them salt tablets. IV hypertonic saline. Diuretics, ADH antagonists, so that's where this one is. Conivaptin, tolvaptan, and demiclocycline. CIAD causes include, so how could you end up with CIAD? So that's like head trauma or CNS tumor, disorders, ectopic ADH, so small cell lung cancer. It's a paraneoplastic syndrome, right? Exogenous hormones, for example, vasopressin, desmopressin, or oxytocin. Since the body already has it, it's not gonna. It's not that this is being made. It's just that it's coming from outside, and since that's not gonna be regulated by the body, it's gonna have similar effect as CIAD. Lung disease and drugs. For example, SSRIs, that's selective serotonin receptor inhibitors, carbamazepines, and cyclophosphamide. Okay. The important one is paraneoplastic one. You need to know about this one. Okay, now we do DI, primary polydipsia and diabetes insipidus, characterized by the production of large amount of dilute urine with or without thirst. Urine specific gravity is usually less than 1.006. Normally it's like 1.02, I think. But now that it doesn't have that, it has more water, there are less things that's bringing down the specific gravity. When you have more things in the urine, it increases the specific gravity, okay? Compared to the amount of water, okay? Urine osmolality, usually so when they give you this and it sounds less or something like that, if it's less than like, let me actually check the normal range for this. So okay, so that's the normal range. So I said 1.02, that's like in the middle. So 1.005 to 1.003. If it's less than this, then it's considered so if it's less than you're well hydrated. If minimal dehydration is that from 1.01 to 1.02. Significant dehydration is below that as well, and then serious dehydration is below that. Okay. So yeah, when they give you a number that's low like this, that just means that there's more water than there is stuff in it. Okay, and if it's more than the range, then that means that there's less water and more concentration of other things. Okay, that's easier to fix than this. Okay, urine specific gravity less than 1.006. Urine osmolality usually less than 300 milliosmol per kg. Central DI may be transient if damage is below hypothalamic median eminence or in the posterior pituitary. This value, I think they gave it in the urine section of the lab values on UWorld or even steps. In steps they don't section it out like that, you just gotta scroll and see where it is. Okay, 300 milliosmol per kg. Central DI may be transient if damage is below hypothalamic median eminence or in the posterior pituitary. ADH in hypothalamus can still be secreted systematically via portal capillaries in median eminence. So that means even if there is damage here, right? How is ADH still normal? Okay, that's because of capillary network. I think I talked about it. Not sure, but they're like paramedian capillaries, reticular network, right? Over here, mesh-like network, or however you want to say it. And so even if this is damaged, it will still travel down via paramedian capillaries. Okay, so ADH in hypothalamus can be secreted systematically via portal capillaries in the median eminence. Okay, so now we have primary polydipsia, central DI, and nephrogenic DI. Already went over this earlier, so I'll go through it right away. Like faster. Definition of polydipsia is excessive water intake, causes of psychiatric illnesses or hypothalamic lesions affecting their center. Serum osmolality is decreased. Okay, so that means there's less concentration on sodium compared to the water. ADH level is decreased or normal. Right, ADH is not going to be triggered, so it's going to be low, or it's going to stay the normal amount it stays in your body. Water's restriction, water's restriction, significant increase in urine osmolality, so more than 700. We don't really need to worry about what the normal level is. What we look for is that if this increases or decreases from the initial amount it was. Okay, so if it increases, that means the concentration is osmolality is increased, and if it's decreased, then osmolality is decreased. That's what it means, right? And if it increases, that means the concentration is increased, and if it decreases, that means concentration of it is decreased. And then you have to pay attention to concentration of what decreased or increased. Was it urine or serum, right? We don't give desmopressin for this because that's antidiuretic, right? And you already have enough water in your body, so we don't give that. The treatment is just water restriction. That's it. Okay. Then central DI and nephrogenic DI. Decrease in ADH release, right? Let me just draw hypothalamus, ADH, and then you have your loop of Fanley, proximal tubule, descending, ascending, distal convoluted, and then collecting tubule, right? So, hypothalamus, pituitary, and loop of Fanley. Okay. So there's decreased ADH release here, right? So ADH is not being released. Idiopathic causes usually idiopathic brain injury or trauma, hypoxia, tumor surgery, infiltrative disease. So if there was like an adenoma and you got it surgically removed, there's chances that posterior pituitary got removed, right? So what's going to happen to serum osmolality, right? Serum concentration of sodium is going to increase, right? Because the water is getting leaked out. There's no antidiuretic hormone, so there's increased diuresis. So sodium is going to increase in the serum, but what's going to happen in the urine is going to decrease, right? Because all the water is there. ADH level is decreased. Obviously, it's not being made. Then we have water restriction. So what's going to happen when you restrict the water? Nothing. Because it's not about water or anything else. It's about the antidiuretic hormone retaining the water. That's the problem, right? So So water restriction, no change or slight increase in urine osmolality. Okay. Maybe that's because other factors other than ADH that would cause increase in osmolality. There could be shift of sodium intracellular to outercellular and potassium going intracellular. There would be other mechanisms that do that, but it's not going to cause a significant increase. Basically, that's the important thing. So desmopressin administration. Instead of this, we give desmopressin. Right. Keep that red. So instead of ADH, we give desmopressin, which does the same thing. So since ADH can't come and attach to the aquaporins and make more aquaporins, we have desmopressin doing that, right? So it comes out. However, this is not selective. It's not V2 selective, so it does act on V1 as well, but V1 is in the vessels, right? So it's still called vasopressin. So desmopressin, that's DDAVP, is gonna come in and then it's gonna, take in the water again. So central DI is pretty easily treatable, just with that desmopressin. But nephrogenic DI is a little complicated than that. So when you have nephrogenic DI, it's called ADH resistance because no matter how much ADH you have and how much it goes to the thing, there's no receptor to attach to, right? So it's just gonna float around and scratch its head, wondering what's going on. Why is there no door here? So it could be hereditary ADH receptor mutation. Drugs, for example, lithium does this, so you gotta know about that. And demiclocycline. Right? So it could be a patient who's on lithium and she comes in and then says that she's having she's always feeling thirsty and has to go to the washroom a lot. So why is that? It's because lithium causes nephrogenic DI. Okay, it can cause hypercalcemia and hypokalemia as well. Remember, serum osmolality. What's going to happen is the concentration of sodium in the serum is going to increase, so it increases serum osmolality. But in urine, it's going to decrease because all the water is there, and compared to the concentration of solutes, it's going to be less. So decreases serum osmolality there. ADH level normal or increase, right? Because brain's gonna think that ADH is not going over and doing its thing, right? So it's gonna keep making more ADH and sending the signals down. But here, there's already like a crowd of ADH scratching their heads. Okay, desmopressin administration. Again, ADH and desmopressin is the same thing, right? You make that in blue. So desmopressin is gonna come in and then it's gonna be like, okay, I'll take care of it, and then it's like, oh, whoops, and then go back in the crowd and start scratching his head too, because it can't do anything. There's no door. Right? There's no minimal change in urine osmolality. Then treatment here is manage the underlying cause, low solute diet, and HCTZ or hypochlorothiazide. This thing has a paradoxical effect, and that's why we give it, because you'll be like, okay, this person is already leaking out all the fluid it can, why would we give diuretic, right? That should be a question that should arise. But that's because its effect is on this part of the tubule right here, right? But because of that, it actually causes increase in water from proximal convoluted tubule. Okay, so that's why you would give a diuretic in nephrogenic DI, because it causes increased reabsorption of water over here, even though because of its effect on distal convoluted tubule. Okay, that's why you would give a diuretic in nephrogenic DI. because it's not gonna do, any effect over here. So manage the underlying cause: low solute diet, HCTZ, and amyloride and indomethacin. Okay. Uh, no water intake for 2 to 3 hours following. So they're talking about the water restriction test, right? So this here right here. So how is that conducted? So no water intake for 2 to 3 hours, followed by hourly measurement of urine volume and osmolality, as well as plasma sodium concentration and osmolality. And then they're talking about the desmopressin administration. That is, desmopressin, ADH analog, is administered if serum osmolality is more than this. So 300 milliosmol per kilogram. Plasma sodium is more than 145, right? That means the osmolality is increased, and sodium is usually like 132 to 136 or something. So anything more than that, you have increased plasma sodium levels. Or urine osmolality does not increase despite increase in plasma osmolality. Okay. So, or urine osmolality does not increase despite increasing. Okay, so that just means even though there's increase in sodium concentration in the serum, you should see a rise in urine, right? But there's no rise in urine. Why? Because all the water is being leaked out, right? That's why. Moving on, hypopituitarism. So this is about the things that get affected because of pituitary. Okay. So pituitary could be anterior or posterior. So under secretion of pituitary hormones due to non-secreting pituitary adenomas or craniopharyngioma. Okay. You have Sheehan syndrome. Okay, this is an important one. All of these three are important, so know them. Let me do a highlight. Let's highlight that. Okay. For you people with OCD, I'll take care of that. And I'll take care of this. Okay, so Sheehan syndrome, ischemic infarct of pituitary following severe postpartum hemorrhage. Pregnancy-induced pituitary growth increases susceptibility to hypoperfusion, usually presents with failure of lactate, absent maturation, and cold intolerance. Okay. So what happens during pregnancy is you have this pituitary, right? That's the anterior, and this is like the posterior. Okay. Or either or. Okay. And in pregnancy, what happens is it demands more, blood volume and all that stuff. So antidiuretic hormone increases and all that, and also FSH and LH and all that stuff. So this thing becomes bigger. Okay, because it goes under hyperplasia, right? Because of pregnancy, and it's using up all the hormones it's secreting out, so it's being well taken care of. Okay, until pregnancy is induced, right? So after labor happens and everything is done, what about this? This is still big, right? It doesn't shrink like your stomach after pregnancy. So this thing is still gonna, and this thing is being supplied by blood, because there's increasing blood volume and all that stuff, right? And there was demand. So now there is no demand, but this is still secreting, and all the blood is also reduced, right? So now what's gonna happen is this is gonna get ischemic. Okay. First of all, it was only getting limited blood supply to pituitary, right? Maybe there was like one artery for explanation's sake. So it was supplied by this when it was small, right? it was small, it was supplied by this. But even when it got bigger during pregnancy, it was still supplied by the same. And it's not like new arteries were made to supply it. So now that, however, there was increase in blood supply, right? Blood volume and all that. So it was being taken care of. Now that pregnancy is done, blood supply decreases. It's still one artery, so it's now gonna, not be able to keep up with the demand as it used to. So now it's only supplying this bit. So all of this area is gonna go under ischemia, right? So ischemic infarct of pituitary following severe postpartum hemorrhage, or that. Okay, so it's not that pregnancy. It was postpartum hemorrhage. So when you go under postpartum hemorrhage, there's decrease in blood volume reaching the pituitary. Okay, and this thing is already big, right? So pregnancy-induced pituitary growth will cause increase in susceptibility to hypoperfusion. Okay, so again, same thing. So hypoperfusion because of decrease in blood, because of severe postpartum hemorrhage. So usually presents with failure to lactate. It's not that this will show up like it does if you had internal bleeding or something, right? How it will show up is that the person is gonna come and they're like, okay, I'm not lactating, so what's the problem? And you're gonna be like, oh, I know this one. It's gonna be edema, adenoma, right? Not edema, adenoma. But no, it's not adenoma, because you're gonna think it's this one, non-secreting adenoma, but it's not that. You gotta think about, okay, this person was that, and she had a complicated pregnancy or labor, right? So she probably went under this. So failure to lactate, and absent menstruation, or cold intolerance, right? Because TRH is decreased, or TSH is decreased rather, and that causes hypothyroidism, and hypothyroidism is known for cold intolerance, right? Okay, so that's called Sheehan syndrome, or Sheehan's no pituitary, kind of like that. Sheehan's no pituitary. Okay, empty cella syndrome, atrophy or compression of pituitary. Okay, so you just think of this pituitary. I'll just keep that for. Pituitary actually sits at on the sella tunica, right? That thing right there. So call this the sella tunica, right? Sella tunica. So what is empty sella tunica? That rather than having this, there's nothing there, right? Why? Because this became atrophied. Okay, now there's nothing there. So atrophy or compression of pituitary, okay, that could work too. Atrophy or compression of pituitary, which lies in the sella tunica. Often idiopathic, common in obese female, and associated with idiopathic intracranial hypertension. Okay. All of these are gonna have hypopituitarism symptoms. Then you have pituitary apoplexy. That is sudden hemorrhage of pituitary gland, often in the presence of an existing pituitary adenoma. Usually presents with sudden onset, severe headache, visual impairment, for example, bitemporal hemianopia, diplopia due to cranial nerve 3 palsy, and feature of hypopituitarism. Right? So when you have headache and bitemporal hemianopia, or hemianopia by itself, it's going to be usually unilateral, the one I'm talking about. So if you have unilateral hemianopia and or blindness or visual impairment along with severe headache, it's usually a sign of vasculitis. okay, or giant cell arteritis, because that's what its symptoms are. But when it's something bitemporal, it's affecting bitemporal. There's only one spot, optic chiasm, right, where the fibers cross, both of them, and the damage has to be somewhere here, right? And what's there? You have pituitary right there, right? So that's why bitemporal hemianopia, you should think of this area, and then when you think of this area, you should think of something's wrong with the pituitary. Okay, so pituitary apoplexy, sudden hemorrhage of pituitary gland, often in presence of an existing pituitary adenoma. There's like another thing that's on here, adenoma that got bigger or something. Okay. Pressing into this. Okay, so this adenoma is going to press onto this, and that's causing diplopia due to third node palsy. Okay. That's the oculomotor palsy as well. Okay. So it could be this, or it could be the palsy, either or. And features of hypopituitarism, it could be because of brain injury and radiation. Okay. Treatment is hormone replacement therapy. So you just give them all the hormones that pituitary makes. So glucocorticoids, thyroxine, sex hormone, steroids, human growth hormone. Okay. Acromegaly is excess growth hormone in adults, typically caused by pituitary adenoma. Findings are large tongue and with deep furrows. So the person I think of is the great Kali. Right, this guy. So think of him and don't get scared. Large tongue with deep furrows, frontal bulging, and coarsening of facial features with aging, and deep voice, diaphoresis, excessive sweating, impaired glucose intolerance, so insulin resistance, hypertension, left ventricular hypertrophy, diastolic heart failure, and which is the most common cause of death. Sorry, right? Diastolic heart failure. That's when your ejection fraction is preserved or reduced. It's preserved. Diastolic heart failure. Okay, because systolic is functioning great, so that's why it's preserved. We did that yesterday, or day before yesterday. Okay, diagnosis is increase in serum insulin-like growth factor 1, failure to suppress serum growth hormone following oral glucose tolerance test, pituitary mass seen on brain MRI. Treatment is pituitary adenoma resection. If not cured, treat with octreotide, which is a stomatostatin analog, right? Or pigvisocement, growth hormone receptor antagonist. That's what it is. Or dopamine agonist, for example, cabergoline. There's increase in growth hormone in children, for which causes gigantism. Increase in linear bone growth. This is an easy one to understand. Like they'll give you all of these features that's going to remind you of the Greek Kali, right? Frontal bulging, coarse facial features. The hands are going to be broad, and X-ray is going to show like broad fingers or long fingers. Okay, all that stuff. If they're young, then they're going to have gigantism. If they're older, they're going to have acromegaly. Because why does acromegaly happen and not gigantism in older people? Because your bones are fused, right? Epiphyseal plates or your growth plates are fused. So now it can't have linear growth. So what's it going to do? It's going to cause horizontal growth or broad. So that's why you have broad face and like broad fingers and all that stuff. Okay. Hypothyroidism versus hyperthyroidism. Hypothyroidism and hypothyroidism, metabolic, skin hair, ocular, GIT, musculo, repro, neuro, CVS, and lab findings. Okay, hypo. This is an important one. Like you'll have someone coming into your clinic and telling you that this person has cold. She's feeling colder or he's feeling colder. Okay, there's decrease in sweating and there's going to be weight gain. So they have gained weight over the past month, like 3 to 4 kilograms or pounds or whatever, and without even trying to gain weight. Right? Yeah, so that's going to be like the way they usually show it. But they also use any of these. They can use any of these either as well. So decrease in BMR, which causes decrease in calorogenesis, hyponatremia, decrease in free water clearance. Skin hair, this is dry, cool hair skin. So they'll have dry skin, cool skin. Yes. Due to decrease in blood flow, so it's going to be coarse, and this is the buzzword, brittle hair. If you hear brittle hair, that can only mean hypothyroidism. Okay. Because remember, scurvy has what kind? It has cork screw hair and scurvy or whatever. Okay, so it's going to look like that. No. I think they'll show you that one. They'll show you something like this. A corkscrew hair. That's scurvy. Okay, so when they say brittle, you always think of hypothyroidism, especially if it's an adult. If it's a child, you can think of like marasmus or something like that, or malnutrition. Okay, diffuse alopecia, brittle nails, puffy face, and generalized non-pitting edema. This is also a giveaway, generalized non-pitting edema, because normally we deal with pedal edema, or that's pitting, right, for heart failure, or because there's nephrotic syndrome, also known as mixed edema. That's this thing. Due to increase in glycosaminoglycans and interstitial spaces, which causes increase in osmotic pressure, which causes water retention. Increase in osmotic pressure outside causes increase pull of water, right? They pull the water, osmotic pressure. Okay. Hyperthyroidism. So how does that happen? It's nephrotic. Remember, albumin gets flushed out, right? Or in diabetes, there's hypofiltration of albumin. So oncotic pressure is decreased on the in the plasma, but on the outside interstitial fluid, it stays the same. So then it starts pooling, and the net pull effect happens because of that. Okay, so water retention. In ocular, you have periorbital edema. That's C. There. Okay. Then you have gastrointestinal, or where you have constipation, decrease in GI motility, decrease in appetite. Okay. There's decrease in appetite, but there's still weight gain. Okay, so you need to know the difference over there. Musculoskeletal, hypothyroid myopathy, proximal weakness, increase in creatine kinase, carpal tunnel syndrome. You can have myedema, small lump rising on the surface of the muscle when struck with a hammer. Reproductive, abnormal uterine bleeding, decrease in libido, infertility, neuropsychiatric, hypoactivity. They're feeling tired, they can't do much things around the house, they're fatigued easily, they can't climb stairs as many as they could before. Weakness, depressed mood is important. This is one of the things that you will see like in your practice as well. Decrease in reflexes, delayed or slow relaxing cardiovascular, there will be bradycardia, dyspnea on exertion, decreased cardiac output, right? So all of these things should paint you an image of a person who's like tired all the time. They're obese even though they're not eating anything. They're cold even though they're fat, right? Something like that. So when you read it, this should come to your mind immediately. Okay. Labs: increase in TSH if primary, decrease in free T3 and T4. Okay, because that's the defining feature of hypothyroidism, right? Decrease in T3, T4. So if you have decrease of this, you will obviously have increase of this, right? Hypercholesteremia due to decrease in LDL receptor expression. Hyperthyroidism, metabolic, heat intolerance. Obviously, this is talking about non-treated hypothyroidism, right? If it's treated, you're not going to see this, obviously. But this is symptoms for someone who has hypothyroidism that is not being treated. Okay, so in real life, don't be like, okay, this guy has hypothyroidism, but he's not fat or this. It's because he's being treated for it, or she's being treated for it, right? So hyperthyroidism, it's heat tolerance, increase in sweating, weight loss, increase in synthesis of sodium, potassium, ATPase, increase in basal metabolic rate, and increase in calorigenesis. So this is going to be opposite of this. They're going to be hyperactive. They're going to have, instead of edema in the eyes, ocular, right, periorbital edema, they're going to have exophthalmos, and instead of being, having weight gain, they'll have weight loss. Decreased sweating, instead of that, they'll have increased sweating, instead of cold intolerance, they have heat intolerance, right? Yeah, 9 minutes. Metabolic and that. Okay, so in skin, it's going to be warm and moist due to vasodilation. Fine hair, it's called onycholysis. Oh, okay, it's talking about this thing. The nails. Okay, so this thing right here, or this thing right there. Peritibial myxedema and Graves' disease. Ophthalmopathy and Graves' disease including periorbital edema. So you have that, never mind. But you have exophthalmos. This is the one they will talk about. You have lid lag in Graves. That's important, right? You also have like ptosis or something. No, you have tiring of. Never mind. So Graves' disease, you have lid lag, but in like myasthenia gravis, they're tired of keeping the eye. They can't keep the lids open, basically. Okay, so eyes are tired. So lid lag, retraction, increase in sympathetic stimulation of levator pectoralis superior and superior tarsal muscle. Gastrointestinal, hyperdefecation or diarrhea, increase in GI motility, whereas here you had decrease of constipation. You have increase in appetite. Even though they're eating a lot, they're not gaining the weight. Musculoskeletal, thyrotoxic myopathy, proximal weakness, normal CK, osteoporosis, increase in fracture rate. T3 directly stimulates bone resorption. Reproductive, abnormal uterine bleeding, gynecomastia, decrease in libido. That's similar to this, libido and infertility, right? For neuropsychiatric, you have hyperactivity, restlessness, anxiety, insomnia, fine timer, due to increase in beta adrenergic activity and increase in reflex. So in your practice, this is usually going to be the trigger for you to think it's thyroid. That they're like, panic, they're having panic attack, they have palpitations for like 15 minutes or something. They think they're going into like cardiac arrest, but by the time EMTs show up, their heart rate is like back to normal or something, right? So you're gonna think of this for hypothyroidism, basically. Also, it could be a side effect of hypothyroidism drug. They, it's even though their dosages are calculated, It could be that they're having toxicity of the doses because they're taking, even though they're taking the same amount they were before, but now they don't need it as much because it takes like 4 to 6 weeks to have the effect. So after the effect starts happening, it might be that they don't need it as much. So then they're gonna start having symptoms of hyperthyroidism. Okay, that could be a thing too. So you gotta look out for that. Cardiovascular. Oh yeah, so increase reflexes as well. Okay, so cardiovascular tagging. How much time do I have? 6 minutes. Tachycardia, palpitation, dyspnea, arrhythmias, for example, atrial fibrillation, chest pain, and systolic hypertension, due to increase in number and sensitivity of beta-adrenergic receptors, increase in expression of cardiac sarcolemmal ATPase, and decrease in expression of phospholipid. Okay, labs again, you have increased T3, so decrease in stimulating hormones, and decrease in LDL, HDL, and total cholesterol. You should know these. There's decrease in LDL. There's increase in cholesterol because of decrease in LDL receptor expression. What do? They recycle LDL, right, or all that stuff. They uptake LDL. It was the PSCK9 one that inhibits this, so it takes more of LDL. Right? That was a anti-lipidemic drug, but here you have decrease in LDL and HDL and total cholesterol as well. Okay. Done with that. And over here, hypothyroidism. For Sheehan syndrome, it's going to be failure to lactate. That's how you're going to figure it out. And it can be asymptomatic up to 2 weeks, so it can happen after 2 weeks, right? And for pituitary apoplexy, they'll say acromegaly. They'll give you a clinical picture of acromegaly, and then sudden features of hypopituitarism, right? For findings in acromegaly, they're gonna say that this person had increase in glove size or increase in head size due to frontal bossing or broadening of the fingers. Okay. Over here in reproductive, you know how it has in hypothyroidism you get gynecomastia here, as well as in hyperthyroidism you get gynecomastia as well, right? So you can have it in both, even though it's not written here. But the mechanism of getting it's different. For hypothyroidism, it's due to increase in TSH due to increase in TSH, and TSH is structurally similar to prolactin. That's why you get gynecomastia in hypothyroidism. And in hyperthyroidism, it's because there is an increase in conversion of testosterone to estrogen, and that's how you get gynecomastia here. Okay. And that's it. Now on to hypothyroidism. Hashimoto thyroiditis, also called chronic autoimmune thyroiditis, most common cause of hypothyroidism in iodine sufficient regions, associated with HLA-DR3, right? That's one number. That's 2 letters, so that's MHC2. Associated with HLA-DR3, it differs in ethnicity. Increase in risk of primary thyroid lymphoma, typically diffuse large B-cell lymphoma. Findings are moderately enlarged non-tender thyroid. This is important. It's non-tender. These are like the buzzwords for these things. Not really buzzword, but that's how you differentiate it, because some of them are going to be tender, like this one. Okay, very tender thyroid. So one, they're going to give you that it's decrease in T3 and T4 levels, or something like that, so it's hypothyroid. Then within hypothyroid, you got to figure out which one it is. So this one is non-tender, this one is tender, this one is non-tender again, and then these two we can figure out later. Okay, so non-tender, moderately enlarged, may be preceded by transient hyperthyroid state or toxicosis due to follicular rupture and thyroid hormone release. Serology, it's positive for anti-thyroid peroxidase, right? And we know what thyroid peroxidase does. It was involved in oxidation of iodine, organification, and also the coupling, right? So if there are antibodies again or antigens against that or antibodies against that, sorry, antibodies are against this, then you're gonna have decrease in uh, making of thyroid, right? Or T3 and T4. Okay, and that's why you have hypothyroidism for that. So antimicrosomal and antithyroglobulin antibodies. Histology, you should know what Hurdle cells are, and this is what that looks like. It looks like an inclusion body, doesn't it? It's a lymphoid aggregate with germinal center. Okay, no, it's not that. Hold on. Let's see. So that's the lymphoid follicle, and this is the Hurdle cell. We should know what the follicles of thyroids are. Yeah, this is follicle. This is parafollicular cells, right? And these are the parafollicular or C cells in the middle, right there. Okay, these ones are not attached to the follicular cells, and this ones are. And you gotta figure out this. So that is colloid. That's a follicle. That's follicular epithelium, and you need to know how to recognize these because you'll get photos of these and without a description, and you have to figure out that it's a thyroid specimen. A couple more. So that's the C cell, okay, in the middle. It's right there. So that would be one as well. This is colloid. These are principal cells. Okay. Cool. Okay. So Hurdle cell, that did not help, but they might just tell you there are Hurdle cells in it, and that will just give it away. H for Hashimoto, right? But they probably won't. But they might give you this lymphoid aggregate with germinal centers, and that should give it away. Okay. So there's one of that. Okay. So these little cells with that look like faces, they would be Hurdle cells, I guess. Okay. And then follicle center is right there, and these are the lymphoid aggregates right here. It looks like a cheetah print, I guess. Right. If you see it like that, it's because of the lymphoid aggregates. Because we saw what normal thyroid looks like, right? Hurdle cells here, lymphoid aggregates, follicle. Okay. Then we have postpartum thyroiditis. Now it's important to know what this is because it's really hard to figure out in the question stem. So postpartum thyroiditis, this is mild self-limited variant of Hashimoto thyroiditis, arises less than 1 year after delivery. Okay, so after delivery and less than 1 year. So if the thyroid problems persist beyond 1 year, it's not going to be postpartum thyroiditis. Okay. So for this, it occurs in 3 phases. The first phase is hyperthyroid phase, which is between 1 to 3 months. It really there's a release of preformed thyroid hormone in this. Okay. Then there is phase two. Uh, that is hypothyroid phase. So first one was hyperthyroid because there was release of preformed thyroid hormone from the follicles. Then the second one is hypothyroid phase, which is from anywhere 4 to 8 months. This is because of depletion of the preformed thyroid hormones, right? And there's emptying of the stores. And then there's phase three. This is called the recovery phase or return to euthyroid state. Okay. Not all three phases occur in all patients. That's important to know for postpartum thyroiditis. Okay. So how would you figure out it's this one? You'll have an elevated you will have an elevated T3 or T4 because of phase 1, and there will be suppressed TSH as well. Um, and the giveaway will be that there is a diffuse non-tender goiter. Okay, so non-tender goiter and with an increase in T3, T4, and suppression in TSH should give you an hint you towards this Hashimoto thyroiditis or postpartum thyroiditis. Okay, on to subacute. Again, this is non-tender. Okay, important to know. No pain. Subacute granulomatous thyroiditis. Okay, also called the Endocrine thyroiditis. This is important. You know this because this is usually how we refer to it. We don't refer to it as subacute granulomatous thyroiditis. We refer to it as Endocrine thyroiditis. Okay, it's usually a self-limited disease. Natural history is transient hyperthyroidism, then euthyroid state, and then hypothyroidism, and then again euthyroid state. Often preceded by viral infection. So that's a giveaway right there. If there is pain, okay, so findings are increase in erythrosedimentary rates, sedimentation rates, jaw pain, very tender thyroid. Decor vein is associated with pain. Histology is granulomatous inflammation. So this would be your giveaway. If they tell you that there is a granuloma or granulomatous inflammation or something like inflammation even, or pain in thyroid, or pain in the jaw, that should give you a hint that it's dequervin thyroiditis. Okay. Increase in ESR, increase in since it's inflammation, there'll be increase in CRP as well, and when they give you you check if it picks up on radioiodine uptake, so there will be decreased radioiodine uptake as well with this one. Okay, why? Because it's hypothyroidism, right? Yeah, so increase in ESR, increase in CRP, but decrease in radioiodine uptake. Granulomatous inflammation is just giant cells. Okay, on to radial thyroiditis, also called invasive fibrous thyroiditis. Most may be associated with hemoglobin G4 related disease, for example, autoimmune pancreatitis, retroperitoneal fibrosis, and non-infectious aortitis. A variant of autoimmune thyroiditis or part of systemic fibrosing disorder. Hypothyroidism occurs in 1 out of 3 of the patients. Fibrosis may extend to local structures like trachea and esophagus. It mimics anaplastic carcinoma. Findings will be slowly enlarging, hard, rock-like, or fixed, non-tender thyroid. So that's the giveaway. 1, it's non-tender. Then you got to differentiate between radial thyroiditis and Hashimoto thyroiditis, right? And so This one is enlarged, right? Moderately enlarged, and this one is slowly enlarging. However, this one is hard, rock-like, and fixed, right? The way I remember it is, there's a porn star named Riley Reid, so that's how I remember Reid, right? So you can remember that and that from that, or yeah. So that's how I remember the findings. Because Reid, you gotta remember Rydal that this one is the one with the hard rock like. Because non-tender, it can be either this or Hashimoto. Hashimoto is the most common one, and that's the one that they test you on majority of the time. But this can be asked. Okay, so you need to know about that. Then they have, yeah. So histology is going to be thyroid replaced by fibrous tissue. This can be also a giveaway, right? Fibrous tissue and inflammatory infiltrate, so you'll have CRP increased in this as well. But when they give you fibrous tissue, that should be good because you don't have fibrous tissue in this. You have hurdle cell, but lymphoid aggregates with the germinal center, right? You need to learn to remember these because this is where the pathology comes in handy. So lymphoid aggregates with germinal centers is going to be Hashimoto. With granulomatous inflammation or giant cells, it's going to be subacute granulomatous thyroiditis or Dick-Queren thyroiditis. For Rydal thyroiditis, it's going to be thyroid replaced by fibrous tissue and inflammatory infiltrate. Then we have congenital hypothyroidism. Okay. This one is like the cretinism, right? So formerly called cretinism. So most commonly caused by thyroid dysgenesis, abnormal thyroid gland development. For example, agenesis or hypoplasia or ectopy of thyroid gland. Or dishormonogenesis, abnormal thyroid hormone synthesis. For example, mutations in thyroid peroxidase. In iodine sufficient region, okay, so it affects. Okay. For this, they have a classic presentation, so you should let's just look at that. Okay, so this is what they look like. Okay, I'm not gonna put that one. Okay, let's do this one. Okay. So, or that you can think of. Okay. So it's gonna be pot-bellied, right? You see the pot-belly. They're going to be pale. You can see they're pale here. Puffy face. You can see the puffy face with uh, protruding umbilicus. So okay, it's hard to see in that, but there's protruding umbilicus and protuberant tongue, right? Like right there. So she looks a little pale, right? Their pot belly over here, and you would see it here too. Puffy face. You can tell there's a puffy face. That's a puffy face compared to that. Okay. Protuberant tongue and poor brain development. Okay, that's important. Nowadays, you don't see this anymore because there was like an initiative with the salt industry where they infuse iodine inside the salt. So now this is pretty rare, but it still happens. Right? So formerly called cretinism. Other causes are iodine deficiency, most common cause worldwide. Typically presents with goiter, iodine excess, or drugs, which are amiodarone lithium, or non-thyroidal illness syndromes, also called the euthyroid 6 syndrome. There's decrease in T3 with normal or decreased T4, and TSH in critically ill patients. We already talked about this one. That's the most important one out of these. Okay, you need to know about lithium. Lithium causes hypothyroidism. Amiodarone as well is I think. Damn, I forgot what this was used for. Let me just real quick look into that. Was it AIDS or HIV? No, it was CVS drug. Right? No? Yeah, CVS drug. Okay. Also called euthyroid 6 syndrome. That's a goiter right there. Okay, and that's a lymphoid aggregate. So, where's D? Nope, that's not lymphoid aggregate. That's thyroid replaced by fibrous tissue and inflammation. Okay. Yeah, I'll just point to it and you guys figure it out. For C, it was granulomatous inflammation, right? So, yeah, right there. I pointed to it. You guys figured out. B and lymphoid aggregates of general center. For these, it's really not helpful to look at these photos, but what helps is you remembering that lymphoid aggregates is Hashimoto, granulomatous or giant cells or anything like that in the question stem. They're pointing towards subacute granulomatous or Dickworm thyroiditis. If they say the goiter or the thyroid is rock hard, fixed, enlarged, and it's not painful, right? It's gonna be this. If very tender thyroid. That's the important one for this. Okay. For congenital, they'll basically give you a picture of this, that this person has a pot belly, puffy, or they have a protruding tongue with like something like that. I forget how they explain it, but you'll figure it out. Now that we did hypo, we're going to do hyper. Hyper is Graves' disease, right? Already explained what that was over here. Just bring that back. Okay, so most common cause of hyperthyroidism. Thyroid stimulating immunoglobulins, immunoglobulin G, can cause transient neonatal hyperthyroidism, which is type 2 hypersensitivity, right? That's antigen antibody interacting. So stimulates TSH receptors on thyroid hyperthyroidism diffuse goiter. Okay, so stimulates TSH, right, on thyroid. Instead on thyroid, right? So causes hyperthyroidism and diffuse goiter. Dermal fibroblasts, pre-tibial myxedema. So you'll see everything that we read about under hyperthyroidism, signs and symptoms. So pre-tibial myxedema and orbital fibroblasts, grave orbitopathy, activation of T cells. This leads to lymphocytic infiltration of retroorbital space. Okay, this is important. This is why you get exophthalmos. Okay, it's because of activation of T cells, which then have the lymphocytic infiltration of retroorbital space behind the eyes. Then there is increase in cytokines, for example, tumor necrosis factor alpha and interferon gamma. All of these will increase fibroblast secretion of hydrophilic GAGs or glycosaminoglycans, and these will lead to increase in osmotic muscle swelling. And this osmotic muscle swelling and muscle inflammation and adipose count lead to exophthalmos. Okay? So that's why it's important to know this whole mechanism. Often presents during stress, for example, pregnancy, associated with HLA-DR3 and HLA-B8. Histology is tall, crowded follicular epithelial cells, and scalloped colloid. Okay. Yeah, no notes on that. So, again, histology, this is what they'll describe. Scalloped colloid. See what that is. So that's scalloping, this is normal, okay, and this is hyperplasia. Cool. Notice how you don't see the cheetah print here. Okay, there it is. This is probably not that. They didn't explain what this is, so. Yeah, no cheetah print. You'll see a scallop. These little things right here. That. Over here, 1, 2, 3, 4. Okay. So that's what scalloped colloid are. They have crowded follicular epithelial cells and tall. Okay, so graves. So you need tall people to dig a grave. Okay. With a scalloped, what do you call that thing? The tool you use to dig graves. And then crowded follicular epithelial. Shovel, yes, shovel. That's what I'm saying. Scallop shovel, right? You need a tall person with a scallop shovel to dig a grave, and then you have crowded follicular epithelial cells, right? Epithelial cells could be like the skin, crowded because there's multiple people in the grave. Follicle. I don't know. I'm going dark, but you can go light. But remember these histology findings for graves. Next, toxic multinodular goiter, focal patches of hyperfunctioning follicular cells distended with colloid working independently of TSH. Due to TSH receptor mutations in 60% of cases, there is increased release of T3 and T4. Their hot nodules are rarely malignant though. Okay. What hot nodule means is that it's active, and cold nodule means that it's not active. It's not secreting thyroid hormones. Okay. So these are focal patches. So see, it's a thyroid. Right? You have a thyroid right here. And in that you have some areas in which there's increased amount of thyroid being made right there, maybe there. Right? So these are the toxic multinodular goiter. So focal patches of hyperfunctioning follicular cells. So these cells over here are hyperfunctioning. So distended with colloid working independently of TSH. So these cells don't listen to anterior pituitary. Okay, they function on their own. This whole area is listening to pituitary, but not these multinodular goiters, and that's why they're toxic, because they can't work alongside with other follicles. Due to TSH receptor mutations in 60% of cases, increase in release of T3 and T4, hot nodules are rarely malignant though. Okay. Thyroid storm. Uncommon but serious complication that occurs when hyperthyroidism is incompletely untreated, and then treated or untreated, and then significantly worsens in the setting of acute stress such as infection, trauma, or surgery. It presents with agitation, delirium, fever, diarrhea, coma, and tachyarrhythmia, which is a cause of death. Right. May see increase in LFTs, ASD, and ALTs. Treat with the 4 P's. So beta blockers, which is propranolol, propylthiouracil, glucocorticoids, and potassium iodide to do the Wolff-Chekhov effect, right? So iodine load decreases T4 synthesis via this effect. Low iodine. You should remember these drugs from the diagram above. Right, so treat with the 4P. So these things with PTU and methimazole, you can stop that. You can stop this with 5-deiodinase, PTU, beta blockers, corticosteroids, and all of that work here as well. So you have increased T4, but no T3. T3 is the active form of thyroid, right? That's how everything works. So when you don't have T3, this will just make reverse T3, and reverse T3 is inactive, remember? And yeah, so done with that. Again, thyroid peroxide oxidation, organification, and coupling reaction. Then we have Jode-Basedow phenomenon. That's iodine-induced hyperthyroidism. Okay, this is the one I think where, okay, we'll see. Occurs when a patient with iodine deficiency and partially autonomous thyroid tissue, for example, autonomous nodule, is made iodine replete. Can happen after iodine IV contrast or amiodarone use. So it's opposite of Volkschakov effect. So this is when you're given this thing, iodine IV contrast, and then they start having increased amount of T3, T4 levels. After some kind of contrast scan or something, they start having thyroidism, hypothyroidism symptoms. Then it's called the Jode-Basedow phenomenon. Causes of goiter: smooth and diffuse, Graves' disease, Hashimoto thyroiditis, and iodine deficiency, TSH secreting pituitary adenoma. Okay, nodular toxic multinodular goiter, thyroid adenoma, thyroid cancer, and thyroid cyst. So all of these things can cause goiter. Smooth and diffuse ones are these. Okay, so they'll give you this in the question stem, that there's a smooth goiter or a diffuse goiter, then you gotta figure out which one is. But this one it won't help you out that much because it could be Graves or it could be Hashimoto. What it's not gonna be is toxic multinodular goiter or thyroid cancer, right? Those are the ones they usually test you on. So it's not gonna tell you if it's hyper or hypo. The levels will, right? And if there are some parts that are hot and some parts that are cold, then that's going to be your toxic multinodular goiter. Cool. Understand what thyroid storm is. Know about Graves' disease, definitely. Also remember, it interacts with the thyroid stimulating glands, or like follicular glands, sorry, directly, and it doesn't deal with hypothalamus and pituitary. So their levels, TRH and TSH, are going to be low. And this is thyroid globulin, sorry, TSI, so thyroid stimulating immunoglobulin. Okay. And it's this IgG. That's the type it is. Okay, it's specific. Okay, and that's about it. We can move on to thyroid adenoma. For thyroid adenoma, it's a benign solitary growth of thyroid. Most are non-functional or cold on radioactive iodine scan. Can rarely cause hyperthyroidism via autonomous thyroid hormone production. It could be hot or toxic. Okay, so it wasn't this one that I was talking about, it was this one. This one's just hot at some places. but this one can be hot or cold. Okay, and it's benign. Most common histology is follicular, so like that. Easy to make out now. Absence of capsular or vascular invasion, unlike follicular carcinoma. Okay, so that's why this is benign. A malignant one will have capsular or vascular invasion, and that's a follicular lymphoma, right? So let's learn about that. Look there. Thyroid cancer. Typically, these are important because they test you on all of these, so understand them. Okay. Thyroid cancer. Typically diagnosed with fine needle aspiration, treated with thyroidectomy. Okay. So you have superior thyroid artery over there. You have a vein over here. You have the superior laryngeal external branch over there, going above from the north pole of that, and into this, and that's the thyroid gland. Right here, you have the covering of it. Right, so you have cricothyroid. You have inferior pharyngeal constrictor muscle, sternohyoid muscle right there. You have cricothyroid muscle over there, and cricopharyngeus over here. Okay. You should know this anatomy of thyroid. Okay. So typically diagnosed with fine needle aspiration, treated with thyroidectomy. Complications of surgery include hypocalcemia due to removal of parathyroid glands, transection of recurrent laryngeal nerve during ligation of inferior thyroid artery, leads to dysphagia and dysphonia or hoarseness. Right, so transection of recurrent laryngeal nerve. Hold on, I have a photo. Let me send it here. Okay. Okay, so you have superior laryngeal nerve right there. It's a weird ass diagram, I understand that, but try to keep up, okay? So internal laryngeal, uh, right there, supraglottic sensation, that's what it carries. Then you have external laryngeal right there, the nerve. It supplies the cricothyroid, okay? So cricothyroid is right there. Okay. Then you have left vagus and the right vagus going down all the way from here to here, from here to here. Okay. You have left recurrent laryngeal right there, so it's coming down from here and going around the aorta, under the aorta, aortic arch, and then going back up. Okay. So this will supply to your posterior cricothyroid, lateral cricothyroid, oblique arytenoid, transverse arytenoid, and thyroarytenoid. Okay, these are your um, muscles that we were talking about. These, but just in more details. Okay. So when you're removing the thyroid from here, what happens is there is a chance that you can there can be a transaction of recurrent laryngeal nerve. Okay, so that's right. This one, recurrent laryngeal, from here to here. All that just to show you that. Okay. Also, I wanted to go over my notes. So, okay. Again, typically diagnosed with fine needle aspiration, treated with thyroidectomy. Complication of surgery include hypocalcemia due to removal of parathyroid glands, transection of recurrent laryngeal nerve during ligation of inferior thyroid artery. Right, we looked at that. No, we didn't. There's no inferior one. It's right there. Would be your inferior one. So inferior thyroid artery leads to, so this can lead to dysphagia and dysphonia or hoarseness, right? Why do we ligate it? It's so that you don't get internal bleeding or like all the bleeding from cutting open your thyroid, right? Okay, and injury to external branch of superior laryngeal nerve during ligation of superior thyroid vascular pedicle. So superior thyroid would be, I guess, right there. Okay, probably under it. Somewhere here. Not sure. Okay, so an injury to the external branch of superior laryngeal nerve during ligation of the superior thyroid vascular pedicle. So for this, you need to know about the extrinsic muscles and intrinsic muscles as well, and then they'll tell you that they were working at this intrinsic muscle. So I think it's like cricohyoid or something on top, right? Uh, Constrictor muscle is the cricohyoid. Okay, so that's your cricothyroid, and cricopharyngeus is down here. So they'll tell you that they were working on either that or like something up here, like your constrictor muscles or something. And then they'll tell you that the nerve passing through there was ligated and accidentally damaged during this whatever they were doing procedure. So then you have to figure out where that muscle is, and then you have to figure out which nerve goes through it, and that's the nerve that got damaged. It's either going to be superior or it's going to be recurrent laryngeal. Okay, recurrent laryngeal or the superior laryngeal nerve during ligation of superior thyroid vascular pedicle may lead to loss of tenor, usually noticeable in professional voice. Okay, or professional voice users. So you can think of professional voice users or like professional singers having a superior voice. So that's what gets affected. So superior laryngeal nerve was the one that got damaged there. All us laymen have the lower one, so that's going to be recurrent laryngeal nerve during ligation of inferior thyroid artery. Okay, this is a good one to remember. The papillary carcinoma, the one way you remember is Pappy and Mama adopted Orphan Annie. Orphan Annie was a cartoon, and her eyes resembled this. Little Orphan Annie. Okay, so those are the eyes. Uh, Creepy. But yeah, so most that's what the eyes look like, right? So that's where it comes from. Those are called the Orphan Annie eyes. Okay, so most common empty appearing nuclei with central clearing. Orphan Annie eyes. Somoma bodies are seen, and you have nuclear grooves. Pappy and Moma adopted Orphan Annie. So Pappy for papillary carcinoma, Moma for Sumoma bodies. So if you see Sumoma bodies with a nuclei with a central clearing, it's meant to be this. Okay. They'll tell you that there's a goiter or something there, so that will tell you that they're talking about thyroid and maybe cancer. Right. There's an increased risk with RET or PTC rearrangements and BRAF mutations. Okay, and then childhood irritation. Papillary carcinoma most prevalent, palpable lymph nodes, good prognosis. Okay, papillary is most prevalent. You have palpable lymph nodes with this one, but the prognosis is pretty good. Okay. Now we're talking about the follicular carcinoma. That's the one we were differentiating over here, with the absence of capsular and vascular invasion with thyroid adenoma. So how do you differentiate between the two? In follicular carcinoma, it's a good prognosis. It invades the thyroid capsule and vasculature, unlike the follicular one. Uniform follicles, hematogenous spread is common, associated with RAS mutation and PAX8 and party translocation. I call that party, but it's PPR gamma translocation. Fine needle aspiration cytology may not be able to distinguish between follicular and carcinoma. Follicular adenoma and carcinoma. Okay, so papillary is orphan any eyes and all that. Follicular, it invades the follicles in the carcinoma, but if it's just the adenoma, then it doesn't invade it. Okay. Then you have medullary carcinoma, and this one is also important. For parafollicular C cell, produces calcitonin, sheets of polygonal cells, and an amyloid stroma. They'll give you this, it stains with Congo red. So you have to remember Congo red for C cells, which are parafollicular. We figured out what those were, right, when we're looking at the photos. So C cells produce calcitonin. That's the opposite of PTH, so it decreases calcium in the blood. Sheets of polygonal cells in amyloid stroma, and it stains with Congo red. It's associated with MAN2A and 2B. Okay, so RET mutation. And then you have undifferentiated anaplastic carcinoma. Okay. For follicular, they actually use the words sheets of uniform cells forming small follicles. And so external branch of superior laryngeal nerve supplies the cricothyroid muscles. Okay, I don't know if it's given here or not, I forgot, but it's not. So this branch right here, it supplies the cricothyroid one. Okay, so if you hear cricothyroid, it's supplied by superior laryngeal nerve. Okay. And then now we are on to undifferentiated and anaplastic carcinoma. Older patients presents with rapidly enlarging neck veins, causing compressive symptoms, for example, dyspnea, dysphagia, or hoarseness. There's very poor prognosis, and it's associated with TP53 mutation. This one also looks like Riley Reed, I guess. I don't know. Those thyroiditis, the one up there. This one. Yeah. That's what this one looks like. Sorry. And the wordings they use are pleomorphic giant cell nest with cells. Okay, so polymorphic giant cells nest with occasional multinucleated cells, and the presentation looks like renal thyroiditis. So undifferentiated and anaplastic carcinoma. If nothing else makes sense, it's not. You figured out it's thyroid cancer, but it's not papillary, it's not follicular, or sheets of uniform cells forming small follicles, or it doesn't stain with Congo red, or doesn't have calcitonin in the serum. It's gonna be this one. Now diagnosing parathyroid disease. We have calcium over here, and then you have PTH over here. So if PTH is increased and you get calcium increase, that's just primary hyperparathyroidism. But you have increase in PTH but decrease in calcium, that's secondary hyperparathyroidism. Okay, why is there a decrease? It could be because of vitamin D deficiency, right? Because this one, what does vitamin D do? It reabsorbs calcium from the intestine and the bone, right? It helps do that. Or kidney, sorry. Yeah. And there's decrease in calcium intake or chronic kidney disease as well. So that's your secondary. So it depends on your PTH. That's what it depends on, not your calcium. So if PTH is high, it's going to be hyperparathyroid. It's going to be primary, or is the secondary. Okay, so primary happens because of hyperplasia, adenoma, or carcinoma. Secondary is because of vitamin D deficiency or decrease in calcium intake or chronic disease. Okay, if it's more increase in calcium, then it's going to be primary. If it's decreased, it's going to be your secondary. Then say if the PTH is low, that's hypoparathyroidism, right? So if it's low and the calcium is low as well, that's your primary hyperparathyroidism. So it could be because of surgical resection or autoimmune. But if you have low PTH and high calcium, that's not due to PTH, right? So that's PTH independent hypercalcemia, and that could be because of increased calcium intake or cancer, right? Or increase in vitamin D. And cancer, they mean paraneoplastic syndromes that causes increase in calcium. And like sarcoidosis, was it? Yeah. Causing increase in vitamin D because it has increase in macrophages. Macrophages secrete 1-alpha hydroxylase, and while 1-alpha hydroxylase converts calcidiol into calcitriol or activated vitamin D. Okay, hypoparathyroidism due to injury to parathyroid glands. 10 minutes, okay. Hypoparathyroidism. So due to injury to parathyroid glands or their blood supply, usually during thyroid surgery, autoimmune destruction or DiGeorge syndrome. Findings are tetany, hypocalcemia, and hyperphosphatemia. So all you need to know is that how you're going to figure out it's hypoparathyroidism. It's easy. They're going to give you either Shostak sign or Trousseau sign. Okay, and what are these signs? It's basically tapping your facial nerve, and that's going to contract the facial muscle. So tap the cheek and then contraction of facial muscle. That's how you know that there's decrease in calcium, okay, in your serum calcium. And then there's also Trousseau sign, which is the sphygmomanometer of the manual BP machine, or just the BP cuff. That's what it's called, okay, or sphygmomanometer. They put it on and then they start it, and then what happens is there's occlusion of the brachial artery, right? And this will start causing carpal spasms because the calcium is decreased, right? So calcium gets used up really fairly quickly, and then you start getting the spasms. Okay, so findings are tetany, hypocalcemia, and hyperphosphatemia. Okay, why phosphatemia? because PTH does what? It thrashes phosphate. Now PTH is reduced, so it doesn't thrash it anymore. Pseudohypoparathyroidism type 1A. This is autosomal dominant, maternally transmitted mutations, imprinted gene as 1 inactivating mutation coupled to PTH receptor that encodes to GS protein alpha subunit. We already know what that is, right? Hopefully by now. That's the alpha subunit right there for the GS protein. GS protein, and that's the soft, that one right there, or that one right there. Okay, so GNAS inactivating mutation coupled to the PTH receptor that encodes the GS protein alpha subunit. So inactivation of adenylate cyclase when PTH binds to its receptor. Okay, so when that attaches like over here, PTH comes in and attaches that, it inactivates this whole complex, so then it inhibits this. So it kind of acts like this, doesn't it? Inactivation of the adenylate cyclase when PTH binds to its receptor. So this causes an organ resistance in the kidney or bones to PTH. Okay. And this is called pseudohypoparathyroidism type 1. Okay. Physical finding is going to be Albright hereditary osteodystrophy. This is important to know what that is. So that's the shortening of the fourth toe right there. So that's what it looks like. Okay. And this is important because that's the giveaway. That's the one that they're going to describe. But they won't say this fancy word. They'll just say shortening of fourth or fifth digits. And then you should understand that they're talking about Albright hereditary osteodystrophy, and that it's associated with pseudohypoparathyroidism type 1A. There will be short stature, round face, subcutaneous calcification, and developmental delay. Labs are increase in PTH and decrease in calcium and increase in phosphate. Obviously, because what does PTH do? It thrashes phosphate, but now PTH is mutated, so it's not functioning like it normally. So you can just think of it like PTH deficiency, and then you have decrease in calcium and phosphate increases. Pseudohypoparathyroidism is autosomal dominant, paternally transmitted mutation imprinted gene as gene, but without an organ resistance to PTH due to normal maternal allele, maintaining renal responsive to PTH. So like that. Physical findings are same as this. Albright hereditary osteodystrophy. But here the labs, you're going to have a normal PTH, calcium, and phosphate because of the responsiveness to the maternal allele. Okay. 6 minutes. Let's talk more about that. So you need to know about Albright hereditary osteodystrophy. This is like literally the buzzword that they use. Okay, and then you need to know that this is pseudohypoparathyroidism or this one, pseudo. How do you differentiate between the two? In this one, the first one, type 1A, it acts like there's a deficiency of PTH. In the second one, they act like normal, like everything is normal, PTH, calcium, and phosphate. However, you still have these shortened toes, right? So that's how you differentiate between the two. This is important sign. It's pretty much gives away what the answer is going to be, because there's tetany, and tetany is due to decrease in calcium, and decrease in calcium because of hypoparathyroidism, right? It can happen in DiGeorge, it can happen in autoimmune destruction, okay, or injury to parathyroid glands, so it becomes ischemic and atrophies. Lab values in hypocalcemic disorder. Let's see. Can we do it in 5 minutes or 4 minutes? I think we can, but I don't want to rush it, so let's just take a break here. Then go on with this. We need to know what ALP is. So ALP is an enzyme found throughout the body, but it's mostly found in liver, bones, kidneys, and digestive system, right? So, but ideally it's for liver and bones. Okay, so when the liver is damaged, ALP may leak out into the bloodstream. High levels of ALP can indicate liver disease or bone disorders. Okay. Other names are ALP, ALK, phospho-ALKP. We just look for this. Okay. So how do you differentiate between liver and bone disease? You do gamma glutamyl transferase test. Okay. So if GGT is normal, then it's usually bone disorder, and if this is high as well, it's going to be due to liver then. So high level ALP and high levels of GGT means your symptoms are likely due to liver disorder, and not a bone disorder. High levels of ALP and low or normal levels of GGT means it's more likely you have a bone disorder. Cool. So vitamin D deficiency. Vitamin D deficiency. Okay, so that's going to be with calcium. We know that vitamin D pulls in the calcium from intestine and renals, right? So if you have vitamin D deficiency, you're going to have a decreased calcium. Okay. PTH is increased, so if it's not pulling in phosphate, it's not gonna secrete phosphate either, because vitamin D does what? It excretes phosphate as well, right? In the renals, but not the intestine. So whatever phosphate is there is gonna, release it, I guess. I don't know. Or does it? I'm not too sure about that one. Let's see. For PTH, it's gonna be increased, because it's gonna try to make more D. Because remember, vitamin D decrease causes increase in PTH. Vitamin D, ALP. So what's it gonna do to the bones? When PTH is increased, it's gonna have increase in this, right? Oh, right. So PTH is increased, then phosphate is gonna be decreased, then, right? Because phosphate, PTH thrashes phosphate, so that should be decreased too, along with calcium. ELP is gonna be increased, right? Because ELP, because of the bone resorption, because of high PTH, it's gonna be resorbed. But since vitamin D deficiency is there, calcium does not stay in the serum; it gets excreted out because there's no resorption. Vitamin D, since this is vitamin D deficiency, it should be decreased. Let's see. Okay, calcium is decreased, phosphate is decreased, right? Phosphate, parathyroid hormone is increased, ELP is increased, and vitamin D is decreased because of vitamin D deficiency. Hypoparathyroidism, we know what this is, or no? Okay, so hypoparathyroidism is this thing right here, right? It's probably this one, because PTH is decreased, and decrease in calcium is what hypoparathyroidism is, right? So calcium and hypoparathyroidism is going to be decrease in calcium, because we have decrease in PTH as well. What happens to the phosphate? Since PTH is, not there to thrash phosphate, we will have rise in phosphate then, right? What's going to be in ELP? Since this is normal or, low, there's not going to be any bone resorption, so there's not going to be any effect on this, or it's going to be low effect, very minute effect, I guess. So probably decreased or something, or no effect. Vitamin D is going to be decreased because PTH is decreased. Yeah, so no effect there. Calcium is low. Phosphate is increased. Hold on. That's what I said, right? Because there's no PTH to thrash phosphate, so it's going to be increased. Since there's no PTH, then there's no difference in bone resorption, and we don't have vitamin D, active vitamin D being made, because there's no PTH to stimulate that growth. We have secondary hyperparathyroidism, or CKD. Okay, so that one is over here. We have high PTH but low calcium causes secondary hyperparathyroidism, right? That's because of vitamin D deficiency or decrease in calcium intake, or even chronic kidney disease. If you have chronic kidney disease, what do you have? Decrease in vitamin D, because it's being made in proximal tubule, right? So we can say that one is decreased. It's hyperparathyroidism. So what happens to PTH? It's going to be increased, right? But why is it increased? It's got to be increased because of something, right? One, decrease in vitamin D, and second, it's got to be decrease in calcium as well. Okay, why? Because calcium is not being reabsorbed in in distal convoluted tubule. We'll read about that over here. Okay, what happens to phosphate? Phosphate also, I guess, gets decreased. What happens to ALP? ALP also gets increased, I guess, right? Let's see. So we have, okay, so first we went with vitamin D, right? Chronic kidney disease, it doesn't make vitamin D, so it decreased or no change, okay. Since we have, it's hyperparathyroidism, they give you that PTH is increased. If that is increased, that means there will be bone resorption, so ALP is increased. This is a thrashing hormone. I think I said it decreases. But there's an increase in phosphate, right? Because why? Because kidney's not functioning properly, so it's not being able to excrete phosphate. Okay, that's why. And since it can reabsorb calcium in the renals, you're gonna have a decrease in calcium as well. Okay. Pseudo hypoparathyroidism. Okay, that's not up there. That's this thing right here. So in pseudo hypoparathyroidism, you have decrease in calcium and increase in phosphate, right? And increase in PTH. So that's what it will be. Decrease in calcium, increase in phosphate. Why? Because PTH doesn't do what it's meant to, so PTH is going to be increased. What's going to happen to ALP? No change, I guess, or decreased. Vitamin D, PTH doesn't function like it's supposed to. Vitamin D is going to be decreased. Okay. Calcium decrease, phosphate increased. PTH is increased. ALP is increased. Okay, so I thought that was a inactivation of that. Okay, this one doesn't make sense to me, but apparently ALP is increased for PTH, and there's no change in vitamin D. No effect in vitamin D for pseudo hypoparathyroidism. Let me check that again. Okay, so it only affects the calcium and phosphate part of the system, I guess. It doesn't affect the bones, because bone doesn't use GS protein or alpha subunit for the osteoclastic and osteoblastic activity. So PTH will still have the osteoclastic activity, so resorption of bone will still occur, so ALP will be increased because of that. Okay. And for vitamin D, there's no effect on it because of a mutation over there. Okay. Okay, then we have hyperphosphatemia. That's telling you that this is increased, right? If this is increased, that means PTH is increased. If PTH is increased, calcium is going to increase. If calcium is increased, that means it's taken from the bone, so ALP will be increased. And vitamin D should be decreased because we have enough phosphate for that. But we do have increased amount of PTH, so this should increase as well then. calcium, there's increase in phosphate, so we have increase in PTH to do that, but we have decrease in calcium, serum calcium. However, we do get it from the bones, so that is increased. But vitamin D is decreased, so I guess that's why there's decrease in calcium, because it's not reabsorbing calcium from the renal tubules. Okay, so vitamin D is decreased in all of them. ELP is increased in all of them except for this hypoparathyroidism, right? Because no PTH to reabsorb the bone. And calcium is decreased in all of them, so that should have been a giveaway that I looked over. Hypocalcemic disorders, so all of these are hypocalcemic disorders. Okay. All of them increase phosphate besides the vitamin D deficiency. Okay. And all of them increase PTH except for parathyroid. Hypoparathyroidism. Cool. That's one way to remember it, but just make sense of it, then you don't have to memorize it. The hard one I found was this one, because I don't understand that one. Right, okay. Hyperparathyroidism. Primary hyperparathyroidism. It's usually due to the parathyroid adenoma or hyperplasia. Hypercalcemia, hypercalciuria, renal stones, polyuria, thrones. So this is the one with the stones, thrones, bones, and groans, and psychiatric overtones. Okay, that's the one for. Like, this is how you remember it. That's not what they give you. They will give you that there's a, costovertebral pain or flank tenderness, and they'll tell you that this person has pain urinating, I guess, or no, he goes to urination for, like, urinary frequency is increased, right? Bones is for bone pain. Groans is because of constipation, and psychiatric overtones are neuropsychiatric disturbances. Okay. So usually due to parathyroid adenoma or hyperplasia. So that's gonna increase PTH, right? So that's why this is primary hyperparathyroidism. You get hypercalcemia, increase in calcium in urine. So you have renal stones because of that. You'll have polyuria and hypophosphatemia, because PTH is a phosphate thrashing hormone. So increase in PTH will increase ALP. That will increase urinary CAMP, because it uses GS protein, and that uses CCAP. Right. Most often asymptomatic, may present with bone pain, weakness, constipation, abdominal flank pain, kidney stones, acute pancreatitis, neuropsychiatric disturbances, psychiatric overtones. So that's what the X-ray would look like. You see those shadows in the middle? That's reabsorption of the bone. That's why there's like a less dense bone over there. So light is going in farther, or X-ray is going in further into the bone. Osteitis, fibrosa, cystica. So these are the cystic bone spaces. Okay. Cystic bone spaces filled with brown fibrous tissue. Brown tumor consisting of osteoclasts, that's the crushing ones, and deposited hemosiderin from hemorrhages. Remember hemosiderin? You need to differentiate between this and like heart failure cells, or like lipofuscin, the age-related pigmentation. Causes bone pain. Okay. Due to increase in PTH, classically associated with primary, but also seen with secondary hyperparathyroidism. So stones, thrones, bones, groans, and psychiatric overtones. Osteitis, fibrosa cystica. Then we have secondary hyperparathyroidism. That's secondary hyperplasia due to decrease in calcium absorption and or increase in phosphate, most often in chronic kidney disease. Causes are hypovitaminosis, D, and hyperphosphatemia. This leads to decrease in calcium. Hypocalcemia, hyperphosphatemia, and chronic kidney disease versus hypophosphatemia with most other causes, increase in ALP and PTH. So you have renal osteodystrophy, renal disease, secondary and tertiary hyperparathyroidism causing bone lesions. So this one secondary. How does it differ with this one? Here you have hyperplasia due to decrease in calcium absorption and increase in phosphate. Right here, it just happened, and that caused increase in all of that calcium and decrease in phosphate. Right here, it's because of calcium that's influencing the PTH. So most often in chronic kidney disease, because of hypovitaminosis D, right? Because that's the function of vitamin D, and hyperphosphatemia, decrease in calcium, right? So it causes this because renals can't secrete phosphate out, so excrete or secrete whatever in kidney disease, and it can't reabsorb calcium either. So hypocalcemia, hyperphosphatemia, and chronic kidney disease. Okay, so increase in ELP and PTH, because PTH will be increased because of decrease in calcium. Then you have tertiary hyperparathyroidism, which is refractory autonomous hyperparathyroidism resulting from chronic kidney disease. Okay, so there's a severe increase in PTH, which causes an increase in calcium. Okay, familial hypocalciuric hypercalcemia, defective G-coupled calcium sensing receptors. Okay, these are your circas. That's smooth endoplasmic reticulum calcium channels. Okay. So defective G-coupled calcium sensing receptors in multiple tissues, for example parathyroids or kidneys. Higher than normal calcium levels required to suppress PTH. Excessive renal calcium at reabsorption will cause mild hypercalcemia and hypocalciuria with normal to increased PTH levels. Decrease calcium in the urine but increase in the serum. Okay, because defective G-coupled calcium sensing receptors in multiple tissue. So higher than normal calcium levels. So see, this is the parathyroid hormone. This is the calcium sensing receptor. There's already calcium. You have majority of calcium right here. So what is this going to do? One of them is going to go back onto the parathyroid and tell them that, yo, we here, stop making more PTH. But then this one is like, no one in store, come back tomorrow kind of thing. Right? So then this continues, it's automated, so PTH keeps releasing and no one's here. Until like this whole crowd is over here, right? Then the whole crowd gets accumulated here, and that's when you need this whole thing gets opened up, and then it senses it, and then it stops pulling out PTH. So defective G-coupled, this is the defective G-coupled calcium sensing receptor in multiple tissues like parathyroids or kidneys. Higher than normal calcium levels required to suppress PTH. Excessive renal calcium reabsorption, right? Even in the kidneys, if this was a kidney, it's going to keep pulling in calcium, right, through the cell. because it's not sensing that there's enough calcium already. Okay, so excessive renal calcium reabsorption causes mild hypercalcemia and hypocalciuria, with normal to increased PTH levels. Diabetes mellitus, DM, acute manifestation are polydipsia, polyuria, polyphagia, weight loss, DKA type 1, hyperosmolar hyperglycemic state, and this is type 2. DK is type 1. Okay. So how do you get type 1 and how do you get type 2, right? Type 1 is when you have a pancreas right here. Let's make that green. Right, pancreas right there. Let's get rid of that. And then you have insulin producing cells, and then okay, we don't need that. So these are the beta cells in the pancreas. Okay. Beta cells in the pancreas, and then you have intestine, or like vessels. Sorry, vessels. I'm falling asleep. Sorry. The vessels with the receptors. Okay, now you have too many glucoses here, and they need to be taken out of the bloodstream, right? So there's a lot of this in the bloodstream, okay, and they need to be taken out of the bloodstream. So this one, normally what happens is this one makes insulin, right? Insulin, and that goes in here, attaches to that, so that the glucose can come in and go into the thing, into the cell. Via G4 it would go into the striatal muscles, right? GLUT4. So then in diabetes 1, what happens is this thing does not make insulin, so there's no key to go in. Okay, that's why it needs exogenous insulin, the one without the C peptides. So that will come in, can't make that, but it's similar to that. So we got purple, right? So now this one is coming in and making that. So it requires that. So when you don't have, insulin, and you have glucose and you don't take any medicine, what's gonna happen? You're gonna get DKA. Right? For type 2, what's happening is you have insulin, and you can have other insulin as well. This insulin, it's not being made as much as it used to be, so we can help it make more with metformin, or we can give other insulin analogs, right? But what happens is these channels now, instead of this many that used to be there, now there's only like one left. Okay, so no channels and no channels here. So what this does is, the treatment is we give them so much insulin that even if there's like anywhere one receptor anywhere, it's gonna pick this insulin up, and it's gonna take in the glucose as much as it can. That's the problem with type 2, that these channels are not there. Either that, or it's affecting the insulin here as well. It could be that as well. This and this along with that. We'll read about it now. So anyways, so if you have too much glucose, what's gonna happen? It's gonna pull in the water, right? That's why you feel thirsty. So that's why you drink a lot of water, and you piss out a lot of water. And then also, since glucose is not being used for energy, your body feels weak. That's why you eat a lot, because your body thinks that you're not getting enough food or energy. Weight loss happens because when sugar is not available, body breaks down fat into fatty acids, and when it does that, you get ketones made, and that's how you get ketoacidosis, right? And hyperosmolar hyperglycemic state is just, water being pulled in because of glucose. So hyperosmolar state because of high glycemic state. Okay. Rarely can be caused by unopposed secretion of growth hormone and epinephrine, also seen in patients on glucocorticoid therapies like steroid diabetes, right? Because this is what does this do? It secretes insulin like uh, growth factor, right? The IGF or whatever from the liver. So that is insulin. It causes insulin resistance because of that. Uh, Similarly, this thing I guess does the same, similar kind of mechanism. So also seen in patients with glucocorticoid therapy as well. Then you have chronic complications, so non-enzymatic glycations, so small vessel disease, diffuse thickening of basement membrane. The most common ones you should know are retinopathy, nephropathy, and neuropathy, right? And these are the things that are going to show up in the questions then, majority of the time. So retinopathy, so hemorrhage, exudate, microaneurysm, vasoproliferation, glaucoma, and nephropathy. Nodular, so what is nephropathy? That's nodular glomerulosclerosis. And there are 3 stages to it as well. So progressive proteinuria. Initially, there's microalbuminuria. Sorry about that. Right, so initially it's albuminuria. Okay. Then you have ACE inhibitors, and ARBs are renoprotective. That's important to know. Right, so that's your pearls and the. It starts with the STOA. What was it? I keep mixing this up with statins. It's sartans, right? So your sartans and your pearls. Okay. Pearl, like Remy pearl. They're renoprotective. You should know that. Okay. Arteriosclerosis, causing hypertension, which can cause chronic kidney disease. You should know that how hypertension causes chronic kidney disease. We discussed that in renal. Large vessel atherosclerosis, CAD, peripheral vascular occlusive disease, causing gangrene. This is an important one too. How peripheral vascular occlusion disease causes gangrene, so it can cause limb loss, cerebrovascular disease, and MI, most common cause of death. Osmotic damage, sorbitol accumulation in organs with aldose reductase, and decrease in absent sorbitol dehydrogenase. We did that in biochem. Neuropathy, motor, sensory, glove, and stocking distribution. They'll give you that the patient is feeling tickling sensation or pin and prick sensation in glove and stocking distribution type of manner. Autonomic degeneration, for example, GERD, gastroparesis, and diabetic diarrhea. And cataracts. How do you diagnose it? You diagnose it with HbA1c, right? The cutoff is more than 6.5%, or 6.5 or more than that. No, reflects average blood glucose over the prior 3 months, influenced by RBC turnover. Okay, that's how we diagnose if the person has diabetes or not. And even though it's prior to 3 months, it can change in like 1 month as well. Say a person has like 6.1, and then in like 1 month, all he's been having is like outside food with drinks and donuts, I guess, or something like that, chocolates all day. Then within a month, he'll have like a 9.5 HbA1c as well. But typically, this is like over 3 months in a normal person. Fasting plasma glucose is more than 126 milligram per deciliter. That's fasting for more than 8 hours. Should remember that. Should remember all these values actually. Postprandial or 2 hours oral glucose or tolerance test, more than so 200 milligram per deciliter is the cutoff. 2 hours after consumption of 75 grams of glucose in water. This is important. That's 2 hours after 75 grams of glucose in water. Then you have random plasma glucose test, anything more than 200. Presence of hyperglycemic symptoms is required. Okay, so usually it should be done like in the morning, right? Because that way you know there is some insulin working. Ideally, but it could be anytime. Insulin deficiency or severe insulin insensitivity, decrease in tissue. Okay, so sorry. And these are all the functions of insulin, right? So if there's no insulin, then what's going to happen? There will be decrease in tissue for glucose uptake. There will be increase in glycogenolysis, right? Because the body thinks that you don't have any sugar, so it's going to now start making more sugar for energy, right? So it breaks down the glycogen. It's going to make more glucose, so gluconeogenesis increases, right? It's going to cause increase in proteolysis and increase in lipolysis for energy, right? So these three things, decrease in tissue glucose uptake and increase in glycogeno and gluconeo, will cause hyperglycemia and glycosuria. What will this cause? It will cause increase in plasma osmolality, which will cause increase in thirst. It also causes osmotic diuresis, so loss of water, sodium, and potassium, which will cause hypovolemia, circulation failure, and decrease in tissue perfusion, causing death or coma. Right? The proteolysis can decrease muscle mass. That's why you see a person with diabetes who might be losing weight. They're also losing muscle mass, right? And weight loss. Okay. This also causes an increase in gluconeogenesis. The fatty acid metabolism, or breakdown of that, will cause increase in plasma-free fatty acids. This will cause breakdown of that causes ketogenesis and ester coenzyme A. So ketones will cause increase in ketogenesis, ketonemia, ketonuria. All of these will give you diabetic ketoacidosis, right? So that will cause vomiting and loss of water and all this cycle. Then you have anion gap metabolic acidosis, hyperventilation, cosmal respiration. Also, because of this, it's going to go into anaerobic glycolysis, which will increase serum lactate as well. Okay, which will cause anion gap metabolic acidosis as well. How do you calculate this real quick? It's sodium subtract the sum of calcium and bicarbonate. Okay, that's how you calculate anion gap. Okay, I think it was like 8 to 12 is within range, and anything higher is high anion gap. We'll do that in renal. Type 1 versus type 2 diabetes mellitus. So type 1, already went over. The primary defect is autoimmune T cell mediated destruction of B cells, for example, due to presence of glutamic acid decarboxylase antibodies. So you won't produce any insulin now, right? Then you have insulin necessary in treatment. You're gonna always need insulin because your body can't make it. Ages is usually less than 30 years. Association with obesity, no association with obesity. Genetic predisposition, it's relatively weak. 50% concordance in identical twins, and polygenic. Associated with HLA system, it is HLA DR4, and DR3. So 4 minus 3 equals 1. Then you have glucose intolerance, severe glucose intolerance, because your body can't make any amount of insulin, right? So it's gonna shoot up. Insulin sensitivity, sorry, insulin sensitivity is pretty high because it will take in whatever you give it, whatever amount of insulin you give, because it's deprived of it. Ketoacidosis, it's pretty common because if it can't use glucose, it's gonna use fatty acid, and breakdown of fatty acid makes ketones along with the acetylcholine coenzyme A for ATP, right? So that beta cell numbers in the islets will decrease because it's being attacked by your immune system, T cells. Serum insulin levels decrease, right? Okay, because that's the pathogenesis of it, right? Classic symptoms of polyuria, polydipsia, polydysphagia, and weight loss is pretty common. Histology is islet leukocyte infiltrates. Leukocytes are your T cells. Type 2, there's increased resistance to insulin and progressive pancreatic B cell failure, right? So it could be either this with the channels I said, and it could be this progressive pancreatic B cell failure, because it keeps on making it, so it's overworked by now. So that's why it goes into the failure. Insulin necessary in treatment, sometimes it is. Okay. Because again, I told you why. We give them as much insulin as we can, because even if there's an open anywhere, there's an open channel or GLUT4 of any kind, we need the insulin to be there so glucose can be taken in. Okay, that's why sometimes we do use that. Ages, it's usually more than 40 years, but nowadays with packaged foods and all that, this can be lower in real life. Association with obesity, it is. It does have a genetic predisposition, relatively strong, 90% concordance in identical twins, and it's polygenic. Association with HLA system, it's not. Glucose intolerance is mild to moderate. Then we have insulin sensitivity, it's pretty low. Ketoacidosis is rare. Why? Because we were giving it so much insulin, right? It's not that insulin's not being made, right? Insulin is being made, it's just that there's resistance to it. Okay. So it doesn't need free fatty acid as much as it does in type 1. B cell numbers in islets, variable with amyloid deposits. Okay, this is important. We read that in multiple myeloma in immuno. Okay. Serum insulin level is increased it's increased initially, but decreases in advanced disease. Okay. It decreases in advanced disease because it gets fatigued, right? Progressive beta cell failure. But initially, since it has a lot of glucose, pancreas is going to be like, yo, I got it. But then it don't got it. Classic symptoms of polyuria, polydipsia, polyphagia, weight loss. Sometimes you can see that. Normally, if you've seen this, it's usually type 1. Sometimes you don't have to make the differentiation between type 1 and type 2. Sorry, excuse me. Histology, islet amyloid polypeptide deposits. So amyloid is what you need to remember. You'll see a light chain amyloid, blue-green fluorescence over there. Hyperglycemic emergencies. Okay, so if you have too much glucose in the blood, what can happen? One, it's not being used by the body, so fatty acid is being broken down, and then a lot of ketones are a byproduct for that, so you can go into diabetic ketoacidosis, right? So pathogenesis. Also, red blood cells can use ketones, right? So it the cycle viciously continues. So pathogenesis, insulin non-compliance or increased requirements due to increase in stress, for example, infection, lipolysis, and oxidation of free fatty acids, uh, right? Breakdown of free fatty acid causes increase in ketone bodies. So you have ketone bodies are which ones? It's beta hydroxybutyrate, acetoacetate, and acetone as well, I think, or acetate, I think. Insulin deficient, ketones are present. Okay, that's the pathogenesis. Signs and symptoms are DK is deadly, so you have delirium or psychosis. You have cosmal breathing, that's the buzzword. You should know what that is. It's rapid and deep breathing. Abdominal pain, nausea, vomiting, and dehydration. You have fruity breath odor due to exhaled acetone. Yes, that one. So fruity, they describe it like a sweet odor or fruity odor. Actually, you can just see that. Is sense in the breath. Because when the question stem comes in, you're gonna have find a person in the outside somewhere in the park. They were collapsed and then they were brought in and unconscious. So it could be usually a drunk person, but then you have to differentiate between drunk or someone in diabetic coma. Labs are hyperglycemia, increasing. There will be increase in ketoacidosis. Acidosis is in the name, so increase in H ions and decrease in bicarbonate ions. So there's increase in anion gap metabolic acidosis, increase in urine and blood ketone levels, leukocytes, normal or increase in serum potassium, but depleted intracellular potassium due to transcellular shift from decrease in insulin and acidosis. Okay, so osmotic diuresis will lead to increase in potassium loss in urine, total body potassium depletion. This is an important one. I think they'll give you something down here too, or not. It's somewhere else. I think it's in musculo. But insulin causes shifting of potassium inside of the cell, right? That was the mnemonic for that. In makes the potassium go in the cell. So there's decrease in insulin, so increase in potassium coming out. Why? Because since there's so much H ions, they get exchanged with potassium. So H ions go inwards, and then potassium comes out of the cell as exchange, and the renal tubules at least. Why does H come in? Because with carbonic anhydrase and CO2, they make bicarbonate. Okay, in the renal tubules, but outside inside the body, normally it's the other way. Complications, we'll talk about that in renal. Complications: life-threatening mucormycosis, the black fungus. Right, so mucormycosis, if you don't know what that is, it was pretty rampant during COVID, the rise of COVID. Is this black thing? Not that, not that. Like that. That's what it usually looks like. Okay. Cerebral edema, cardiac arrhythmias, and then treatment for this is IV fluids, IV insulin, and potassium to replete intracellular stores. Glucose can be required to prevent hypoglycemia and insulin therapy. Okay. Right. Okay. So if not this, then you can also have this hyperosmolar hyperglycemic state, right? This the profound hyperglycemia causes excessive osmotic diuresis, causing dehydration and increase in serum osmolality. HHS, or hyperosmolar hyperglycemic state, classically seen in older patients with type 2 diabetes mellitus, okay, and limited ability to drink. Insulin present, then ketones deficient, because there is insulin, and here we looked at that, right? Ketoacidosis is rare in type 2. So, got 10 minutes. Signs and symptoms: thirst, polyuria, lethargy, focal neurologic deficits, and seizures. Labs are hyperglycemia, often more than 600 milligram per deciliter, increase in serum osmolality, right, more than 320 milliosmol per kilogram. Normal pH, no acidosis, so no ketones. That's why. Normal or increased serum potassium. There's less intracellular potassium. Okay. So gotta differentiate this way. So normal or increased serum potassium, there's decreased amount of potassium intracellularly. Over here we had depleted intracellular potassium, right? And total body potassium depletion. That's the difference between the two. Complication: it can progress to coma and death if untreated. Right, this one as well. I went into coma and death as well. And then treatment for this is IV fluids, IV insulin, and potassium to deplete intracellular stores. Glucose may be required to prevent hypoglycemia from insulin therapy. You have to remember, potassium is required for what? In HEMAT, we'll learn about that, right? It's needed for the coagulation factors, right? So that's why you don't have, quick wound healing, because of that. Okay. Required to prevent hypoglycemia from insulin therapy. Hypoglycemia in diabetes mellitus usually occurs in patients treated with insulin or insulin secretagogues. For example, sulfonylureas or meglitinides. These work on potassium channels as well. Both of these. In the setting of high dose treatment, inadequate food intake and or exercise. Neurogenic autonomic symptoms: diaphoresis, tachycardia, tremor, anxiety, hunger, allow perception of decreased glucose, hypoglycemic awareness. Then you have neuroglycopenic symptoms. These are altered mental status. Seizures, death due to insufficient glucose in CNS may occur in the absence of preceding neurogenic symptoms in patients with attenuated autonomic response. So hypoglycemic unawareness. Okay. And treatment is simple carbohydrates, for example, glucose tablets or fruit juice. That's only for hypoglycemia, okay? Even if they have diabetes, and so this usually happens when they take their medicine 30 minutes before food, and then they forget to eat on time, and they go into hypoglycemic state. So just give them glucose tablets or fruit juice. IM or intramuscular glucagon. So this is a long-term thing. It doesn't happen right away. This would be your immediate thing, and then you'd give this for longer effect, and then, or you can give IV dextrose. Okay. Let's take a break here and then Cushing come back. Syndrome. Etiology: increase in cholesterol due to variety of causes. Exogenous glucocorticoids will lead to decrease in acetylcholine, right? Remember the whole pathway we did over here with the adrenal right here. So this thing gets inhibited by cortisol if there's too much cortisol, right? Okay. So exogenous glucocorticoids decreases ACTH, leads to bilateral adrenal atrophy, right? Most common cause. This is the most common cause of Cushing's. Then primary adrenal adenoma, hyperplasia, or carcinoma, they all decrease ACTH, and that leads to atrophy of uninvolved adrenal glands. ACTH secreting pituitary adenoma, this is the Cushing's disease. Paraneoplastic ACTH secretion, for example, small cell lung cancer, bronchial carcinoids. Bilateral adrenal hyperplasia. Cushing's disease is responsible for majority of the endogenous causes of Cushing's syndrome. So since with exogenous glucocorticoids, right? So you have adrenal here, and hypothalamus over here, and pituitary over here. Okay, so hypo, pituitary, adrenals. Okay. Let's put a different color. Green. So exogenous. So when there's normally what happens is the signal comes in here, and then ACTH gets cleaved from the proprio whatever pump or whatever, and then ACTH comes into the vesiculata to secrete cortisol, right? And the cortisol then goes back and inhibits the secretion of more signals or ACTH, right? But say there's exogenous corticosteroids, right? Steroids. Let's do that in red. So you have steroids. This is going to also go back and then inhibit release of ACTH. So since you have steroid already and no ACTH is stimulating adrenals to secrete more cortisol, eventually this thing is gonna go out of shape and atrophy. So when that atrophy happens, you cannot stop giving these steroids, right? Because you have to taper it off. So slowly you get a rise out of ACTH, and then ACTH can do its action on the adrenals, right? So if you just stop giving this, then there's no steroid left, and now you're going through all its symptoms. Over here, it's saying that the hypoplasia, hyperplasia, or adenoma, or whatever, it decreases ACTH release, and that leads to atrophy of uninvolved adrenal gland. We just talked about that. And then ACTH secreting pituitary adenoma. So this thing has an adenoma, so it's bigger, and now it's secreting more ACTH instead of what it was doing before, right? Okay. For example, small cell lung cancer or bronchial carcinoids. Bilateral adrenal hyperplasia. So now you have hyperplasia, right? So now you have bilateral hyperplasia because now this is getting bigger as well now. Okay. So that's what the Cushing's disease is. When you have increase in ACTH, you get Cushing's syndrome. Or cortisol actually, but yeah, increase in cortisol causes Cushing's syndrome, CHC. So Cushing's disease is responsible for the majority of the endogenous causes of Cushing's syndrome. Findings are Cushing's syndrome, increase in cholesterol, urinary free cortisol, skin changes, thinning, stria, facial plethora, acanthosis, nigricans, hypertension, immunosuppression, neoplasm, a chance neoplasm, a cause but not a finding. Growth restriction in children, increase in sugar, hyperglycemia, or insulin resistance. Also, amenorrhea or moon feces. Right? So you should know what that looks like. And you should know buffalo hump as well. So moon feces is just, that thing right there. And then we have buffalo hump. You get a hump right there instead of that. So these are the things. So you get a buffalo hump, stretch marks, thin arms, thin skin. There's easy bruising, extra face and body hair. That's the moon face, right? So round moon face, thinning of hair, red cheeks. Okay. Normally they give you that there are purple lines or striations, right? So that's your skin changes. They'll give you moon faces and buffalo hump. Usually those are the giveaways. So that's the stria and that's the moon face. Diagnosis screening tests include increasing free cortisol on 24-hour urine analysis, increase in late night salivary cortisol, and no suppression with overnight low dose dexamethasone. Sorry. Okay, so increase in free cortisol on 24-hour urine analysis. Right, so when you have that or late night salivary cortisol increase and no suppression with overnight low dose dexamethasone, so you give that and then you check on in the morning as well, so that does not suppress it, then we go on further examining or testing it, right? So increase in 24-hour urine free cortisol. Right, free cortisol are the ones that are not bound to anything. Increase in late night salivary cortisol and or inadequate suppression with 1 milligram of overnight dexamethasone. Test. Why dexamethasone? Because that's a corticosteroid, right? So when you give corticosteroid, what should happen to the ACTH with the feedback loop? It gets inhibited, right? Cortisol inhibits this, or exogenous steroid also inhibits this. But if there is suppression, that's easy then. It's ACTH independent Cushing's syndrome. So you have exogenous glucocorticoids or adrenal tumor. Consider adrenal CT to confirm this. Right. So the cortisol is not dependent on the ACTH. It's being made by the adrenals, right? Because of the adrenal tumor. Or it could be that the person is taking exogenous glucocorticoids. Either way, it's not because of ACTH that you have free cortisol increase, right? So to make sure it's not adrenal tumor, you do this CT. Okay, now say you give dexamethasone and ACTH is not suppressed, it's actually elevated, right? So elevated, then you have ACTH dependent Cushing syndrome. Okay, I'm just wondering, so if this is given and this is suppressed, the dexamethasone, then this is suppressed, but in an adrenal tumor shouldn't already be suppressed. I guess it's suppressed more than it was already. It might have been leaking and then it gets suppressed because of this. Okay. But anyways, so if it's elevated, they'll give you if it's suppressed or not, and then you can just figure it out from that. So if it's suppressed, it's because of adrenal tumor. Easy. And if it's elevated, then it's ACTH dependent Cushing syndrome. So now we have to figure out why is ACTH elevated, right? So you do a high dose dexamethasone suppression test, more than 1 milligram, and then you either have adequate suppression, right? So you have Cushing's disease, so you MRI the pituitary, okay. So ACTH increased because of the pituitary gland tumor or some place on the pituitary, or there could be no suppression. Then the ACTH is perineoplastic syndrome now. It could be an ectopic ACTH secretion. So you do a CT of the chest and abdomen or pelvis. Another thing you can do is you can check for the CRH stimulation test, right? That's coming from where? The hypothalamus, right? So it could be a tumor of that. So there can be increase in ACTH and cortisol. That's the Cushing's disease. So you do an MRI for the pituitary, or it could be that there's no increase in ACTH and cortisol, even with CRH stimulation. Sorry, I got that wrong. So CRH, you secrete, or I guess you give CRH, or you stimulate the hypothalamus to release CRH, and then that will increase ACTH and the cortisol. So now you have Cushing's disease. So you do a pituitary MRI. If you do the stimulation of CRH and there is no increase in ACTH and cortisol, then it could be ectopic ACTH secretion. So then you do, again, that's a perineoplastic. So CT scan of the chest, abdo or pelvis. So ACTH secreting pituitary adenoma. Okay, so that's what they mean by Cushing's disease. And anywhere outside of the pituitary would be ectopic ACTH secretion. Okay. Again, to wrap that up, you measure the ACTH after giving a dexamethasone. If it's suppressed, it is because of adrenal tumor and nothing to do with ACTH, so it's ACTH independent. And if it's elevated and it had no effect, then you give again a high dose, right, of dexamethasone, because now we figured out that ACTH dependent Cushing syndrome. So high dose, it will either get suppressed. If it does get suppressed, then it's not because of perineoplastic, it's because of an adenoma of the pituitary that's causing increase in secretion of ACTH. If there is no suppression, then it's perineoplastic, ectopic, so you do chest, abdo, pelvis, CT. You can also do cortisol releasing hormone stimulation test. So when you stimulate that, you have CRH release, and the CRH will then increase ACTH and cortisol. That's on top of the adenoma, right? So then there's something wrong with the pituitary. We figured that out. Or there is no increase in the ACTH. That means it's perineoplastic, and you do CT of the chest or Nelson syndrome, enlargement of pre-existing ACTH secreting pituitary adenoma after bilateral adrenalectomy for refractory Cushing's disease. It leads to increase in ACTH, hyperpigmentation, right? So mass effect, headache, bitemporal hemianopia. This is enlargement of pre-existing ACTH secreting pituitary adenoma. So there was already an adenoma there, okay, and it got enlarged after the bilateral adrenalectomy for refractory Cushing's disease. So you did the surgery to take it out, but then it just grew for causing refractory Cushing disease. So you have increase in ACTH, also hyperpigmentation because of MSH, and then the mass effect, which are headache, bitemporal hemianopia. Bitemporal hemianopia because it presses down on the optic chiasm, right? It's the sella tunica and all that stuff. So presses down on that, the adenoma does, so then it squeezes into the nerve. Okay, the treatment is again transsphenoidal resection, post-operative pituitary irradiation for residual tumor. You have adrenal insufficiency, that's inability of adrenal glands to generate enough glucocorticoids with or without mineralocorticoids for the body's needs. Can be acute or chronic. Symptoms include weakness, fatigue, orthostatic hypotension, muscle aches, weight loss, GI disturbances, sugar and or salt cravings. Treatment is glucocorticoid with or without mineralocorticoid replacement. Okay, so if adrenals can't function the way it should be functioning, then it's called adrenal insufficiency. Okay, so there's a primary adrenal insufficiency. This is decreasing gland function, decreasing cortisol and aldosterone. This leads to hypotension, hyponatremic volume contraction, hyperkalemia, metabolic acidosis, skin mucosal hyperpigmentation, like that, and increase in melanin synthesis due to increase in MSH, a byproduct of POMC cleavage. Primary pigments, the skin and mucosa. For this, it's quite easy to figure out because it's just going to be, it's not making either of these things, right? The mineralocorticoid or glucocorticoid, sorry, sex hormone even. But that one's harder to pick up in an adult. But these ones you can pick it up. Then there's Addison's disease, that's chronic primary adrenal insufficiency caused by adrenal atrophy or destruction, most commonly due to autoimmune adrenalitis, resource-rich countries, or TB, resource-limited countries. Okay, so in a developed country, it's going to be this autoimmune adrenalitis. These are resource-rich countries, and in developing countries, you're going to have this as the cause of primary adrenal insufficiency, tuberculosis. Secondary and tertiary adrenal insufficiency is decrease in pituitary ACTH secretion, secondary, or decrease in hypothalamic CRH secretion, which is tertiary. Okay, basically just go back through this pathway. Okay, so it's like that. That's the hypothalamus, this is the pituitary, and then this is the adrenals. Okay, so if there's a problem in here, it's going to be primary adrenal insufficiency. If it's a problem here, it's going to be secondary. If there's a problem here, it's going to be tertiary. Right? No hyperkalemia, aldosterone synthesis preserved due to function of adrenal gland, intact RAS, and no hyperpigmentation. Secondary adrenal insufficiency is due to pituitary pathology. Tertiary adrenal insufficiency is most commonly due to abrupt cessation of chronic glucocorticoid therapy, HPA suppression. Tertiary form from treatment. So here, you should have increase in pigmentation, right? Or ACTH at least, because never mind, you wouldn't. Got it. Because it's secondary, that means the problem is in the pituitary, so that's why you don't have the MSH secretion. Okay. Acute adrenal insufficiency, also called adrenal Addisonian crisis. Okay. Often precipitated by acute stressors that increase glucocorticoid requirements, for example, infection in patients with pre-existing adrenal insufficiency or on glucocorticoid therapy, may present with acute abdominal pain, nausea, vomiting, altered mental status, and shock. You have Waterhouse-Friderichsen syndrome. This is bilateral adrenal hemorrhage in the setting of sepsis, for example, meningococcemia. So it's acute primary adrenal insufficiency. I think of this like this. So a Waterhouse, right? So you have a Waterhouse, so it's something like that. But I'm thinking of water tank, but I call that a Waterhouse, right? So tank, and then there's a hemorrhage in there, so it's leaking water, right? And this is your adrenal gland as well. So if adrenal gland starts leaking blood, that's similar to a Waterhouse leaking water, right? So that's bilateral adrenal hemorrhage in the setting of sepsis because of meningococcemia. That's the cause of it, and this causes acute primary adrenal insufficiency. So how do you figure out if it's primary or secondary or tertiary? You check the morning cortisol or ACTH stimulation test. You do that, and then you have a decrease in morning cortisol or ACTH stimulation test with decrease in peak cortisol, right? Then you check, you measure random serum ACTH, and you see that there is decrease or inappropriately normal ACTH. Then that's because then you have your secondary or tertiary adrenal insufficiency. If there is increase in ACTH, you have increase in adrenal insufficiency. Increase in primary adrenal insufficiency. Okay, because ACTH is stimulating your adrenal glands, but adrenal gland is not, increasing cortisol, morning cortisol. Over here measures random serum, so it's still decreased, and it's either because of pituitary or hypothalamus that cortisol is not being made. So here you basically check for cortisol levels, and then if you don't have it, you figure out why you don't have it. It could be either that there's a problem in pituitary from releasing ACTH, or hypothalamus from releasing cortisol releasing hormone, or it could be they both are functioning properly, but it's the adrenals that are not functioning properly. Okay, then you have hyperaldosteronism. This is increased secretion of aldosterone from adrenal gland. Clinical features include hypertension, decrease or normal potassium, metabolic alkalosis. Primary hyperaldosteronism does not directly cause edema due to aldosterone escape mechanism. However, certain secondary cause of hyperaldosteronism, for example, heart failure, impair the aldosterone escape mechanism, leading to worsening of edema. Okay, I kind of zoned out in there. I'll read that again. Increased secretion of aldosterone from adrenal gland, that's from the glomerulosa, or from the GFR, right? So glomerular zona glomerulosa, sorry. Right. So clinical features include hypertension, because that's what mineralocorticoid do. Aldosterone also does what? It decreases, or it causes excretion of potassium, right? So you could have decrease or normal amount of that. Metabolic alkalosis happens. Okay. Then you have primary hyperaldosteronism does not directly cause edema due to aldosterone. Okay, so primary does not directly cause edema. Right, because why? Because increase in hypertension is also going to do what? It's going to they're going to start secreting ANP and BNP, right? A and B and P. And what do? They reduce the volume. So that's why you don't have any that. So primary hyperaldosteronism does not directly cause edema due to the aldosterone escape mechanism. That's what that is. However, certain secondary causes of hyperaldosteronism, for example, heart failure, impair right. So heart failure now won't you won't have these being released because there's a problem in the heart now. Failure impair the aldosterone escape mechanism, leading to worsening of edema. You have primary hyperaldosteronism that's seen in patients with bilateral adrenal hyperplasia or adrenal adenoma. That is known as the Crohn disease, right? You can think of it like a cone on top of the adrenal. So if this was your adrenal, there's a cone on top of it. So that's called a cone disease, and now it's part of adrenal. So part of adrenal. Cool. Increase in aldosterone and decreases renin. Right? Why? Because renin is there when you don't have aldosteronism. So there's a feedback loop there. Leads to treatment-resistant hypertension. Even if you're giving treatment for the hypertension, you still have it. So you're doing your ACE inhibitors and ARBs, but BP is still increased. So because you have aldosterone, primary hyperaldosteronism. Secondary hyperaldosteronism is seen in patients with renovascular hypertension, juxtaglomerular cell tumors. These are your renin-producing ones, and edema, for example, cirrhosis, heart failure, and nephrotic syndrome. Okay. Neuroendocrine tumors. These are heterogeneous groups of neoplasms originating from the neuroendocrine cells, which have traits similar to nerve cells and hormone-producing cells. Okay, so most neoplasms occur in the GI system, like for example, carcinoid or gastrinoma. Pancreas, for example, insulinoma or glucagonoma, and lungs, for example, small cell carcinoma. Also in thyroid, medullary carcinoma, and adrenals have pheochromocytoma. Pheochromocytoma. So neuroendocrine cells will have pancreatic beta cells and enterochromaffin cells share a common biologic function through amine precursors uptake decarboxylase (APUD). Despite differences in embryologic origin, anatomic site, and secretory products, for example, chromogranin A, neurophysin specific analase, synaptophysin, serotonin, and hematin and calcitonin. Treatment is surgical resection and somatostatin analogs. These are a giveaway, right? So if you have these, you know it's gonna be from neural cell derived tumor. We'll do that in RESP. Most of them will do it in like their respective chapters, but here we're going to talk about neuroblastoma, and most common tumor of the adrenal medulla in children. That's what this is. It's usually less than 4 years old children. Originates from neurocrest cells, right? Neurocrest cells. Occurs anywhere along the sympathetic chain. Most common presentation is abdominal distension and a firm, irregular mass that can cross the midline. That's how you differentiate this with the Wilms tumor, because Wilms tumor does not cross the midline, whereas this one does. A neuroblastoma, right? Then you're less likely to develop hypertension than with pheochromocytoma. Neuroblastoma is normotensive. That's an important differentiating feature. It can also present with opsoclonus or myoclonus syndrome. They'll tell you this, that the parents notice the child, uh, moving the eyes like they're dancing, like their feet are. Right. So it's called dancing eyes and dancing feet. So neuroblastoma. Increase in HVA and VMA. These are the byproducts or waste products, so of catecholamine metabolites, right? So breakdown of catecholamines in urine. Homer right rosettes or neuroblasts surrounding a central area of neutrophils. That's these things that look like a cheetah print. Characteristic of neoblastoma and medulloblastoma. Bomacine and NSE or neuron specific analase. Right, neuron specific analase is positive, associated with amplification of N-mice oncogene. Okay, so neuroblastoma. Now we talk about pheochromocytoma. That's most common tumor. Pheochromocytoma etiology. So most common tumor of the adrenal medulla in adults, derived from chromaffin cells, arise from neurocrest, may be associated with germline mutations. For example, NF1, VHL, RET, MEN2A, and 2B. Rules of 10. So pheochromocytoma is 10% malignant, 10% bilateral, 10% extra-adrenal. For example, bladder wall organ of Zuckerland, 10% calcify, and 10% kids. Okay, it's associated with MEN2A, 2B, 1 hypolindo, and neurofibromatosis 1. Cool. So symptoms are most tumors secrete epinephrine, norepinephrine, and dopamine, which can cause episodic hypertension. May also secrete EPO, which causes polycythemia. Symptoms occur in spells, so relapse and remet. Okay. Episodic hyperadrenergic symptoms. These are pressure, increase in BP, pain, headache, um, perspiration, palpitation, pallor, right? It's going to be everything about sympathetic stuff, right? So, increase in pressure, you have pain, you have perspiration, you have palpitation, and pallor. You'll see these things. Then findings are increase in catecholamines and metapnephrine's. That's HVA and VMA in urine and plasma. That's what they were talking about here as well. VMA and HVA, right? So you see it in both of these things. This neuroblastoma and pheochromocytoma. Okay, in urine and plasma. So chromogranin, cimetophycine, and neuron-specific analase positive as well. So basically, just make sure if it's a child, the patient is less than 4 years old. Most of the time, it's going to be this. They might even tell you that it's palpable beyond the umbilical, umbilicus, right? Because if it doesn't, then it's usually Wilms tumor, right? And that's a kidney thing. Although this was adrenal medulla thing, right? And medulla makes catecholamines. Treatment is irreversible alpha antagonists. For example, phenoxybenzamine, that's the Batman one, followed by beta blockers prior to the tumor resection. Alpha blockade must be achieved before giving beta blockers to avoid a hypertensive crisis. Alpha blockade because of alpha 1, which is a vasoconstrictor, but you don't want to give a vasodilator blocker, right? Beta 2 blocker, because then you'll have unopposed alpha action, so vasoconstriction. So you need to block the vasoconstriction before you can block the vasodilators to avoid hypertensive crisis. So phenoxybenzamine for pheochromocytoma, that's how you remember that. Multiple endocrine neoplasia. So all men syndromes have autosomal dominant inheritance. The X-men are dominant, were villains. You have men 1 and men 2A and men 2B. The easiest way to remember this is that the first circle has 3 P's, second circle has 2 P's, and the last circle has 1 P. Okay, so men 1 is pituitary tumor. Right? It could be prolactin or growth hormone. So we have pituitary, we have pancreas. Pancreatic endocrine tumors are Zollinger-Ellison syndrome or insulinomas, VIPomas, or glucagonomas. Right, so it's rare. Parathyroid adenomas associated, right? So parathyroid adenomas there. So pit pan para or pituitary, pancreas, and parathyroid. Then with parathyroid, we have thyroid, and then what's left is pheochromocytoma is the third P or the fourth P, right? And then with just one P, that is pheochromocytoma, thyroid, and mucosal neuroma. So here, associated with mutation of MEN1 tumor suppressor codes for menin, chromosome 11, angiofibromas, cholangiomas, and meningiomas. The question for this is gonna come like there was a person who has a mother who suffered from pituitary, a sister who was suffering from pancreatic cancer, or had a brother who had like parathyroid dysfunction or something. So something like that, and then you have to figure out what other thing is this person at risk of, other than the ones that are been stated. So it could be, they give you two of these, and the third one you gotta figure it out. It could be MEN 2A, similar concept. Parathyroid hyperplasia, medullary thyroid carcinoma, neoplasm of parafollicular C cells, secretes calcitonin, and it stains with what did it stain with? Sorry, Congo red, right? So Congo red. Okay. Secretes calcitonin, prophylactic thyroidectomy required. Pheochromocytoma secretes catecholamines associated with mutations in red. Proto-oncogene codes for receptor tyrosine kinase and chromosome 10. MEN2B, medullary thyroid carcinoma, pheochromocytoma, and mucosal neuromas, oral intestine. Ganglioneuromatosis associated with marfanoid habitus. This is important because they'll give you this and you'll think of like marfans and all that stuff, but it's not marfan or homocystinuria or anything. It's this one. So mutations in red gene. MEN1 has 3 P's: pituitary, parathyroid, and pancreas. MEN2P has two thyroids. That's how I remember. The 2A is 2 thyroids, so parathyroid and thyroid, medullary thyroid. Okay, parathyroids and pheochromocytoma. Okay, and then the last one has 1 P, pheochromocytoma. We have pancreatic islet cell tumors, insulinoma, tumor of pancreatic beta cells, which lead to overproduction of insulin, also leads to hypoglycemia. Macy-Whipple triad, low blood glucose, symptoms of hypoglycemia, for example, lethargy, syncope, and diplopia, and resolution of symptoms after normalization of plasma glucose levels. Symptomatic patients have decreased blood glucose and increase in C-peptide levels versus exogenous insulin use. We already know that. Uh, so approximately 10% of cases associated with MEN1 syndrome. Treatment is surgical resection here. That's the important thing. If you have increase in that insulin, you check for C-peptide. If there's increase for that, it's insulinoma. If it's not, then it's exogenous insulin use. Okay. The Whipple's triad is low blood glucose, symptoms of hypoglycemia, for example, lethargy, syncope or diplopia, and resolution symptoms after normalization of plasma glucose levels. Sorry. Okay. Uh, Glucagonoma, tumor of pancreatic alpha cells, leads to overproduction of glucose. Presents with 6 Ds. So for dermatitis, diabetes, DVT, declining weight, depression, and diarrhea. Drink some water. Give me a second. Okay. Good enough. Okay. So for glucagonoma, you need to know that the tumor is about alpha cells, and it causes overproduction of glucagon. But most importantly, it has the 6 Ds, and they'll give you this. They'll start with diarrhea. Okay, this person has diarrhea, uh, has difficulty in breathing because of DVT embolism. It could be that, or pain in the calf, unilateral pain in the calves, one of the calves. They will give you a rash as well. So rash and diarrhea, there's not that many things that do that. Okay, so you should think of this, and especially if they tell you that there's a sign of DVT there. Right. Right. So and declining weight. Okay. Somatostatinoma. That's the one which statin so stops everything. Tumor of pancreatic delta cells. Overproduction of somatostatin leads to decrease in secretion of secretin, cholecytokinin, glucagon, insulin, gastrin, gastric inhibitory peptide. It may present with diabetes or glucose intolerance, steatorrhea, gallstone, or achlorhydria. Okay, so it decreases secretion of all of these things, so almost everything. May present with diabetes, glucose intolerance, steatorrhea. This is fatted stool, gallstone, because it doesn't have, it's not making bile, or cholesterol is not making it there either, or cholesterol is like just staying there and it's not moving on, or for any reason. So there are stones in there. Achlorhydria, that's no HCl is being released because it's inhibited by this. So treatment is surgical resection or somatostatin analogs like octreotide for symptom controls. Okay. Then you have carcinoid tumors. Okay. That's what that looks like. Carcinoid tumors arise from neuroendocrine cells, most commonly in the intestine or lungs. Okay. In the lungs, it causes wheezing. In the intestine, it causes flushing. Neuroendocrine cells secrete 5-HT, which undergoes hepatic first pass metabolism, right? And this is why you won't notice it until it's too late, because if it's in the colon, where does the blood supply go? It goes to the liver, right? So the liver is gonna metabolize 5-HT, right? the histamine, which undergoes hepatic first pass metabolism and enzymatic breakdown. So enzymatic breakdown happens there by MAO or MAO, monoamine oxidase, in the lung, not in the liver, in the lung. Okay. If IHT reaches the systemic circulation, that is after the liver metastasis. So if you find it anywhere after liver, chances are it's already been invaded the system. So carcinoid tumor may present with carcinoid syndrome. This is episodic flushing, diarrhea, wheezing, right-sided valvular heart disease, for example, tricuspid regurgitation or pulmonic stenosis, and then niacin deficiency or pellagra, and there's increased urinary 5-HIAA. Okay. Histology: prominent rosette, arrow in A, this thing. There's chromogranin A positive or synaptophysin positive. Right. So it could be carcinoid. It's also positive in this, right? And it's also positive in this. So surgical resection is the treatment, or somatostatin analog like octreotide or tryptophan hydroxylase inhibitor, telotristat, for symptom control. Rule of thirds. So 1/3 of the time it metastasizes, 1/3 of it is present with second malignancy, and 1/3 are multiple. Zollinger-Ellison syndrome, gastrin secreting tumor, gastrinoma of duodenum or pancreas. We'll do this in GIT as well. So gastrin secreting tumor or gastrinoma of duodenum or pancreas. Acid hypersecretion causes recurrent ulcers in duodenum and jejunum. Presents with abdominal pain, peptic ulcer disease, distal ulcers, diarrhea, and which is because of malabsorption. Positive secretin simulation test. Increase in gastrin levels after administration of secretin, which normally inhibits gastrin release, may be associated with MED1. Okay, why? Because this is pancreas, and pancreas was part of MED1, so it could be part of that. But this one, it's known to cause duodenal ulcers because of high levels of gastrin in the duodenum, and normally in duodenum they get neutralized. The HCl gets neutralized there, but if there's high levels, it can't neutralize all of it, so that's why you end up with recurrent ulcers in duodenum and jejunum. Okay. We're on to pharmac. Yeah, 1, 2, 3.5 page to go. Let's come back. Diabetes mellitus therapy. All patients with diabetes mellitus should receive education on diet, exercise, blood glucose monitoring, and complication management. Treatment differs based on the types of diabetes and glycemic control. Type 1 diabetes mellitus, this is insulin replacement, right? Because your body doesn't make insulin. So type 2 diabetes mellitus, oral agents, metformin is first line. Non-insulin injectables, insulin replacement. Weight loss particularly helpful in lowering blood glucose. Then you have gestational diabetes mellitus, that's insulin replacement if nutrition, therapy, and exercise alone fails. Regular short-acting insulin is preferred for DKA, IV, and hyperkalemia plus glucose, okay, and stress hyperglycemia. So for DKA, DKA is treated with initially rapid IV infusion of regular insulin. That's this blue line right here, up to the 10 hours. Right, so it allows for adjustment based on the blood glucose. IV half-life is 5 minutes, and then subcutaneous half-life is, it starts in 30 minutes, peaks for 2 to 4, and lasts 5 to 8 hours. Okay. So these drugs help to normalize pancreatic functions. Okay. Uh, so we'll look at this while we're doing these, but overview is biguanides or thiazolidinone, dinidiones, that these increase insulin sensitivity, so they don't really, they're not insulin analogs, they just increase the sensitivity, so adipose tissue and skeletal muscles. Okay. Then also decrease glucose production in the liver. You have SGLT2 inhibitors. They decrease the glucose reabsorption in the kidneys. Then you have alpha glucosidase inhibitors. That's decreasing glucose absorption or intestine. We have GLP dash 1 analog and DPP4 inhibitors and amylin analogs. Decreasing glucagon release, pancreas alpha cells, and decreasing gastric emptying stomach. And sulfonylurease, meglitide, GLP-1 analogs, and DPP-4 inhibitors. They increase insulin secretion in pancreas beta cells, right? We'll go over all this, and they're like tips and tricks from Dirty Medicine that I use. So again, Dirty Medicine is, I'll show you which one the video is. This video right here, it's a pretty good one. Right, 30 minutes, but he goes over all of them and he gives you tips on how to remember it. So, okay, so insulin preparation, so drug class, mechanism, and adverse effects. We have rapid acting, that's 1 hour peak, so there's no lag in its action, right? So lag L for Lispro, A for Aspart, and G for glulisine. Okay. Glulisine is different from glargine, so don't mix that up. This is glulisine up here. Okay, and then you have short acting. Okay, these ones you use as IV. You administer it as IV. Okay. Short is regular and short. That's how you remember that one. So rapid insulin has no lag. And then for this second one is just regular and short. Short and regular, or we can just remember that one. Okay, short and regular. So this has a 2 to 3 hour peak, right? And then you have intermediate acting. So for that, intermediate acting is not particularly hasty. So that's how I remember that one. NP and H. So NPH. Okay, not particularly hasty, intermediate acting. So that's 4 to 10 hour peak. And then you have long acting. Right. So long time. Like GN is for glargine and D is for detamere. Human insulin is mimicked by glargine and rapid acting. Okay. So mechanism for all these insulin preparations is that it binds insulin receptor, tyrosine kinase activity. You have liver, increase glucose storage as glycogen, and muscle increase glycogen and protein synthesis. Fat will increase triglyceride storage, and cell membrane will increase potassium uptake. The adverse effect you have is hypoglycemia, lipodystrophy, hypersensitivity reaction, rare, but it happens, and then also weight gain. So you would be given this kind of chart and then none of the names, and then you have to figure out which one is which. So the first one is always the, no lag in the peak. So that's lisproaspartate and glulisine. And then comes the, short and regular. The second short is peak. Right? This occurs in 10 hours, so regular. And then you have intermediate acting, which is not particularly hasty, so NPH. That's the intermediate one. It's the third one that ends, and then peaks also at third. And then you have ones with no peak. The goddamn 24 hours is long time. Detamere and glargine. Okay. So glargine, it goes over 24 hours, right? Detamere also is pretty long, but you can see it end over here somewhere, but not for glargine. So these are long acting, remember that, and remember the names. For biguanide, let's bring this photo here. Okay. For this, so biguanide has metformin and thiazolidinedines, right? The glidas. So for metformin, you need to remember this one for its adverse effect. Met for, let's do that one in green. Metabolic acidosis. Gotta remember that one. That's the important side effect for metformin. So it inhibits mitochondrial glycerol 3-phosphate dehydrogenase (MGPD), which leads to inhibition of hepatic gluconeogenesis and the action of glucagon. There is an increase in glycolysis, peripheral glucose uptake, so increase in insulin sensitivity. Okay, so it stops hepatic gluconeogenesis and the action of glucagon, which is to make more in the liver, right? So when you stop this, what happens in the arms? You have, breakdown of this, so it uses up more glucose, so then there's more glucose uptake because of it. Okay, none of this is important. What is important is the side effect for metformin. So that's GI upset. You have lactic acidosis. Use with caution and renal insufficiency, right? Because it causes that. And to get over lactic acidosis or any kind of acidosis, you need proper renal function, right? Because it absorbs bicarbonate and gets rid of the H. And then you have vitamin B12 deficiency also happening because of this. Cobalamin, right? And weight loss often desired because of this. Okay, then we have thiazolidinedines. Okay, for this one it was remember PPR gamma. I just read that as party. So for that, the mnemonic is bring glitter, but instead of glitter we say glitter to the party, right? But and the party is PPR gamma, right? So bring glitter to the party, or activates party, or PPRY, or gamma, sorry, a nuclear receptor which increases insulin sensitivity and levels of adiponectin. It leads to regulation of glucose metabolism and fatty acid storage. Okay, the way you remember the side effects for these is that Rosie at the party, she was dancing and she fell over and broke a leg. So it increases risk of fracture. Also, she had heart problems because she was dancing so much at the party, right? So increases risk of MI or cardiovascular death. Okay. There's a delayed onset of action, several weeks. There's a weight gain, edema, heart failure, and increased risk of fracture. Important to remember the side effect for this one as well. But also remember the mechanism of action for this, for the glitter. So it activates PPAR gamma. So just remember glitazone. So glita is in pioglita and rosiglitazone, right? So glita. That's how you figure out that it's the one with the party. You bring glita to the party. So PPRY or gamma. Okay. And while they were dancing, one person was feeling, like a heart attack was coming, or they fell and they had a fracture. So there's an increased risk of fracture at the party. Okay. For increased insulin secretion, you remember IDE, right? And IDE for sulfonylurease, first and second. Okay, and also for meglitinide as well. There's IDE in there as well, and he had us memorize that it was like dirty. He said that there's like this guy who was on ad on American TV, but that one didn't really work for me, so I just changed it a little. So instead of his, I just say I'd remember this, right? So I'd remember to take my diabetes drugs. Okay. Okay, so when you have IDE, you remember that it's the one with the diabetes drug, and OK is so that you remember that it's the one with the K channels. So all of these, they work the same. Okay. They have IDE at the end, right? Meglitinide, sulfonylurease, which have IDEs as well. You just need to remember these ones are sulfonylurease, and naclinide and ripaglinide are for meglitinide. They are under that, so you remember that way. But other than that, you just remember this mnemonic. So I'd remember to take my diabetes drugs. Okay. So K is for potassium channels. So these drugs close the potassium channels in pancreatic B cells, B cell membrane. So if there's no potassium coming in, remember the third or fourth step was ATP closes the potassium channel, so that causes depolarization. Let me go bring that down here. Right here. So this step right here. Right, so you have glycolysis to produce ATP. ATP comes and attaches to potassium, and then potassium closes, which causes depolarization. Right. So closes potassium channel in pancreatic B cell membrane, and cell that causes cell depolarization, which causes insulin release via the calcium influx. So calcium comes in, attaches to the receptors, and causes exocytosis of insulin granules. And that's how the mechanism works with this one. There's a disulfiram-like reaction with first generation sulfonyl urease only, so it's rarely used as well. But that's an important side effect for this. Okay, and hypoglycemia can happen. That's going to be with everyone most of the time. There's increased risk in renal insufficiency and weight gain. Okay. Then we have GLP-1 analogs and DPP-4 inhibitors. For this, you need to know what the mechanism looks like. So let's see. Actually, let's see if I can just open up the video without sound. Oh, wait, this thing right here. Right. And yeah, let's see if it makes sense now. Okay, so we have GLP-1 or glucagon like peptide 1. Okay, and we have in what it does, it like stimulates the insulin release, and it inhibits the glucagon release. Okay, so when you eat food, it releases glucagon like peptide, right? And yeah, so insulin release or glucagon inhibits or decreases glucagon release. So then you have DPP-4 right here, right? So that's dipeptidyl peptidase 4. What does that do? It inhibits glucagon like peptide 1. Okay, so it inhibits this, and then you have GLP-1 analogs which actually stimulate this or activate this. Okay, so what we do with GPP-4 inhibitor is that it comes in and it inhibits this, so this no longer can inhibit this. So with this gets disinhibited from DPP-4. Okay, so that's how that mechanism works. And actually, wait, see if he has that. Okay, right. So okay, so like I said, GLP-1 agonist activates this, and this one inhibits this. Okay, so to prevent inhibition of this, we have DPP-4 inhibitors, which are linagliptin and sexagliptin or sitagliptin, and then you also have GLP-1 analogs, because they're agonists, because we want more of this, right? So because we want the uptake of blood and sugar from the blood. We want blood to have low levels of sugar, so insulin does that. So GLP-1 analogs are exenatide, liraglutide, and semaglutide, right? So how does it work? It decreases glucagon release and decreases gastric emptying. increases glucagon dependent insulin release. Okay, just remember this, and then you remember that. So the mnemonic for this is, uh, remember how there was a time when people were swallowing Tide Pods, right? They were just gulping it down. So gulp one Tide Pod, right? So with that, you remember, okay, so gulp one was all were the ones with the Tide in it, okay? And then you remember gulp is GLP-1, and GLP does what? It activates GLP-1 or glucagon like peptide, and its action is what you desire, which is insulin release and glucagon release. Not you desire, but what you would want in a diabetic. Unless you're a diabetic, then yeah, you could desire this. So nausea, vomiting, pancreatitis, weight loss often desired, and increase in satiety, which is also often desired. Okay, for this one, it was, the mnemonic was Lipton tea makes you PP 4 more times. Okay. So with the Lipton in it, you remember Lipton tea, right? That's it's Lipton, but okay. So that's Lipton tea, or just Lipton tea for us. You have Lipton tea, so which makes you PP 4 more times. So that's how you remember the ones with the Lipton are DPP4 inhibitors. Okay, they function by inhibiting DPP4 enzyme. That's this thing. Its initial function is to inhibit this, right? So we inhibit this, so this does not get inhibited. So inhibit DPP4 enzyme that deactivates GLP-1, which leads to decrease in glucagon release and decrease in gastric emptying. You have increase in glucose-dependent insulin release then. Side effects are respiratory and urinary infections. This is important. Lipton can cause urinary infections. Okay. Weight can stay neutral. Okay. Then you have sodium glucose co-transporter 2, the famous one, and the easiest one to remember. It has flozin in it. Okay. For that, I think he has a diagram for this too. So that's the SGLT2 inhibitor, carbkenaflozin and dapagliflozin and epagliflozin. So you have glucose flowing through it, right? So what this one does is it blocks the reabsorption of glucose in the proximal convolute tubule. Okay. So what does that mean? It means it's flows in through the proximal convoluted tubule. It's flowing through the proximal convoluted tubule, right? That's where its action is. Okay, so it blocks reabsorption of glucose in proximal convoluted tubule. That's the mnemonic, flowing through the PCT. So anything that has flozin in it, that's going to be your sodium glucose co-transporter 2 inhibitors. Okay, flozin through PCT. The side effects are glucosuria, UTIs, vulvovaginal candidiasis, because you have a lot of sugar in your kidneys now, right? And sugar is used by fungus and bacteria for growth. So you'll have UTIs, vulvovaginal candidiasis, dehydration, orthostatic hypotension, weight loss. Use with caution and renal insufficiency. Okay, because it's important to be careful here. If there's decreased efficacy with decrease in GFR. Okay, alpha glycoside inhibitor or acarbose and meglitol. So let's ignore that. Just look at this, right? So what does that mean? Acarb is without a carb, right? That's what it means. So alpha glucosidase inhibitor. It inhibits intestinal brush border alpha glucosidase. So there's a delayed carbohydrate hydrolysis and glucose absorption. So you're without carb for a long time, right? So it delays carbohydrate hydrolysis because glucose, breakdown of carb makes glucose, and also glucose does not get absorbed as fast. So acarbose works on the intestine at the brush border on the alpha glucosidase. Okay, it's an alpha glucosidase inhibitor. Okay, meglitol, nothing for that, but they usually ask you about acarbose anyways. So you can imagine what would happen. So is GI upset or bloating? It's not recommended again in renal insufficiency. And then you have amylin analogs. Amylin is saying I am working alongside insulin. Okay, so that's how I remember that one. M working alongside insulin. Okay, or amylin. That's how you just remember that. Don't confuse this tide with the gulp Tide Pod. Okay, this is the one with amylin. That's what you focus on. You don't focus on the tide because that's for GLP-1. Decrease in glucagon release and decrease in gastric emptying. Okay, that's just what you would want anyways. So you don't spike up your glucose. Then hypoglycemia and nausea and increase in satiety are the side effects. Okay. So that basically takes care of that. I can draw you a diagram for alpha glucosidase inhibitor. So you have oligosaccharides right here coming in, and then you have, acarbose coming in from here, outside, and breaking this down into sugars or glucose, right? Sorry, not acarbose. You have alpha glucosidase. Over here coming in and converting this into oligosaccharide into sugar, and then this is why we have acarbose coming in and inhibiting this. So this doesn't work, so this doesn't happen, and if this doesn't happen, you don't have glucose, and if you don't have glucose, this is just gonna go and get excreted out. Okay. So that we're done with diabetic drugs. Just to wrap up, metformin, remember the side effect, metabolic acidosis. For this one, pioglitazone and rosiglitazone, remember to bring glitter to the party for PPAR gamma. Okay, and they were dancing so hard that they fell and had a fracture, so there's increased risk of fracture. And they were partying so hard that they had like mild heart problems. So that for sulfonylureas and meglitinides, you remember the Ides, and it's like, yeah, I'd remember to take my diabetic drugs. Okay, K for closing of K channels causes cell depolarization, causing calcium influx, causing uh, release of insulin vesicles. Right? For this, remember the diagram. Gulp 1 causes, so it, you gulp one Tide Pod, right? From the opening down the swallowing the Tide Pods. So GLP-1 Tide Pods. So anything with the Tide in it is going to be GLP-1. What do? They increase or activate glucagon like peptide, and it decreases glucagon release and increases insulin release. Similarly, this one inhibits, right, DPP4. It inhibits GLP-1. So we have an inhibitor for this inhibitor, so it can get disinhibited, right? So the ones with the leptin, you remember that with leptin T makes you PP4 more times. So anything that has leptin in it, you remember that's its DPP4, and that inhibits the inhibitor. So then again, same mechanism there. For this one, it flows through the PCT. We looked at that, right? So glucose goes straight through it. This is the one that has the highest UTI causing. This is the UTI causing diabetic drug, right? And it flows straight through the PCT. Acarbose, that's without a carb, right? It does let this get converted, so this goes straight down. And the intestinal, it acts on the intestinal brush border of alpha glucosidase. So it acts only on the alpha glucosidase that are on the intestinal brush border, and it inhibits them. Okay, and then I am working with alongside with insulin, so amylin. Okay, so it acts just like an insulin, decreases glucagon release, decreases gastric emptying, hypoglycemia, nausea, and all that. Okay. Thianamides, this is PTU and methimazole. Remember that from the diagram? Let me bring that back. Okay, so PTU, methimazole, mechanism is it blocks thyroid peroxidase. Okay, so oxidation doesn't happen, organification doesn't happen, coupling reaction doesn't happen. Blocks thyroid peroxidase, inhibits the oxidation of iodide as well as the organification of coupling of the iodine, and this causes inhibition of the thyroid hormone synthesis. The PTU also blocks 5-deiodinase, right, and as well. There's a decrease in peripheral conversion of T4 to T3. Clinical use is hyperthyroidism. PTU used in primary first trimester of pregnancy due to methimazole or teratogenicity. Methimazole used in second and third trimesters of pregnancy due to risk of PTU-induced hepatotoxicity. Not used to treat Graves' ophthalmopathy is because that one is treated with glucocorticoids. Why? Because we know the mechanism of exophthalmos, right? And that's treated with glucocorticoids. Adverse effect is skin rash, agranulocytosis, aplastic anemia, hepatotoxicity. PTU has been associated with ANCA-positive vasculitis. Methimazole is possible teratogen. It can cause aplasia cutis. This is the important one. So levothyroxine and leothyronin. Okay, so mechanism, hormonal replacement for T4, which is levothyroxine, and or T3, leothyronin. Clinical use is obviously hypothyroidism or myxedema. Maybe misused for weight loss. So there's a question about a mother coming with daughter, concerned about her because she's feeling hot, like heat tolerance is happening and all that. So you do a thyroid function test. You find out that she has decrease in TSH, but increase in T3 and T4, and you know the mother has a history of thyroid as well. So chances are this teen is taking her mother's medication for weight loss. Okay. Distinguish exogenous hyperthyroidism from endogenous hyperthyroidism by using a combination of TSH receptor antibodies, radioactive iodine uptake, and or measurement of thyroid blood flow on ultrasound. Adverse effect is tachycardia, heat tolerance, tremors, and arrhythmias. Then we have hypothalamic or pituitary drugs. Drug clinical use. So we have convactin or tolvactin. Uh, Vactin sounds like captain, and captain offers ship, and ship is always on water, and you need water uh, in the ocean body or body. Uh, ADH is involved for that. So conivactin and tolvactin, these are ADH blockers, and CIAD. So you use it for CIAD as well. It blocks action of ADH at V2 receptors, the ones in your kidneys. Then we have demiclocycline. This is also ADH antagonist, a tetracycline. CIAD interferes with ADH signaling as well. We have desmopressin. We use it for ADH analog purposes, central diabetes insipidus as well. 1 milligram disease. Why? Because it has a V1 effect, and that's how you release 1 milligram from the endothelial cells of the vessels. We use it in sleep enuresis and hemophilia A. They recently, cured hemophilia B. Just a side note. Growth hormone deficiency, and Turner syndrome. Oxytocin, induction of labor, stimulates uterine contractions, control uterine hemorrhage, and then you have somatostatin octreotide. You use it to treat acromegaly, carcinoid syndrome, carcinoma, glucagonoma, and esophageal varices. Okay. We have fludrocortisone. This is a synthetic analog of aldosterone with glucocorticoid effects. Okay, so aldosterone does what? It drains water, right? So there's fluid in the name, or fludrocortisone retains fluid. So clinical use, it's a mineralocorticoid replacement in primary adrenal insufficiency. Adverse effects similar to glucocorticoids, also edema, exacerbation of heart failure, and hyperpigmentation. Cool. We have cinacalcet. Mechanism is sensitizes calcium sensing receptors, right, in parathyroid gland to circulating calcium. So this will decrease your PTH. Okay, pronounce sensacalcium. So that's how you pronounce that, to remember that it increases sensitivity of the calcium in parathyroid hormone. So clinical use is secondary hyperparathyroidism in patients with chronic CKD receiving hemodialysis, hypercalcemia and primary hyperparathyroidism if parathyroidectomy fails, or in parathyroid carcinoma. Adverse effect is hypocalcemia. Okay. Remember the mechanism of action for this one, if that's what they test you on. Remember the mechanism of action for this as well. This is sevelamer. It's a non-absorbable phosphate binder that prevents phosphate absorption from GI tract. Okay. Then you have clinical use, hyperphosphatemia and CKD, and adverse effects, right? Hypophosphatemia, GI upset. Okay, that's what it causes. This one is important. They do test you on this, and then you have, they test you on the mechanism of it. So, and then you have cation exchange resins. These are your periromer, sodium polystyrene sulfonate, zirconium cyclosilicate. Okay, these are also, they bind potassium and coal in exchange for other cations, for example sodium or calcium, and that leads to potassium excreted in the feces. Uh, they test you on this one, Petiromer. It has a similar action as Sevlomer, and they both have murmur in it, so maybe you can remember it that way. Uh, Clinical use, hyperkalemia. Sorry, this is potassium, but this is phosphate, but they have similar ones, and they have murmur in it. So don't mix up that. This one is for phosphate, and Petiromer is for potassium. So clinical use, hyperkalemia, and adverse effects are hypokalemia and GI upset.